Good.
And we've had a great problem with lack of information around, we've had a great problem with lack of information about who's at risk. We've had great problems with lack of information to inform clinical decision making. Much of the early work on who's at risk of developing adverse COVID outcomes came from this major platform, from the Open Safely platform, and demonstrated that people were at increased risk. But there were increased risks with age, sex, obesity, ethnicity, and deprivation. What was interesting for us as dermatologists was the finding that people with rheumatoid arthritis, lupus, and psoriasis had an increased risk. And from a clinical perspective, the immediate question I asked myself is, well, which one of those conditions is driving that association, and is it related to the drugs that we use to treat that condition? And is it related to the drugs that we use to treat that condition? Good morning. Good morning. This research aims to answer research questions that we as clinicians have come up against in the last 2 years. The last 2 years have been like no other. 6.3 million people dead globally related to coronavirus, and many challenging decisions to make clinically without information. Some of the early information told us a bit about who was at increased risk: the people who are older, who had male sex, who were obese, different ethnicities, and ethnicity and deprivation. But one of the factors that for us as dermatologists stood out was this increased risk that we saw in people with rheumatoid arthritis, lupus, and psoriasis. And immediately as a dermatologist, I want to know which of those conditions is driving that increased risk, and is it related to the condition, or is it related to the drugs that we use to treat that condition? So the types of questions that we get from patients are: does having an inflammatory skin disease increase my risk of adverse outcomes? Should I stop my immune-modifying treatment for skin disease because I'm worried about coronavirus? And these questions are really similar, not just in skin clinics, but also in bowel and joint clinics. And to address this question, we did this major piece of work, which is published now in Lancet Rheumatology. And this is one of the biggest authorship lists in any paper that I've ever been involved in. And the reason for this is that this has been a huge team effort. So the initial technical large-scale national data platform was led by Ben Goldegger and Liam Smith. But to do this type of work that requires genuine team science from computer programmers, statisticians, epidemiologists. And to do this particular piece of work, we brought together a group of clinicians across different immune-mediated inflammatory diseases. So from rheumatology, James Galloway; dermatology, myself and Catherine Smith; gastroenterology, we see someone very familiar looking, Nick Kennedy from Exeter, and Charlie Lees from Edinburgh. And the immune-mediated inflammatory diseases that we focused on were joint diseases, including rheumatoid arthritis; skin diseases, psoriasis, hidradenitis suppurativa; and bowel diseases, Crohn's and ulcerative colitis. Good morning. So I'm going to talk you through how we designed our study. So it started on the 1st of March 2020, and we identified adults who'd been registered with their GPs for a year. We looked back in the previous 3 years to see who had an immune-mediated inflammatory disease, and then we looked back in the previous 6 months to see who'd been treated with immune-modifying therapy. We looked back the previous year to see who'd been treated with rituximab because of the longer half-life of that medicine. We then looked in the previous year to see who had conditions that might increase their risks of adverse COVID outcomes, and then we followed people forward until September 2020, or when they developed the outcome of interest. So here's our study population, and the immediate thing you'll see is that it's huge. So we had 17 million people in our study and 1.1 million people who had an immune-mediated inflammatory disease, with the majority of those having skin disease. You can see that the people with the joint disease were a bit older, and those with skin and bowel disease. We also demonstrated that people with the immune-mediated inflammatory disease had more diabetes, more cardiovascular disease, stroke, and they had more prescriptions for oral steroids in the previous 3 months. Now, I'm going to talk you through this complicated diagram. It's a conceptual framework. It's the type of diagram I draw when I'm trying to answer this type of question. So the question here is, does immune-mediated inflammatory disease increase the risk of dying or being admitted to intensive care unit with coronavirus? And in the pink blobs are factors that are confounders. So they'll mix up this association between the IMID and dying from COVID, and we must adjust for them. The factors shown in blue are mediators, potential mediators. So, for example, having an IMID makes you more likely to have steroids, which may increase your risk of dying from coronavirus. And if we want to answer the question how much of that increased risk is driven by the IMID itself, we might want to consider a model where we adjust for mediators. And on the left-hand side, you can see the forest plot, which summarizes our main results, but I'm going to focus in on one of the specific outcomes, which is admission to ICU or dying. And what we can see here is that people with immune-mediated inflammatory diseases were more likely to die or be admitted to intensive care unit. That risk was higher for people with joint disease than skin or bowel disease. And going back to that, you can see the green are minimally adjusted just for age, sex, and practice. The red are adjusted for those confounders, and the purple are adjusted for the mediators. Now, this may not look like the most exciting table in the world, but what if I told you that I've been trying to get these data for 10 years? I've been lobbying to try and get information on high-cost drugs linked to GP data for 10 years to be able to answer critical questions. So for me, this is one of the most exciting slides in the talk. And for the first time, we have an impression nationally of who is treated with standard systemic drugs, who's treated with targeted immune-modifying therapy. So we have 181,000 people treated with standard systemics, 19,000 with targeted immune therapy. Hello, how are you?
I'll let you finish your
I know, I'm terrible. I always do this.
I always like to see the room.
I do too. I always like to stand up.
Yeah.
Play with the gadgets, make sure it works.
This one's all right.
Yeah. It's not too intimidating. Yes, exactly. Yeah.
Well done.
Thank you.
Yeah.
Thank you. With the majority being treated with TNF inhibitors and smaller numbers being treated with other targeted medicines. So here the directed acyclic graph is a bit more complicated, and what we're focusing on here is targeted immune-modifying drugs for IMIDs versus standard systemics, and severe COVID outcomes, again, death or ICU admission. Here you can see that there's a lot more confounders in the pink and some critical mediators, including oral corticosteroids. So what do we find? Well, here we're looking at the risks of COVID, ICU admission or death, and what you can see is that for people with targeted compared to standard systemic therapy, there was no increased risk. For TNF inhibitors, it looks slightly protective, but for rituximab, we do see a suggestion that those people had an increased risk of dying or being admitted to the intensive care unit, but it is based on a relatively small number of events. The key findings are 23% increased risk of dying from COVID if you have IMIDs, the highest risk in those with inflammatory joint disease, but this is before the introduction of vaccines and antivirals. We saw no increased risk in people in target versus standard systemics, no increased risk, but we do see an increased risk with rituximab, which is attenuated after excluding cancer. So this is a huge platform, teamwork, moving beyond silos, it's population-based, key information on critical things, and we do have some missing data in terms of ethnicity and some other key factors. In terms of some of the specific medicines, the events were infrequent, so we can't directly answer those.
The last 3 years, as you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Hello, I'm Pew Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population, and that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free Rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist, a Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together
to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Royal Free in London. To me, diversity is about recognising everyone's different and the value those differences bring.
From London. Diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name is Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Hello, I'm Pew Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane, and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months, and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Welcome everybody to this morning session. It's a combined BAD, British Society of Medical Dermatology session. We've got quite a packed schedule, so we'd be really appreciative if our speakers could stick to time. We welcome questions. If when you ask questions you speak right up to the microphone, that would be very helpful. Thank you very much indeed. So, Laura, would you like to introduce our first speaker, please?
Absolutely, shall. So thank you very much, Jane. So I'd like to invite Professor Andrew Thompson to come and present for us on vitiligo diagnosis, how it's associated with an increase in new onset depression and anxiety in a population-based cohort study in the UK. Unfortunately, Professor Andrew Thompson couldn't join us today, so this is a pre-recorded session, but he will join us virtually for a Q&A afterwards, so please do come and line up for your questions.
Good morning. Thanks for joining us for this early session focused on determining the risk and impact of psychological comorbidity in people with new onset vitiligo. I'm Andrew Thompson, a Professor of Clinical Psychology based in Cardiff, and my co-authors are Victoria Alefadu, Consultant Dermatologist, and John Nesnas, who works for Pfizer. Here are our declarations. And it's important to note that the study was funded by Pfizer, and we also had support from Momentum Data to assist with the statistical analysis. And I'd like to acknowledge the work of Anita Lynham and Charlotte Curtis in doing that with us. So, vitiligo, of course, is an acquired autoimmune depigmenting skin disorder. It affects between 0.5 to 2% of the global population. And society places a profound significance on appearance, and perhaps unsurprisingly, if disappointingly, this condition is well known to be associated with stigmatisation. It's also well known to be associated with higher levels of psychological distress. However, there are some issues with the existing data. For example, recent systematic reviews suggest that the studies that have been conducted have had small sample size, high heterogeneity, and most of the sample have been drawn from secondary care, and of course most people living with vitiligo receive their treatment in the community and don't necessarily see a dermatologist. Recent observational study in the UK investigating the burden of major depressive disorder in vitiligo noted a bidirectional relationship between depression and vitiligo. However, the study didn't explore the associations of other mental health conditions or adjust for ethnicity. There is another recent large population-based study which found people of Asian ethnicity and vitiligo had nearly a threefold increased risk of developing psychological distress, but that study only looked at that ethnic group. So therefore in this study we sought to determine the risk and impact of specific psychological comorbidities in people with new onset vitiligo, and we also sought to stratify risk by age, sex, ethnicity, and we wanted to also look at the impact in terms of impact on work and healthcare utilisation. So to do this, we conducted a retrospective observational study using a UK general practice data set, the OPCRD, and this has records of around 10 million people. The protocol for this project was approved by the OPCRD Approvals Committee, and that happened in June last year. So all eligible adults in the data set between 2004 and the end of 2020 were eligible for inclusion, and we identified all people diagnosed with new onset vitiligo over the study period using recognised codes, and we excluded people where there were codes for other depigmenting disorder within 6 months of the vitiligo diagnosis. Each person with vitiligo was also matched at their index date with up to 4 unaffected controls from the same practice. We identified 3 common mental health outcomes: recurrent depressive disorder, depressive episodes and anxiety disorder, and we used recognised algorithms to do that, which not only looked at codes but also looked at evidence for people receiving treatment for the depression and the anxiety. We also looked at secondary mental health outcomes, and there's a list there for you to see, and again we used codes to do that. Measures of healthcare utilisation comprise primary care encounters and referrals on to dermatology, and we looked at the issuing of Med3 certificates and the notes of unemployment and incapacity within the records to look at impacts on work. We also extracted clinical information and demographic information which we used as covariates. So the prevalence of the 3 common mental health conditions and secondary outcomes was estimated at index date for cases and matched controls. And for recurrent depressive and depressive episodes and anxiety, we also examined prevalence in subgroups defined by 2 age categories, so 18 to 49 and 50 plus. We looked at it in gender, male and female, and we looked at it in 2 ethnic categories, black and non-black. Incidence of all primary and secondary new onset mental health conditions was assessed prospectively from the index date. The relative risk of developing each mental health condition in vitiligo cases versus controls was examined using Cox proportional hazards models and stratified by the matched set to provide hazard ratios as summary estimates for the association of the presence of vitiligo with the time to each mental health condition. And we looked at this in an unadjusted fashion, we looked at it in an age and sex adjusted fashion, and in a fully adjusted fashion, taking into account all of the variables that we'd extracted from the data set. So let's look at our results. Just over 7,000 people were identified as having diagnosis of vitiligo during the study window, and these were matched against just under 29,000 controls. The mean age of our people with vitiligo were 44 years, and just over half were women. And the cases were very well matched, with a slight exception that the controls had higher rates of smoking. So, looking at prevalence, prior to the vitiligo diagnosis, prevalence of pre-existing depression in cases was similar to controls. And whilst there was a slightly higher prevalence of anxiety in cases, which was significant, the differences in prevalence of mental health conditions between cases and controls were consistent with the overall findings in all subgroups as stratified by sex, age and ethnicity. And in both cases and controls, males compared to females and those of non-white ethnicity were less likely to have pre-existing depression and anxiety. The prevalence of adjustment disorder, substance misuse, suicidality and the other variables that psychological outcome variables that we were interested in, there was no difference. And interesting for social phobia, the data was so limited in terms of its size that we weren't able to do any form of analysis. Over the 2 years of follow-up, incidents of recurrent depressive disorder and anxiety disorder were more common in people with vitiligo, and there's adjusted hazard ratios there of 1.25 and 1.23 respectively, and I'll translate those into percentages in a moment. The risk was highest in those of non-white ethnicity, and again you can see the hazard ratios there, adjusted hazard ratios there of 1.72 and 1.56. And there was no association was found for the other mental health conditions, as I sort of alluded to earlier. So people with vitiligo and psychological comorbidities compared to those without had more primary care encounters, more time off work, higher levels of unemployment, but not increased dermatology referrals. And these findings held up to robust sensitivity analyses that were conducted by the team. People with vitiligo have a higher incidence of recurrent depressive disorder and anxiety disorder than controls, and the risk increase may be greatest in those of non-white ethnicity. So this is our key finding, our key discussion point. People with both vitiligo and a mental health comorbidity have increased use of primary care services, and people with both vitiligo and mental health comorbidity are twice as likely to have recorded time off work and high levels of unemployment. So this is really significant findings about the impact of vitiligo. There's a number of limitations with our studies. Of course, we weren't able to assess the extent or location of the vitiligo, and of course there could have been any other number of variables that weren't in the data set that might have contributed to our findings. But we do have some considerable strengths in this study, in that it's very large, representative and matched cohort study, and with very robust analyses, and we adjusted for multiple potential confounders. So to conclude, vitiligo is associated with an approximately 25% increase in risk of new onset depression and anxiety within 2 years following diagnosis. And given the findings on healthcare utilisation I mentioned a moment ago, the time off work and unemployment, we should evaluate the potential benefits now of screening distress in people with vitiligo, so as to identify people who might benefit from early psychological intervention, and so that we can provide true holistic care. Thank you for listening.
So, thank you very much to Professor Thompson for that really insightful presentation, and hopefully he's going to be there. Oh, look, by the power of media, there we go. Welcome. Thank you for joining us from Cardiff. Any questions from the audience? Okay, we've got one down at microphone 1.
Morning. Good morning, Andrew. It's Howell Williams, Nottingham here. Thanks for that study. And I was just trying to work out what Pfizer's interest was, but I'm presuming it's because of showing more justification for their launch of topical ruxolitinib. Which is fine, because it's important to look at these psychological consequences. So my question to you, Andrew, is to do with, I mean, the hazard ratios weren't huge, and it's a pity that ethnicity is just crudely broken into white and non-white, because I would have anticipated a gradient with increasing skin colour. So my question to you, this shows the frequency of psychological manifestations with new onset vitiligo. How does this compare with new onset other diseases? To put it in context, so psoriasis, for example, or new onset lichen planus, it's all about vitiligo compared with normal population at the moment. Have you any data on how these hazard ratios compare with other inflammatory new onset diseases, please?
Obviously, thanks for that question. I mean, I think you're right about the motivation of Pfizer here, and obviously our motivation is to identify people that might benefit from early screening for psychological treatment and support, and also to actually raise the profile of the need for people to get access to dermatology and a full assessment, which of course can reduce their risk of going on to develop depression. We didn't collect, obviously, the data that you're suggesting within this study, and that would be interesting to do, to use the same data set and to do this with a wider range of skin conditions to actually look at risk. I mean, there is some data out there that does suggest that people with vitiligo are at a similar level of risk to people with psoriasis, but I can't recall the study off the top of my head. You'll have to forgive me, but there is, I think that there is that concern out there that vitiligo is perhaps has less of a psychological burden. And in the introduction to the paper that's currently in review at the moment, we do go into some detail about the existing background data, and there's actually relatively few comparative studies. I mean, most of the studies have just done, looked at vitiligo in comparison to controls.
Thank you.
So sorry, I'm not able to fully answer your question there.
Thanks very much, Hal. In the interest of time, we'll just take one more question from Mike.
Hi, Mike Arden-Jones, Southampton. Thanks for the talk. I think Hal's question was absolutely critical, and I want to sort of allude to that, which is, have you any comment on potential mechanism, which might sound a bit bizarre, but obviously melanocytes with their sort of neuroendocrine origins, do you think there's any potential for actual vertiginous mechanistic anti-melanocyte type pathways to affect the brain, or do you think this is all simply about observing your own skin changes and not a sort of direct effect?
That's something that we need to look into in more detail. I think some previous studies have suggested that there's a bidirectional relationship, and that there may be impact of the disease itself on the development of depression. But for sure, we know that living with vitiligo can be burdensome in terms of having to manage stigmatization.
Thank you very much indeed, and thank you very much everyone. Please give Andrew a round of applause. Thank you.
So moving on to our second speaker, I'd like to introduce Sinead Langan, who's going to talk to us on the risk of severe COVID-19 outcomes associated with immune-mediated inflammatory diseases and immune-modifying therapies, a nationwide cohort study in the Open Safely platform. Thank you, Sinead.
Thank you. I'm going to present this major team science program of research aiming to address specific clinical uncertainties that we've all been faced with. So the last 2 and a bit years have been like no other. We have had to practice dermatology in a time where we've had a lot of uncertainties about who's at risk of doing badly, how should we best manage our patients. And 6.3 million people worldwide have died directly related to coronavirus. Now, some of the early studies did give us signals as to who was at risk of doing badly with coronavirus, with major focus on age, male sex, obesity, ethnicity, and deprivation. But I guess one of the things that caught my eyes from the original Open Safely papers was the 20% increased risk that they reported with rheumatoid arthritis, lupus, and psoriasis. Now, as a clinician, what I want to know there is which of those diseases is driving that increased risk, and is the increased risk related to drug? So that's the motivation for doing this work. The questions that I have come up with in my dermatology clinic, and I suspect similar around the country, are: does having an inflammatory skin disease increase my risk of doing badly if I get coronavirus? Should I stop my immune-modifying treatment because I'm worried about coronavirus? And these questions aren't just questions for us as dermatologists. The rheumatologists, the gastroenterologists, they're all asking the same questions 2 years ago. We've all had to practice without all the information that we might want. So this is the most authors that I have ever had on a paper, which is why my title slide didn't show this. And there's a reason for it. So this has been a major, large-scale program of work. The data platform was pioneered by Ben Goldacre and Liam Smith to answer clinical uncertainties at a time of urgent need. But it requires team science. It's not just clinicians, computer programmers, statisticians, epidemiologists. And to do this piece of work, we made a new collaboration across immune-mediated inflammatory diseases, rheumatology with James Galloway, dermatology, myself and Catherine Smith, gastroenterology with Nick Kennedy, who looks very familiar to most of us, related to his dad, who hopefully is here in the audience, and Charlie Lease from Edinburgh. And the immune-mediated inflammatory diseases that we were focusing on were rheumatology conditions including rheumatoid arthritis, skin diseases, psoriasis and hidradenitis suppurativa, and inflammatory bowel disease. And the reason for focusing on those is they're quite similar mechanistically, and they're often treated with the same drugs, so TNF inhibitors. I'm now going to talk you through a study design diagram, bit by bit. So we started this study in March 2020. We identified people who were currently registered with their GP practice for 1 year. We looked back in the previous 3 years to see if they had evidence of having an immune-mediated inflammatory disease. We then looked back in the previous 6 months to see if they had immune-modifying treatments, either targeted or standard systemic. And the reason this is possible is because we had new linkage to high-cost drug data. For rituximab, we looked back a year because of the long half-life of the drug. We look for other risk factors that might increase the risk of adverse COVID outcomes in the previous year. And then we follow people forward to September 2020 or until they died or were admitted to the intensive care unit. So here's our study population. It was huge. We have 17 million people in this study and more than 1 million that have immune-mediated inflammatory disease. The majority of those have skin disease, with the majority having psoriasis. And the people with skin disease and bowel disease were a bit younger than those with joint disease. They also had more comorbidities. They were more likely to be diabetic. They were more likely to have cardiovascular disease. And they were more likely to have had oral steroids in the previous 3 months. I'm now going to talk you through a directed acyclic graph. Now, this is the type of nerdy diagram that I like to create when I'm setting up a study like this, but I'm going to walk you through it bit by bit. So the question that we're interested in is, does having an immune-mediated inflammatory disease increase your risk of dying or being admitted to the intensive care unit because of coronavirus? In the pink blobs are confounders. Now, we must adjust for those because they will mix up the association between the exposure, the IMID, and dying from coronavirus. In the blue are factors that might be mediators. So for example, having an IMID might make you more likely to have oral steroids, which might make you more likely to die from coronavirus. Now, if we want to answer the question, to what extent is the IMID responsible for that increased risk of death, we might want to consider additionally adjusting for the mediators. The graph on the left shows our main results, and I'm going to zoom in on one specific outcome. So the outcome I'm going to zoom in on is ICU admission or death. And what we showed is that people with IMIDs were more likely to die than people that didn't have IMIDs, but that the risk was much higher in people with inflammatory joint disease compared to skin disease or bowel disease. The green blobs represent just age and sex adjusted, the red blobs represent the confounder adjusted, and the purple blobs represent mediator adjusted. And all of them are the right-hand side of the line, which is consistent with increased risk. This table may not look exciting to you, but I have been campaigning to get these data for 10 years. So to me, this is one of the most exciting bits of the presentation, because now we have information on high-cost drugs that we've never had before. So in this study, we have 181,000 people treated with standard systemic treatment. We have 19,000 treated with targeted immune-modifying therapy, with the majority of those being treated with TNF inhibitors, with smaller numbers being treated with the other targeted immune-suppressive medicines. So this is a bit of a more complicated diagram, but again here, we're looking at people on targeted compared to standard systemic treatments. The outcomes are the same. We're looking to see if people died or if they were admitted to the intensive care unit. And again, we have a lot more confounders here, so a lot more pink blobs that we must adjust for. And we have some critical mediators that it's important to focus on, including use of oral corticosteroids. So what do we find? So again, looking at the same outcome of it being admitted to intensive care or dying from coronavirus, we can see that people on targeted medicines were not more likely to die or to be admitted to the intensive care unit compared to people on standard drugs like methotrexate. We do see increased risks with rituximab, but you can see that that's based on relatively small numbers. So our key findings. We saw a 23% increased risk of dying from coronavirus if you had immune-mediated inflammatory diseases. The highest risk was for those with joint disease, but critically, this study is before we had the life-changing introduction of vaccines and antiviral treatment. We did not see any increased risk with targeted versus standard systemics overall, but we did see a small increased risk with rituximab, which attenuated a little bit but didn't go away when we excluded people with cancer. In terms of strengths and limitations, this is a huge new platform with drugs that we've never had availability on these types of drugs before. So this gives us power to answer some question and precision to answer questions that we haven't been able to answer before. But it represents teamwork. I'm standing up here, but there's about 50 people who co-authored this paper. But I think there's real advantages in working beyond our traditional silos and working across discipline, and I've learned a lot. It's population-based, which reduces the risks of selection bias, and we have a lot of information on these people. We do have missing data. We don't have as much information on ethnicity as we would like, and there's always the possibility of residual confounding. For some of the drugs, the events were infrequent, which is a good thing, but didn't give us the precision to specifically address increased risks with those medicines, as you would have seen with the wide confidence intervals. So coming back to the questions in clinic. Does having an inflammatory skin disease increase my risk of dying from coronavirus? Well, yes, it does, but that was before having vaccines or antivirals. And to me, what this means is that we should, as we probably all do, encourage our patients to get vaccinated. We might be the only doctors seeing them, but most of the increased risk is likely related to the comorbidities. Should I stop my biological drug? Well, no. We didn't see an increased risk in people on targeted versus standard systemic treatment, but we did see an increased risk with rituximab, which might relate to the characteristics of the patients in terms of either severity or frailty. Clinical decisions should be based on clinical need. On the 74th anniversary of the NHS, it's very important to acknowledge that this work is only possible because of the NHS and the wealth of data that we have collected by providers, all of us, on behalf of our patients. Thank you for your attention.
Thank you very much indeed, Sinead, for presenting that huge body of work, which is providing fantastic data for us to go forward with. Do we have any questions from the floor? Yes, please go ahead.
Thanks, Sinead. That was incredibly important data and beautifully presented, so thank you very much for sharing that with us. And you've mentioned the issue of vaccination, that was before vaccines. So I just wanted to take this opportunity to say that the VROOM study, it only came out last week, and I think many of you participated in the VROOM study, which is a study to pause methotrexate for 2 weeks during the booster vaccination, a randomized controlled trial. And we had to stop the trial early because there was a 2-fold increase in those in whom the methotrexate was paused for anti-spike protein. So whether that translates to reduced morbidity and mortality, we don't know, but there's pretty strong evidence that pausing methotrexate for 2 weeks does make a difference for future booster vaccinations. So, and your data sort of supports that, doesn't it? The biologics seem quite null, but the standard systemics, and there's more than methotrexate, obviously, seem to be associated with some of that increased risk. So incredibly important data. Thank you very much for that, Sinead.
Thanks, Howell. I've already changed my clinical practice. The patients I saw last week, I told them to hold their methotrexate for 2 weeks.
Just 2 weeks, and the disease don't flare much as a result of that. 4 weeks, maybe they would, but 2 weeks is fine. Thanks, Sinead.
It's a phenomenal effort. Congratulations on that study.
Thank you.
We both have got atopic dermatitis at our hearts, as well as psoriasis. So could you comment a little bit on whether the inflammatory disease signal included atopic dermatitis or not, and what's happening to atopic dermatitis? If it's just psoriasis that was included here.
Yeah, this is just psoriasis and hidradenitis because we wanted to choose diseases that had similar mechanisms and were treated with similar drugs. But I do have a protocol and plans to look at atopic dermatitis if the Open Safe Late platform is continued after the COPI notice, which we should find out imminently. So we have already identified the codes for eczema. We've identified the codes for dupilumab and other medicines. So, I mean, absolutely, I want to answer that question. I'm asked it every week. Thanks.
One more question. Microphone 3, thank you.
Great, thanks, Sinead. A brilliant talk, and I echo Howell's comment, very important data. So my question was about your acyclic diagram. Yeah. So I love those as well. It's a really logical way of thinking about study design. And I noticed that you had deprivation as a kind of confounder rather than a mediator. But following on from our talks yesterday, we do know that people with inflammatory disease are more prone to deprivation. So can you comment on that, whether it's maybe not just a confounder and actually could be partly a mediator of poor outcome?
Yeah, it's a great question, Sarah. You wouldn't believe how long we spent debating those directed acyclic graphs. Trying to do this cross-image with everybody having different opinions about which ones are mediators and which ones are confounders. And for some of them, of course, and we saw in the previous talk, some of the factors that they adjusted for, you could argue, could be mediators too. So I think these are always decisions that you make in the moment. The one thing I would say about deprivation in these types of data sources is that it's not perfectly captured, Sarah. It's usually based on the 2011 census. So I would say our measure of deprivation isn't perfect. and there are ways of enhancing it, but I mean, you could always argue these things in different ways, and for many of them we did sensitivity analyses where we treated them differently, but we didn't do that for deprivation. Thanks.
Okay, thanks.
Thank you very much, Sinead, once again.
Okay, so it now gives me great pleasure to invite the first of our invited speakers. This is Professor Raman. He is Professor at the Department of Dermatology and Venereology at the All India Institute of Medical Sciences in New Delhi. He has a clinical and a research interest in granulomatous disorders, pigmentary diseases, dermatopathology and psychosocial aspects of skin disease. He's also Editor-in-Chief of the Indian Journal of Dermatology, Venereology and Leprology from 2014 to 2017, and I understand you're President of the Dermatopathology Society of India and currently Vice President of the Asian Society of Dermatopathology. So over to you. Thank you very much.
Thank you very much for that introduction and the chance to be here. I'd like to thank Adam Fitton and the Medical Dermatology Society and Pew Banerjee and the British Association of Dermatologists for asking me to come here. I've been enjoying my time here in Glasgow. And I'm going to talk today to you about cutaneous clues to systemic disease. If you look at the program, it says novel cutaneous clues to systemic disease, which is how you hook the organizers in. And then when I am here, I can tell you that it's just a bunch of cutaneous clues that you may not have thought of as being really clues to a systemic illness. Now, most of the time when you have an abnormality of the skin, it indicates a disease that's confined to the skin, but some changes point to the possibility of a disease elsewhere. And I'm going to show you this slide and ask you to look at all 4 panels and tell me what you think are the diseases in the corner. You can yell them out or tell them to yourself. So up left, that's hyperlipidemia, hypercholesterolemia. So those are intertriginous xanthomas. And you can even get a genetic diagnosis because of the location of those xanthomas. What about upper right? Pews-Jeghers, that's absolutely right. Lower left, as Fabry's disease, and angiokeratoma corporis diffusum, and this person with pinch purpuras around their eyes, systemic amyloidosis. So those are things that you look at in the skin and you can tell. And there are several examples of this, and entire books have been written on this subject, and we could easily devote several hours to this, but I have about 15 minutes. So I'm going to talk about some conditions that are less familiar as clues, but which I think it's important to know about. Now, the first of these is this. Now, some years ago, we noticed that a couple of patients who we had with generalized ichthyosis had rickets, and it seemed like an unusual combination at that time, but subsequently, we've seen it in many children. Now, it doesn't seem to matter what type of ichthyosis they have. It can be epidermolytic ichthyosis like this child has, or it might be autosomal recessive congenital ichthyosis. Typical scales are seen on the hands. But if you take x-rays of these children, the knees show widening of growth plates and metaphyseal cupping and fraying, and you see the same changes here on the wrists. And very nicely, you can also see at the wrist the scales of ichthyosis there. Now, we looked at this problem more closely in our department, led by Professor Sethu Raman, who's our pediatric dermatologist, and the findings were remarkable. Now, if you look at the bottom, biochemical rickets is just a fancy way of saying hypovitaminosis D, and that occurs in about 36% of children at about the age of 6 months. But when you go up to children who have ichthyosis in addition, it goes up as high as 80%. And this is, for me, the important part of the slide, that this is not just a vitamin D deficiency, which has been reported in a large number of different diseases, and we can't make sense of that. But here, these are people whose bones are bent by the disease. enough to show up clinically or on X-ray. So why do children who live in a country with abundant sunshine develop rickets? It's possible that a dietary deficiency of calcium is likely, and also because they have severe ichthyosis, that there's something going on in the skin that makes it difficult for them to metabolize or use vitamin D. But I think the important part for clinical dermatologists is to be aware of this association and to screen for it appropriately. Because the troubling question to me is not why it happens, is why does it get missed? Why do children get to the point when they have bent bones before the diagnosis is picked up? I think some of it is because, if you have ichthyosis in a child with other problems, you think of it as a syndromic ichthyosis and don't examine as carefully. Fortunately, treatment is very easy, inexpensive, and quite effective. And now we are recommending that any child with ichthyosis should receive vitamin D supplementation. And if they have clinical, radiological, or biochemical rickets, then they should get large doses of vitamin D. A bit of a bonus, and this is again a paper that Professor Sethuraman published, which shows that quite apart from dealing with their vitamin D deficiency, the vitamin D treatment seems also to improve their skin. When I saw these pictures from his article, I also wondered if vitamin D makes them grow up very quickly. Because if you look at baseline picture and day 21, distinctly larger, but I saw the date stamps on these photographs and they are genuine. So I think it's just that they were getting closer and closer to take these pictures because there was less ichthyosis to see as time went by. All right, so that was clue 1. My next clue is skin ulcers. And to make it fun, I'm going to let you guess what the systemic disorder is that this next set of about 6 or 7 slides, these are all cutaneous ulcers, represent. There's one person in the audience who knows, but let's see if the others do. So now, not to make it any more difficult for you, but just to let you know which are the diagnoses you have to exclude. I can tell you that these were patients who were misdiagnosed as pyoderma gangrenosum, atypical mycobacterial infection, sporotrichosis, sporotrichoid infections, and vasculitis. One of them received a diagnosis of paniculitis, and another received diagnosis of hidradenitis suppurativa. So let me show you all of those pictures. So pyoderma gangrenosum was what this was called. This was called atypical mycobacterial infection, sporotrichoid disease, and vasculitis, paniculitis, and hidradenitis suppurativa. But those are all the wrong diagnoses. So now I want you to try and think what it might be that led to these ulcers in this set of patients, all due to one cause. So that cause is pentazocine abuse. All of these and we're going to look at them again very quickly. So Prasad, who is in the audience here, he put together a series of 10 cases when he was in our department, and we found some useful clues. Now, ulcers may be very deep and expose bone and muscle, and they all often have a lot of induration around them, but the diagnosis doesn't come from the large ulcer on the forearm, but the smaller ones at intravenous injection sites in the antecubital fossa and at the wrist. Here again, the ulcer at the wrist doesn't tell you as much as the smaller ulcers in the antecubital fossa. Here is somebody who was injecting on a vein along the leg, and they have ulcers there, and the smaller arrows here show you thrombophlebitis, which has healed with pigmentation. And here is somebody who has puffy hands and feet because of the lymphedema that occurs if you keep injecting yourself repeatedly. If it's an intramuscular injection that you're taking and the person giving it to you is a nurse or a doctor, then you have these neat ulcers and blisters on the sides. But if you were doing it yourself or getting someone who's a non-medically trained person, then you have more widespread and confusing presentation. So there are some morphological clues which would raise a suspicion of pentazocine ulcers, and those are listed here: indurated ulcers along superficial veins with thrombophlebitis and puffy hands. But apart from the morphology, we found it very useful to ask, once you suspected it, whether you've had pain in the past and how was the pain treated. And most people will say they'd used pentazocine in the past, but will deny current use. And the history of previous use is reliable, the denial of current use is not. Another difficulty is if your house officer tells you that it's terribly difficult getting samples of venous blood or starting an intravenous line for these patients. And if you have access to urine screening tests for pentazocine, you should do them for at least 6 days on the trot, because you can go for 3 days without pentazocine, but on the 4th day you need it again. So you have to test for a whole week. And if you suspect vasculitis, as we did in some of our patients, and mistreated them for 2 or 3 years with corticosteroids and immunosuppressives, and you send a biopsy as vasculitis, you know, the biopsy will show a pseudovasculitis, but because the clinical is vasculitis, it gets reported as vasculitis, the loop is closed, and you go for 2.5 years giving them stuff that they don't need. And there's another huge challenge with treating these patients, because this is a situation where the patient is making every effort to see that you don't make the right diagnosis so that they can continue to abuse. So that's something to keep in mind. All right, so number 3, it's facial pigmentation, which is related to metabolic syndrome, but it's facial pigmentation of a particular kind. It's on the sides of the face, so it's not like melasma, which is in front and you can take a picture. Here you have to show profiles because they are over on the side. It's brown, black, and slightly thickened. Sometimes it's accompanied by pigmentation on the forehead and around the mouth. Here are a couple more examples. Left and right profiles in a patient, and right profile in another patient. And all these patients have facial acanthosis nigricans. Let me show you somebody who's a little bit further down, and you can now tell that the skin is velvety and dark, but I think we should try and recognize it at this stage. Sorry, let me go back. Yeah, at this stage we should be able to recognize facial acanthosis nigricans. If you look in their axilla, you can find acanthosis nigricans. For some reason, the neck is not enough to make the diagnosis. I found you need to have them take their shirt off and look in their axilla. You have to screen these patients for metabolic syndrome. Hydroquinone and similar agents are of no use at all. And we know how difficult it is to get people to live a healthy lifestyle. But vanity, I think, could be potentially a motivator. If you tell them that if you lose weight, your face will look better, and it does, it's the truth, maybe you can get people to do things that they are not happy doing otherwise. And my last clue is this. Now, insect bite hypersensitivity is also called exaggerated insect bite responses or papular urticaria, and this is how patients usually look. They are young people, very young people, some of them. Look at this dolorous young man on the right with extensive lesions on exposed skin. You know, the covered skin is spared except for what we call the waistband sign over here. And then you can have them go on till you're in 10 or 11 if you're unlucky, but most of the time it goes away. But there is a set of people who develop these papules later in life. They haven't had it as children, and for the first time, somebody who is a young adult or a slightly older adult might develop this. And at this stage, where if someone develops insect bite hypersensitivity, then this is a clue to an immunocompromised state. This patient is one of the patients we had in a study that looked at papillopustule eruption of HIV infection in Chennai. And across the world, people have found that insect bite reactions are probably the reason for about 70 to 80% of those. They're also well known in oncohematological neoplasms, most commonly chronic lymphocytic leukemia. And we've also seen it in patients undergoing chemotherapy for different disorders. So that brings me to the end of my presentation. I'd just like to acknowledge Dr. Ria Ahuja in my department, who helped me put this presentation together. And I'll leave this on the screen as a visual summary of what we've talked about. And thank you for your attention.
Thank you very much indeed, Professor Raman. Some great insights there for us to take back to our own clinical practice, and certainly food for thought. Any questions for Professor Rahman? Okay, I think in the interest of time, we'll move on to our next speaker. Thank you very much indeed.
Thank you.
So our next speaker is Dr. Zenas Yu, who is going to speak to us on effects modification of biologic survival by patient characteristics, a prospective cohort study from the British Association of Dermatologists, Biologics and Immunomodulators Register. Thank you.
Thank you very much for the opportunity to speak today and to talk about our research findings in bad beer. I'm going to talk about effect modification of biologic survival by patient characteristics. And these are our conflicts of interest. So what is drug survival? Drug survival measures the time between starting and stopping a medication, and it acts as a real-world proxy for treatment effectiveness, safety, tolerability, and also adherence. There has been conflicting evidence over the real-world drug survival of the newer biologics for psoriasis. These are the interleukin-17A inhibitors, secukinumab and ixekizumab, and also interleukin-23 inhibitor, guselkumab. So we are really interested in the field to try and understand and better treat patients and really try to select the right drug for the right patient first time. And a lot of effort has gone into identifying biomarkers. But less is known about clinical markers, really easily accessible markers that we can measure in clinic. And there's not really been any consistently reported clinical marker predictive of a differential biologic response. And this was our objective here. We wanted to assess whether the drug survival of adalimumab, guselkumab, ixekizumab, secukinumab, and ustekinumab, commonly used biologics for psoriasis, whether the drug survival differed between groups of patients as defined by their patient baseline characteristics. So we used data from BADBIR, or the British Association of Dermatologists, Biologic and Immunomodulators Register. I'm sure many of us in the audience are very familiar with this database, but this is a national pharmacovigilance registry of over 20,000 patients now, and really one of the gold standard such databases worldwide. It's really designed for pharmacovigilance, but we have a lot of other data that we can interrogate, as we did here. And we use a data snapshot from August 2021. We defined discontinuation of therapy as any gap in treatment for more than 90 days, and we identified some baseline covariates for drug discontinuation from our own previous studies, as well as clinical observations and a systematic review. So we first examined biologic survival using survival analysis crude methods. We then wanted to take account of confounders and fit regression models. We used something called flexible parametric survival models. And really, we wanted to test for effect modification, whether there was a differential response between these biologics as defined by these different groups of patients by categorical variables. And really here in this talk, I'm going to concentrate on discontinuation due to treatment ineffectiveness. So here are some of our initial baseline patient characteristic results. You can see that we have quite big groups of cohorts of patients. We have a big group on the more older treatments, so adalimumab, ustekinumab, and even secukinumab, one of the biggest cohorts, more than 2,600 patients. We have smaller but still quite substantial cohorts for the newer treatments, ixekizumab and guselkumab. Understandably, we had shorter median follow-up times for these treatments. And I've highlighted some other important baseline patient characteristics that may be spoilers for some of the results coming ahead. But I'd just like to point out a number of previous biologic therapies. This really indicates there's changes in the cohorts of patients on these newer treatments. So on the older treatments, adalimumab, ustekinumab, you have a bigger cohort of patients who are biologic naive, never had a biologic before. Whereas for these newer treatments, ixekizumab and guselkumab, you have more patients who have cycled through more treatments. And this is really, really important, as we'll come on to. So one of our main findings, the most important effect modifier, if you will, is the previous biologics experience. So here you can see a graph. This is a combined graph. These slopes, the steeper the slope, the worse the drug survival. And you've got different treatments in different colors. So guselkumab is in orange, ixekizumab light green, secukinumab darker green, ustekinumab red, and adalimumab in blue. The dotted lines are the non-adjusted results, the Kaplan-Meier curves. The solid lines are the adjusted results, and the shaded areas are the 95% confidence intervals. In this graph here, you can see the first-line treatment. So ixekizumab and guselkumab overlap, so they are the two treatments with the best drug survival. You've got secukinumab and ustekinumab looking quite similar, and adalimumab having the steeper survival. But just to point out that this is still pretty good, still about 75% probability that people will stay on this treatment after 2 years. But as you move along the lines of treatment, you can start to see some differences. So for second-line treatment, you can see a much steeper curve now for ixekizumab. There's some separation between guselkumab and ixekizumab, whereas the other three treatments of secukinumab, ustekinumab, and adalimumab are pretty similar. And then you move further on to third or subsequent line treatment, and again, you can see a more separation. Now, you have that steeper drop-off. The interleukin-17A inhibitors seem to respond pretty similarly, crisscrossing ustekinumab and adalimumab across the different time points. Guselkumab, ustekinumab, and adalimumab tend to stay the same over these effect modifiers. So apart from biologic experience, what other things did we find? So one other important one is psoriatic arthritis. Now in this graph, we have different groups of patients who have no psoriatic arthritis in solid line. Dotted line are patients with psoriatic arthritis and split into the different drugs. And you can see that most of these dotted lines and solid lines are overlapping each other apart from ustekinumab. So just to point out, sorry for my shaky hand, the dotted lines for ustekinumab and solid lines are separating, showing that only in ustekinumab this effect modifier seems to be important in predicting response. Now in psoriasis looks very similar, and this is probably unsurprising given the close relationship between arthritis and nail psoriasis. Ethnicity is another interesting data set. We do measure ethnicity in bad beer, although these are in very broad categories. So here you have the first broad category of white ethnicity, and given what we know about health inequalities, you won't be surprised to learn that patients with white ethnicity do pretty well with drug survival. Over the different treatments, patients of Asian ethnicity tend to do less well, but this drop-off is most marked with patients on adalimumab, and this is not really seen for patients of other ethnicities. So it's important to acknowledge the strengths and weaknesses of our study. So we use one of the largest registries in the world for psoriasis patients to investigate biologic survival, and we were able to stratify for these covariates to try and understand differential response. These results may not be generalizable to other populations. We do need to await for replication, although it kind of explains a little bit why we do see different results from different registries, as often people do not stratify for previous biologic response. And missing data is an issue for many observational cohorts, such as ours. So in conclusion, we have found 4 different differential predictors of response. We have previous biologic experience, psoriatic arthritis, nail psoriasis, and ethnicity. And this reduction effect in drug survival is most pronounced for interleukin-17A inhibitors over treatment lines, most pronounced for adalimumab, and this is only Humira in this study, for patients of Asian ethnicity, and most pronounced for ustekinumab in patients who have psoriatic arthritis or nail psoriasis. So with that, I'd like to conclude my talk by acknowledging all the patients who've contributed data to Bad Beer, all the hardworking research nurses helping us enter data, everyone involved in the steering committee and the steering study group to steer this big project, and everyone in British dermatology contributing. And here are some acknowledgements of all the PIs of the different centers in Bad Beer. Thank you very much for your attention.
Thank you very much indeed, Dr. Yu. That was a fantastic presentation, very clear with enormous amounts of data, huge collaborative study. So thank you for that. Do we have any questions? Mike?
Hi Zain, that's a great talk. Can I just quickly clarify? I'm really interested with the ethnicity story. And I noticed your data cut went up to December 21, which obviously overlapped with COVID. How sure are you that the discontinuation was due to ineffectiveness and there wasn't any evidence of sort of fear of COVID and biologics, etc.?
Yeah, I think this is a really important point, and the related point is also the difference in the treatment landscape across time. And so this was something that many people were concerned about. Theoretically, with more treatments, there may be less persistence. So we broke down the different time points with sensitivity analysis, and we didn't really see a difference before and after 2018, which was reassuring. I think one of the important points also is with COVID, there tended to be more telephone consultations, and also perhaps a tendency to just continue a treatment actually throughout, or actually missing that data. So there is some uncertainty, especially with the newer treatments. So this is a completely important point and valid point. We do need to see replication and also ongoing data hopefully post-pandemic.
Are there any other questions? What are your thoughts on the effect modification for ustekinumab and nail and joint psoriasis?
Yeah, this is really interesting, as we know also ustekinumab is also licensed for the use of psoriatic arthritis. Anecdotally, we have found that patients don't really respond as well for their joints in ustekinumab compared to their skin. So this is probably why patients tend to change. But it is difficult to say for certain because we don't measure the joint outcome data in Bad Beer. So it's really important to triangulate this data with data from, for example, the psoriatic arthritis registries from rheumatology.
Zenas, perhaps I could ask you, obviously as part of drug survival, we know that can relate to treatment outcomes. Are there plans afoot for you to show us some data in due course around maybe absolute PASI responses for these different drugs?
Yeah, that's a really important question. I think this relates partly to missing data. The missing data is a lot more with outcome data compared to drug survival data. We do have plans to look at outcome and in a different way and in different comparators, so do watch this space.
Brilliant. I think this is a call to action for everyone to make sure they're entering as much data as possible into Bad Beer.
Yeah.
So thank you very much indeed, Dr. Yu. Thank you.
Okay, so we'll now move on to our next invited speaker. So it's my great pleasure to introduce Dr. Ruth Lamb, who's a consultant dermatologist from St George's Hospital. And Ruth is going to take us through a very important topic of multidisciplinary care in hidradenitis suppurativa with a focus on surgical management. Thanks very much, Ruth.
Thank you. I'm very lucky to work at the tertiary clinic at St John's, where we see referrals from across the UK. But I also am very privileged to work at St George's, where we run a regional referral service for HS. These are my disclosures. So I'm going to spend the first half of this talk looking at the practicalities of how we do surgery in HS, focusing on more complex disease. I'm not going to talk about laser. And then I'm going to spend the second half of the presentation looking at places where I think we as dermatologists can improve our patients' access to surgery. I think it's very easy to feel despondent in HS when our patients fail to respond to medical treatment. However, I think that the HS landscape is changing with new drug targets ahead on the horizon, many based on translational research rather than borrowed from other immune-mediated inflammatory disease. And I hope through this talk I can persuade you that surgery should be an important part of our growing treatment armamentarium. So HS features in all 9 international HS guidelines. Surgery features in all 9 HS international guidelines. But it's always just to treat refractory disease. Disease refractory to systemic therapy. And here it is in our own BAD guideline, down here at the bottom. And in line with this, we know that patients wait up to 13 years for surgery from diagnosis. So, whilst acknowledging that the evidence for surgery is low quality, uncontrolled, and retrospective, and being in agreement that surgery should not be used in isolation, we believe it should be considered at the outset with every new patient. I think when I think about surgery in HS, I think about it as a way of managing the sinus tract disease and the scarring, and of course the medical therapy to manage that inflammatory aspect. And thus surgery for me comes much higher up my treatment ladder. Earlier in the spring, I surveyed the British Society of Medical Dermatology to understand others' experience of HS surgery, and I wanted to share some of this with you. 80% of those surveyed were easily able to access wide local excision for the axilla via plastics. 10% of this group were doing so via a combined clinic with plastic surgery. Combined clinic working is a really positive collaboration, facilitating immediate discussion about the likely impact and timing of both medical and surgical therapy, thus potentially reducing our patients' time to wait for surgery. At St George's, I do 4 combined clinics with plastics a year, and at GST, we have them in clinic weekly. 40% of those surveyed were referring to colorectal for buttock disease, but 50% were not. There are many approaches to treating HS affecting the gluteal region, but our usual surgical approach would be de-roofing of sinus tracts with curettage of the lining to remove that stratified squamous epithelium and granulation tissue in order to create a healthy wound bed, which can then heal by secondary intention. 1/3 of dermatology departments surveyed had undertaken some form of HS surgery themselves, excluding IND and diagnostic biopsies, to treat HS. This is not something we've undertaken outside of a research setting, but this may be something that should be explored. And for the surgically minded, John Ingram has a fantastic video on the Cardiff University website showing how to de-roof. We know that there are at least perceived barriers in some geographical areas to HS surgery, and I would welcome thoughts on the end about how we can improve this. For example, it's been suggested previously that a national database of interested surgeons may be useful, but my plastic surgery colleagues tell me that the post-op dressing care in the first 8 weeks necessitates care close to home. So, there are 3 aims of surgery in HS, and the different surgical methods lend themselves to these aims as seen here. Now, recurrence rates are hugely and frustratingly variable in the literature, owing to the different definitions of recurrence, severity, anatomical location, and importantly, concurrent medical therapy. So rather than reviewing these rates from the literature, I thought I would share ours, which are significantly lower. And this is perhaps owing to the fact that we have medical control of disease alongside surgery. And these would be the lifetime risks that our surgeons quote to the patients. So we have, for the acute painful pointing lesion, of course, incision and drainage can be useful via A&E. We don't have data on that. De-roofing with curettage can give local control or reduce the disease burden, thus giving medical therapy a much better chance of working in our experience. If extensive de-roofing is undertaken, patients require an inpatient stay, they can shower on day 2 and go home when they're managing with their pain relief. As soon as they can manage the dressings themselves, they can get back to work, which is usually about 2 to 4 weeks, and they should be healed by about 8 weeks. Limited local excision can be useful in the groin and vulva, assuming partial medical control has been gained and there is a normal tissue margin around the plaque being excised to allow primary closure. Wide local excision, of course, with curative intent, for example, in the axilla, is a day case, one-stage reconstruction where sinus tracts are excised down to normal tissue, removing that pilosebaceous unit, often meaning they're down onto fascia in theatre. And the return to work is very similar to the de-roofing procedure. So this is obviously an intraoperative picture. Another patient with some plaques on the thighs that have been de-roofed. All three of these patients were delighted with surgery. As for some, they were able to sit or lie comfortably for the first time in a long time. Here we have wide local excision of the axilla and the groin. So complications are really as you would expect for any surgery, but recurrence is the one that we all worry about with HS. As I've already said, the surgical technique will affect the rate of recurrence. If undergoing wide local excision, then the way in which the surgeon reconstructs the area will affect the recurrence rate, and the area in which the surgery is performed on also has an impact. So I want to move on now to look at some of the methods of reconstruction that we use after wide local excision. But first, secondary intention, as dermatologists we're all familiar with this. This is a patient having had wide local excision on the axilla. Here, 10 weeks out, this is with a VAC dressing or negative pressure wound therapy, which is usually in place for 2 to 4 weeks. At home, the patient obviously manages that device. And then 3 or 4 months out, I think we would all agree, a nice cosmetic result. We're all familiar with skin grafts. This is one of my patients from St. George's showing the surgeon planning her flap reconstruction. She's a 30-year-old hairdresser under our care for a number of years, and she'd achieved a 50% improvement on adalimumab. She took a while to come around to the idea of surgery, and you may be forgiven for thinking that this looks quite mild disease, and this actually is her better axilla. She's had the other axilla already done. But that's why I put this photo in, showing the defect during theatre. I was surprised at how large this was, and in fact the surgeon's already closed part of this primarily. And the other picture showing the flap underway. This video shows how the scar will be disguised once her arm is down. Now, her mum came for the post-surgical follow-up with me after the first axilla, not this one, was done in January. And having known this patient for 4 years, I'd never met mum. So I had a slight feeling of unease as they both walked towards me in the waiting room. But mum wanted to come and speak to me because she wanted me to understand how delighted they all were. Her daughter was back at work, hairdressing, dating, and she told me she'd come out of her shell and that she had her daughter back. So really quite emotional and impactful surgery that patients go through. This is the result from the first axilla, not the one you've just seen, done earlier this year. So we've talked about how we can do surgery. Where can we do surgery? Well, there may be some sites you haven't considered before. Breast reduction and lift and abdominoplasty are successful, but in some cases require funding, so through the IFR route in England. Overall at GST, we've done about 20 breast reductions in the last 9 years, where the affected tissue is excised and the breast lifted, removing that occlusive element of disease. So we've covered most of these things that the surgeon will think about when planning surgery. But these areas are the place where I think we as dermatologists can make a difference. The ideal surgical candidate in HS is hard to find. Slim, non-smoker, perhaps with disease confined to the axilla where cure can be achieved. And we know there are restrictions across surgical specialties with respect to BMI. The BMI ideally pre-surgery should be less than 35, and above 40, the risks are outweighed. So refer for help with weight loss at the outset when you meet your patients. Of course, we know the benefits of weight loss in HS are fourfold. We can improve their cardiovascular health, we can improve their HS, the pharmacokinetics of the medical therapy, and we can improve their access to surgery. So early referral is key. And we're now in the very fortunate position that medical weight loss programs exist alongside bariatric surgery with the advent of the highly effective GLP-1 agonists. So understand your local weight loss pathways and refer these patients as soon as you can. The surgeon will also be keen that the inflammatory component of the disease is controlled, or at least partially controlled, with medical therapy, be that oral antibiotics or biologics. But sometimes we have used IV antibiotics pre-surgery. Many of you who've referred to us at GST will know that we do use ertapenem pre-biologics in some cases with a view to reducing the disease burden. Out of our 30 IV antibiotic patient episodes in the last 9 years, 1/3 were pre-surgery. If required, we would give IV ertapenem for 5 to 10 days, usually as an outpatient, and that has been our practice in the past. This is a patient of mine from St George's who's had ertapenem for 6 weeks pre-biologic, and I think it's easy to see why the surgeon would prefer to operate on the axilla on the right of your screen. We don't have evidence, however, that IV antibiotics improve surgical outcomes, such as looking at reduced time to heal, graft failure, or time on the table under GA, but we hope to look at this. I'd just like to talk about biologics and surgery now. We are often asked about withholding biologics pre or post-op. We don't recommend this. We all know that the half-life of adalimumab means that patients would need to be off treatment for about 6 weeks, and the risk of flare is too high for the surgeon there. And we're lucky that we now have the SHARP study, which is the safety and efficacy of adalimumab for HS peri-surgically. In this RCT, 206 patients were randomized to placebo or adalimumab for the 12 weeks before surgery, the 2 weeks peri-surgically, and 10 weeks post-operatively. Surgery was wide local excision with secondary intention healing. And at week 12, significantly more patients achieved high score, which is essentially a 50% improvement in inflammatory lesions in the biologics group, and there was no increased risk of complications. This study of 68 patients showed that surgery and biologics led to significantly better outcomes compared with biologic or surgery alone, and this group was most likely to achieve a 75% reduction in inflammatory lesion counts, which is enormous when you think the NICE criteria for continuing adalimumab for HS, they have to achieve a 25% reduction. However, they weren't able to show that the timing of biologic with respect to surgery was important. My feeling is that timing probably is important in a subgroup of patients, perhaps those with multi-site severe inflammatory disease, possibly with a higher BMI, where you might imagine that biologic alone would be unlikely to result in significant improvement. Thus, surgery to reduce the disease burden first, followed by biologic, may be helpful. I'd just like to talk now about the patient experience with surgery, which of course is what we're all interested in. This study from the Mayo Clinic, surveying 111 patients between 1976 and 2014, found that most patients were satisfied or very satisfied. This is a summary of all the published surveys on patient experience in HS, showing that patients would recommend the surgery to others. Most felt that it was superior to other treatments, yet this is despite really quite high recurrence rates. I'd like to finish now with a couple of cases. So my first case is a patient of mine from St George's, now in his 50s. He came under my care having been treated in Portugal for about 10 years, mainly with steroids for his HS. So I switched him to adalimumab, and he's had a number of other treatments along the way. This is a plaque on his hip when he's well controlled. This is his bottom. He had had some previous surgery elsewhere before coming under our care. But this is his groin. So we had always planned elective surgery for this gentleman under urology and plastics. And we're very fortunate at St George's that we have Professor Nick Watkin, who will undertake surgery to the male genital skin affected by lymphedema and HS. And he does take national referrals. So whilst waiting for his theatre slot, though, you can imagine getting a urologist and a plastic surgeon in theatre together takes time. Over the course of last year, this patient deteriorated. So you can see here that the areas on his bottom looking more full. This is him actually looking much better, but these areas here were hugely suppurative in the groin. So he's actually had some IV antibiotics when this photo was taken. And he was hardly able to walk by this stage, losing weight. That's the plaque on his thigh, which you can see had clearly extended and again was hugely suppurative. So we agreed that he should walk into A&E and he needed to be admitted. I suggested to the surgeons 2 weeks of IV antibiotics before surgery, but he ended up needing 8 weeks of treatment. And that's because the surgical team were not happy to take him to theatre with his anemia and his low albumin. So he required really quite significant optimization. He then went on to have the staged local excision, wide local excision of the affected areas, and finally with reconstruction in January. This is all as an inpatient. He had a colostomy prior to the perianal skin being debrided, and that was because plastics and colorectal felt that this was needed to ensure optimum healing. Here's an intraoperative image for you all, sorry. And then this is him post-op. This is me seeing him in clinic 4 weeks post-discharge and 9 weeks post-reconstruction. You can see that he's had a neoscrotum created here. This is the grafting on the perianal skin at the top, and then the plaque on his thigh didn't need anything more than IV antibiotics. He continued his adalimumab and acitretin throughout. So learning points, huge numbers of clinicians and allied health professionals involved in what was life-changing surgery for this gentleman. Caution with colostomy. There's no right or wrong at pelvic wide local excision. It's up to the surgeon. But for this patient, psychologically, actually, the colostomy was more challenging than the surgery itself. And I could and should have done more to optimize this patient before he was admitted. I was addressing his anemia, but not aggressively enough. And I wasn't doing anything about his low albumin. Case 2. So this is a patient from GST who has been under our care for a long time. I met him in 2013 when I started at GST. He's now in his 50s. He's failed or partially failed lots of different medical treatments. And he was one of the first patients in our service to undergo de-roofing to the buttocks. He had this on 2 occasions. And this is perhaps a case where we learned some valuable lessons. So this is him post-de-roofing. Whilst the cosmetic outcome here isn't great, this gave the patient significant improvement symptomatically and medically from our point of view. But the colorectal surgeon laid open some tracts running round from the buttocks into the groin and into the scrotum during theatre, and the patient had really very poor wound healing and cosmesis in what is obviously a psychologically sensitive site. As a result of this and some other cases around the same time, we now don't do laying open for the groin, vulva or scrotum, or we avoid it. Since then, he's gone on to have wide local excision of the groin and genital skin, again under Professor Watkins and Miss Lancaster, reconstructing the scrotum and penis, and the patient's very happy. So, learning points here. Avoid de-roofing in flexural sites. This patient's current issue is actually that the scar tissue centrally is now making it quite physically difficult for him to open his bowels. So it may be that there's more learning to come here. Would wide local excision have been preferable for very widespread gluteal disease, more in line with Europe, rather than de-roofing? Watch this space. So, in summary, I think that surgery should and could be an important part of our treatment armamentarium, and you should consider it at the outset. I recommend early referral for surgery and weight loss in parallel with medical treatment. Make the surgeon's job easy by optimizing your patients as much as possible whilst you're waiting for surgery. Think about the timing of surgery with respect to other drugs. And in my mind, ultimately, there is no substitute for face-to-face interaction with the surgeons. I find it creates an enjoyable, collegiate way of working and benefits the patients ultimately. So this is my mind map when I think about HS, but I've added on all of the different people that end up being involved in their care. And of course, central to everything that we do, we must remember there is a patient who has often been on a very difficult journey. and of course the dermatologist, although most of the time I really feel like my role is MDT coordinator. Here are all the fantastic clinicians that I work with, some who've been involved in some of the data that I have presented during this presentation. Thank you.
Thank you very much indeed, Ruth. That was really, really impactful, actually, and thank you for taking the time to collate all those images and videos in surgery, because that's really added to the message there. I'm delighted to see, actually, from your survey that people are able to easily refer to plastics. I was quite surprised by that. Did you collect any data then about waiting times? I think our plastic surgeons seem to collect these referrals, but then don't seem to act on them particularly quickly.
Yeah, no, we haven't. I mean, that's where I think, having the surgeons in clinic, I feel like it just puts a lot more pressure on their waiting list. You know, we have a microbiologist in clinic with us at GST as well, and you would think that that might have limited our use of antibiotics, and that's clearly why they were there in the first place. But in actual fact, I think that it has improved our access to antibiotics for these patients, because seeing the patient in front of you just is a game changer. And so I think, yeah, the face-to-face working does help make sure that the surgeon will put them on the list, because when you see them in 3 months' time, you can say, how's your waiting list looking? When's that patient going to have their op? Yeah, so face-to-face working, there's just no replacement for it.
A great tip there. Got a question over here.
Hello, can you hear me? Thank you very much. Lovely, lovely presentation. Very important subject. I'm Chuck Thomas. I work in Merthyr Tydfil, and when I took up the post, there hadn't been a dermatologist there for 8 years. And unfortunately, I came across a couple of cases of pyoderma complicating HS. And pyoderma gangrenosum were the 2 words missing from your presentation. In terms of just a sort of reality check, because we were talking yesterday about areas of the country that can't get dermatologists. So in West Wales at the moment, the dermatology service is being run by a plastic surgeon. And I guess the plastic surgeons might invite you to present similar presentations. Just take every opportunity you have to introduce the concept of pyoderma gangrenosum to the audience when it comes to HS, because the 2 cases we had were complete disasters. One still got his colostomy 15 years later, and we can't settle his pyoderma well enough in the groin.
Oh, yeah, so do you mean pyoderma as a separate entity? You know, I know there's an association, or do you mean, you know, there are subtypes of HS, so HS can look like PG, that very eroded. So do you mean surgery went wrong because it actually was pyoderma that was operated on and it caused a problem?
It's quite difficult to pick that out, but they certainly, when I met the young lady on the gynae's general surgery ward, she had pyoderma in her axilla. And they'd done very extensive debridement in the groin over the previous 18 months. And, you know, the front and the back of the groin, the buttocks were just incredible. They didn't debride that much, so obviously pyoderma had come in later. But I noticed your case, your 52-year-old, he'd been given prednisolone. I don't know what sort of dose, and whether it was sort of 1 milligram per kilo for 2 or 3 weeks. Because this lady's hidradenitis in her axilla disappeared in 3 weeks with 60 milligrams of prednisolone.
Yeah, and so interestingly, the Americans have prednisolone in their HS guidelines. So, you know, we don't use it. We have used it in a couple of probably less than 10 cases of patients who have PG-like HS. So I think that is different to what you're saying. This sounds like PG. But of course, yeah, there is that very inflammatory, eroded type of HS. And so we have used it, but only ever as a bridge to biologics. So, for example, there's one patient who had very PG-like HS. We actually gave them methylpred for 3 days, then went in with the biologics. But we don't use it in prolonged courses, and that was before this patient came to my care. I mean, I missed out that he was Cushingoid, had diabetes, you know, everything else that goes along with that. But yeah, so steroids can have a role. You have to be careful, again, with all the metabolic syndrome in this group. I think it's really tricky.
It's just a word of caution, because you said we want to consider surgery right at the start. And that was the approach with, I mean, he's now a retired general surgeon, he's left. but they were considering surgery right from the start, and we ended up with a couple of real disasters.
Right, okay, thank you. Any final questions? Thank you very much indeed, Ruth. Thanks. Well done.
So that concludes the first half of our session. Thank you to all our speakers for their excellent talks, and thank you to the audience for your questions.
Hello, I'm Pugh Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane, and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months, and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London. Diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Hello, I'm Pew Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Royal Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
So London. Diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and work in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Hello, I'm Pew Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population, and that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name's Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke, and I'm a consultant dermatologist, a Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of color dermatology is of particular importance to me. Obviously, I'm a man of color myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London. Diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. I'm Pugh Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Did we get anything last night?
Yeah, it's a bit random. Was going to go to Bad Fest, but I went home and had a lie down. I was just absolutely exhausted, and then I got up and was like, there was a dinner from the drug company downstairs in the hotel. So I had to walk half an hour, and I was like, oh, I'm just going to stay. Where are you staying? Now in town.
Oh, in town?
Yeah.
Right.
I thought it was here.
Yeah.
So I said, yeah, I'll go to Bad Fest, but no, it was half an hour walk away. So yeah, what did you do? Yeah.
I just went here for a bit and then went home early.
Did you? It's quite a nice opportunity to get a rest. Get the rest in.
I couldn't sleep actually.
Oh, could you not?
No, I'm never good about it.
No. I was actually better than I am here, actually.
I was better in America, I think, because of the jet lag.
Yeah. Helped. Apart from the sound from the road.
Yes.
Okay, welcome back to part 2 of the medical dermatology session. We've got a number of great speakers this morning. The first one, I'd like to introduce Michael Cork, Professor Cork, who's talking on the efficacy and safety of dupilumab in children aged 6 months to 5 years with moderate to severe atopic dermatitis. Thank you.
Thank you very much. With great respect, could you not take photographs of the clinical images I'm going to show? It's a great pleasure to present this dupilumab pediatric trial, 6 months to 6 years. So we've been conducting pediatric dupilumab trials now since 2015. And this is on behalf of all of our team, recruiting some of the most severe atopic dermatitis children in the world. These are our disclosures. And of course, my co-presenters. So this is Charlotte. This is a picture of her atopic dermatitis just before she went into another dupilumab trial, the Pelistad trial. And you can see her full story on our website, sheffielddermatologyresearch.com. And this, I've got a freezing here. Any help with this, please? Thank you very much. Thank you. This is Cooper. Cooper had extremely severe atopic dermatitis. Nicky Castle Hardcastle asked me to see him. He'd failed every conventional systemic drug. He was desperate to get into a dupilumab trial, and he just missed it. So Christmas Eve 2019, he wrote this letter to Santa Claus. Please read Cooper's letter. By the way, I'm not allowed to present these trials without having these patients participating. So, we're going to see what happens to Cooper. So, the objective of this trial was to evaluate the safety and efficacy of dupilumab in the 6 months to 6 years population. So the very earliest children, but extremely severe. So they'd already failed several conventional systemic drugs. Design of the trial, I'm just going to pick up on the dose. We had 2 different doses depending on their weight. So under 15 kilograms, we gave 200 milligrams every 4 weeks. Over 15 kilograms, 300 milligrams every 4 weeks. And it's placebo-controlled, as with all of the dupilumab trials, apart from the PK trial. Our primary endpoint was the IGA, and that's because the FDA liked the IGA. Secondary is the EASI-75. And then, most importantly probably, is the percentage EASI, and of course, the patient measures, the POEM and the itch. Just want to pick out from the baseline, the average age of the children we're putting into this trial was 3.8, 3.9 years. So this is the IGA, 0-1, the hardest measure to achieve. And you can see 28% of the children achieved in IGA at 16 weeks of 0-1, compared to 4% with placebo. EASI-75, 53% on dupilumab are achieving EASI-75 at 16 weeks, compared to 11% on placebo. And this, I think, is the most important in terms of the clinician measures. It's the percentage change in EASI. And you can see there's a 70% reduction in EASI at week 16 on dupilumab. And all these children went into the open label extension, going on for, well, it's now 4 or 5 years they're going on in the open label extension if they went into the first trials. And many of these are achieving 100% reduction in EASI after a year, 18 months. And then the NRS score, the itch, you can see it's almost 50% reduction in itch with dupilumab compared to 2% with placebo. And of note is the very rapid induction of improvement of itch that we see with dupilumab in this pediatric trial, as we have seen in all of the other trials. One difference with pediatrics is the younger you go, the greater the proportion that are going to respond to dupilumab. So if you think in adults you might get 25% that don't respond, under 6 years we tend not to see any. In the next age group we'll see 5%, and then more as you get older. POEM, again, highly significant reductions in POEM at week 16, dupilumab compared to placebo. Safety, I just want to pick out the serious adverse effects. They were infections, so infections occurring in the placebo group, mainly bacterial infections, some of them necessitating admission to hospital because they were so severe. And we had none of these on the dupilumab. We saw the same in the other dupilumab pediatric trials, where children who didn't get dupilumab were getting severe infections before they went into the open label extension. And then the other adverse event of interest, conjunctivitis, is less in children, significantly less than it is in adults. So in children aged 6 months to 5 years, we see highly significant improvements in clinical measures and a safety profile that is similar to that we've seen in adults, although maybe better on conjunctivitis, but we just have to wait and see with the open label extension. And the post-treatment pictures from my co-presenters. So this is Charlotte. Now, as I mentioned, she's in the Pelistad dupilumab trial. This is a very sophisticated trial where we look at the atopic dermatitis under their skin with a technique called optical cohesive tomography. It's like taking a virtual skin biopsy. And so we can see when all the atopic dermatitis has disappeared under the skin. This in children is going to be very important because this will determine when we can stop dupilumab, because that's the other difference compared to adults. If we look at some of the first children that we put on dupilumab back in 2015, some of the most severe, EASIs of 60 plus, after 3 years or so, they were off dupilumab in complete remission. So getting in early with dupilumab and other therapies in the future is extremely important. We may see disease modification. It's too early to say at the moment, but we may be able to switch the disease off. And I was chatting with David Page last night. We saw that before with drugs like methotrexate, but not as prolonged as we're seeing with dupilumab. We're now seeing them off several years and they're still clear. And then what happened to Cooper? Well, Cooper wrote his letter to Santa, but those of you who know the regulations on the medicines and presents that Santa may distribute to children will know that Santa cannot give out licensed medicines. So Santa's letter came back to me. And I was standing in clinic with our psychiatrist, Shether. I said, Shether, what do I do? It's Christmas Eve and I've got this letter. She said, why don't you send it to Len? Oh yeah, Len is the chief executive of Regeneron. It's lunchtime, so I'll send it. No, wait till midnight. Timing's everything. So midnight, I send Cooper's letter to Len Schlief, the CEO of Regeneron. midnight, Len replies, there's only one thing we can do. We'll give him compassionate use dupilumab. Merry Christmas. Thank you very much for your attention.
Thank you very much. Fantastic and really reassuring to those of us that do paediatric dermatology that potentially dupilumab is safe in that age group and effective as well. Any questions from the floor, please? Microphone 1.
Mike, thanks very much for a great presentation. You mentioned compassionate use approval, and as that brought back some memories of a child who I've looked after who has not responded to dupilumab, at least not in the long term. She did extremely well initially, and then unfortunately after a few months a skin infection came in. She essentially was taken back to where she was before starting dupilumab, and I've struggled ever since. She's now on abrocitinib, 200 milligrams once a day. This is a 12-year-old and still not doing very well. So just wondered, although it's great obviously to have these medications coming into younger ages as well, but from your experience, do you have patients who don't respond to dupilumab? And if so, what characteristics do they have? You know, is there anything particular around those patients?
Yeah, Costa, this is a really important question. So, as I was alluding to, the proportion not responding is different in different age groups. Although we've not seen any non-responders in this very young age group, under 6 years, absolutely. As they get older, I see non-responders, and certainly by the time they're 12, I'm seeing non-responders. And I've put them on abrocitinib as well, on compassionate use, with a good efficacy. And that probably is to be expected, because I always explain to the patients that dupilumab will only hit 2 chemicals, while abrocitinib is going to hit lots of the chemicals that cause your eczema, and so you've got a greater chance of it working. So, yeah, absolutely. The JAK inhibitors are going to be really, really important in patients who don't respond to dupilumab, and we see more as they get older.
Question, microphone 4.
Lovely, thank you. Loma Gardner from Tameside. I just wanted to know if you, in this age group, being a mum of 4, you get threadworms in young children. Is that a concern on dupilumab? Do you stop treatment? Do you tell patients anything to do about it, or do you just...
Okay.
Pardon?
Sorry, what was your question? Whether it comes back if you stop it?
Just if they get threadworms while they're on dupilumab.
Excellent question, yes. Yes, you should be vigilant on parasites. And in the phase 2A, so this is back in 2015, we had one girl who went off to Pakistan, and we'd obviously given her lots of advice about avoiding parasites, but she came back with parasites. So we stopped the dupilumab, and then my pediatric infectious diseases, she's in the next room, so we just went through a standard regime. We treated her. I can't remember which parasite she had, but she had some worm or something. And then she had 3 negative stools, and then we put her back on dupilumab. The number of children where this has happened with is quite small, but if they're going to high-risk areas, yeah, be really vigilant.
Thanks.
Thanks, Tom.
Oh, Mike, sorry, one final question quickly. Sorry. Yeah, I was really impressed with the data, thank you. And the amazing thing about that is saying that you really didn't see any non-responders. Obviously, although they were all responders, they didn't clear, most of them. So I was struck by the dosing, because is there a sort of a physiological reason with children why you would go for 4 weekly? Or was it just a sort of a pragmatic approach to dropping the dose?
It's done on mathematical modelling of the PK data in the age group above them. So they use that to do mathematical modelling to work out the best dose. What's interesting with the dose is, though, when they get to dose boundaries, so they're hitting 15 kilograms or hitting 30 when you go into other age groups, you sometimes see a slight reduction in effect there, so that they seem to be very dose sensitive. But yeah, it's all based on mathematical modelling of PK data from other trials.
So do you think it's possible that going to 2 weekly or even 3 weekly you might have got more effective?
Absolutely. I think this is a really important area for future development and future trials. And we've been having lots of discussions about personalised dosing, because there are some where, well, a bit like the adults, where you get tail-offing in the 2nd week. In children, you see it when they hit the weight boundary, and we joke, that they should put some weights in their pocket, and then, oh right, you've gone over the weight limit. Oh, no, I didn't say that. But seriously, it really does seem to be very sensitive to weight at the weight boundary.
Fantastic. Thanks very much.
Thanks.
Excellent. Thank you very much, Mike. So our next speaker is Dr. Rahimi, who's going to present on behalf of Portsmouth and discuss P3NP and liver fibrosis.
Hi, good morning. Thank you for letting me present today. And in Portsmouth, we've been very interested in liver monitoring in dermatology over the last year. And so our project today that I'm presenting is Erase P3NP as a matter of time, replacing P3NP with FIB4 for monitoring of methotrexate-related liver fibrosis. I have no conflicts of interest to declare. So methotrexate is on the WHO list of essential medicines, so that means it should be available to every healthcare system, and this really highlights its importance as a treatment option. Initial guidelines on the low-dose methotrexate suggested liver biopsies prior starting and 4 weekly blood tests and further liver biopsies if liver function tests were persistently abnormal. However, liver biopsies are associated with significant morbidity and mortality. And this is why it was later on replaced by P3NP, but this was all based on level 4 evidence of small case studies. So in 2016, the BAD guideline for the safe and effective prescribing of methotrexate recommended procollagen type 3 and terminal peptide for monitoring of liver fibrosis in psoriasis patients taking methotrexate. P3NP is a peptide that is broken off when procollagen is being made. It is non-specific and is not specific to liver fibrosis. Our aim was to audit all our P3NP data and assess its relevance in today's practice. FIB4 index is a non-invasive screening tool used to measure the risk of developing liver fibrosis for several liver diseases. It was initially developed for chronic viral hepatitis patients to assess the need for further biopsies or liver biopsies or further treatment. And it has proven to be a sensitive marker in excluding advanced liver fibrosis with good negative predictive values. And it's also cost effective, so a P3NP in our trust costs about £18, whereas an additional AST only costs £1.70. This was a retrospective review of P3NP results in a single center between January 2018 and May 2020. We also reviewed investigations and clinic letters and how these influence future management. FIB4 indices were then retrospectively calculated for those patients with abnormal P3NP results according to the BAD guideline and where all necessary biochemical parameters were available. And a FIB4 of less than 2 in the 65 and above year olds and a FIB4 of less than 1.3 in the 36 to 64-year-olds thought to exclude significant liver fibrosis. In the 35 and below year olds, there were very few patients that were biopsied in the validation studies, so that's why it's not really validated in this cohort, and this is because liver fibrosis is a rarity in this population. Down below you can see a table with sensitivities and specificities of FIB4 and also FibroScan. We didn't add here P3NP because there's actually no robust data sets available in this patient cohort. Metabolic syndrome, as we all know, is prevalent in the psoriasis cohort. The worldwide prevalence of metabolic syndrome in the normal population is thought to be about 25%. In the psoriasis cohort, we think it's about 34%. And with that, non-alcoholic fatty liver disease is also prevalent. Also, metabolic syndrome has shown to correlate with the severity of skin disease in small studies. The increased prevalence of non-alcoholic fatty liver disease in the psoriasis population leads to reduction of the negative predictive value for markers such as P3NP. Sorry, this is a busy slide, but you can see the histological classifications for methotrexate-associated liver injury and non-alcoholic fatty liver disease next to each other. And you may be able to appreciate how similar those are, making an isolated diagnosis very difficult. This highlights that methotrexate-induced liver fibrosis is not a well-defined pathology. And also the reported cases of methotrexate-induced liver fibrosis were often poorly controlled for risk factors such as metabolic syndrome or alcohol use. And also back then, metabolic syndrome was not described yet. Further, I want to highlight the importance that fibrosis, especially in non-alcoholic fatty liver disease, is generally a very slow and chronic process, taking years to develop. In contrast, transient transaminitis is a common occurrence with a twofold increased risk in patients taking methotrexate. So, out of the 369 patients, 168 met the inclusion criteria. This means they were 18 years or above, and they had a diagnosis of chronic plaque psoriasis, and they were on methotrexate. Out of these, 108 had raised P3NP levels according to the BAD guideline. We were able to exclude significant fibrosis by calculating FIB-4 indices for 37 out of 55 of the patients that had all necessary biochemical parameters available. And importantly, no cases of methotrexate-induced fibrosis were found. With the use of FIB-4, we could have saved about £10,875 by doing an additional AST instead of P3NP for those patients. Here you can see that 59.3% of patients with abnormal P3NP results were referred for further investigations. However, many abnormal P3NPs were not investigated further. Why that is, I don't know, because it wasn't a retrospective audit. But a big audit from the Nottingham hospitals a few years ago also, they found the same results. And also to add here, those who did not have abnormal results often had less frequent monitoring than suggested by the BAD guideline, which suggests quarterly P3NPs. So just to recap, 64.3% of all eligible patients had abnormal P3NP levels according to the BAD guideline. Out of those, 59.3% with abnormal P3NP levels were referred for further investigations, and FIB-4 excluded significant fibrosis and 67.3% of patients that had the necessary biochemical results available. In other words, over 2/3 had abnormal P3NP levels, and those who didn't often had less frequent monitoring than advised by our guideline. They're not always investigated, and we may have been able to reduce the amount of referrals by over 2/3 if we had used FIB-4, and could have saved money if FIB-4 was more cost-effective than P3NP. So just some final thoughts. Methotrexate-induced liver fibrosis is not a clear, isolated entity. There's a lack of good evidence that methotrexate-associated liver fibrosis exists, as histological diagnosis is difficult, and early trials were poorly controlled for other risk factors. P3NP causes less harm than a liver biopsy, but nowadays there may be even better tests available, such as FIB-4 or fibroscans, with better negative predictive values. Also, given its slow progressive nature of fibrosis, 3-monthly monitoring may be excessive if methotrexate-associated fibrosis even exists. Thank you for listening.
Thank you very much. Open for questions. Question here at the front.
Thank you very much for the talk. The only trouble is that we have quite a majority of patients in that age group that is not validated for the tools yet, mainly because that transaminitis is pretty much a multifactorial in that age group. Those are the ones who go out drinking and having many problems. Now, the thing about the methotrexate-induced fibrosis is all related to the healing phase of the whole wound healing process. Adenosine related, right? So is there any evidence, so I want the speaker and the audience here correct me if I'm wrong, if we can actually look at the methotrexate-induced fibrosis as a way of an individual getting metabolic liver disease that subsequently over-scar because of the inflammatory response. If we can actually manage the metabolic liver disease, we can actually control the rate of the methotrexate-induced fibrosis. Am I making sense at all?
I think, as I said, thank you for your question. It's very difficult to differentiate between the two, so metabolic syndrome and methotrexate-associated liver fibrosis, as the histological classification is so similar. So I'm not sure how.
What I'm trying to say is that the methotrexate-induced fibrosis is not primarily an inflammatory condition. It is actually the overwhelming scarring, the healing process. Because with wound healing, we have inflammation, debridement, followed by the scar tissue healing. It's that adenosine-related pathway that is actually boosted up by the low-dose methotrexate.
I'm not sure. Does anyone in the audience?
And therefore, it makes sense to just refer to hepatologists early to control the diet, light diet, and P3NP just too non-specific. But I agree, it's a bit difficult.
Thank you. Maybe you can discuss this after the end of the session. A question from number 4.
Yeah, I just wondered if you looked at the basically how superior was the FIB4 to the AST alone, or the AST-ALT ratio?
Definitely superior. We've got a table with all the data available with how more sensitive or specific it is and with the area under the ROC curve. So I'm very happy to show that to you later on.
And was this cross-sectional or did you do 2 time points?
So we just audited from 2018 to 2020 all our P3NP results.
Thanks.
Thanks. Microphone 2, then microphone 1.
Very much. That was a great talk. I've got a question about age and FIB4, because we use FIB4s and they're great, but of course as the patient gets older, the FIB4 goes up because of the way the thing's calculated. So I'm just wondering how you take that into account, and if you have a cut-off where you take the FIB4 a bit less seriously.
We've only really very recently started doing FIB4s, but yeah, we have this cutoff of less than 2 in the cohort of 65 and above.
So I think when you get to 70 or 80, it makes a huge difference. So I just wonder if you need more steps than just above 64.
So I think this is all from hepatology guidelines. So yeah, but interesting. Thank you.
Thank you, microphone 1.
Thanks very much for that. I'm speaking as someone who was involved with P3NP back when I became a consultant in Manchester area in 1983 and inherited a large number of people on methotrexate who'd never been had any liver biopsy or any of that sort of monitoring. And really I worked with a hepatologist, Tom Warnes, at Manchester Royal Infirmary. We were under quite a lot of pressure from the Roenick group in the US to be doing regular liver biopsies on all our patients on methotrexate. And the P3NP, we started to do that to try to spare patients having very regular sort of 2-yearly liver biopsies. And I personally did about 100 liver biopsies as part of that original study. A bit of history for you.
Yeah, that's very interesting. Thank you.
Thank you. Time for perhaps 2 more brief questions, but certainly one here.
Thank you. Sorry, it was a very clear presentation. Thank you very much. If you speak to most hepatologists, they will say the primary risk factors for liver disease, whether it's fatty or cirrhosis or cancer along that spectrum, will be metabolic syndrome, it will be centripetal obesity, it will be the excess alcohol intake, and the methotrexate largely tips them. So what this is a fantastic screening factor to know when to refer on to hepatology. You can combine it with a fibro scan, so you can double up your sensitivity and specificity. They cannot see everybody, and we are in clinic, we can tell people about weight reduction, you
can measure their weight, you can tell them getting off the bus a few stops early, you know, lifts up and down. We see them regularly. They can't see everybody, so this is a fantastic alternative screening tool.
Thank you, I agree. I think tackling the metabolic syndrome is really important, and we can start with basic tests such as FIB4, and then if that's unclear, we can do other, liver screens and fibro scans, and then refer on to hepatology, but reduce the number of referrals.
Thank you. And finally, I think Dr. Rahimi would like to know how many people she's convinced that BAD should revisit the guidance to test P3NP. Put your hands up if you think we should revisit that. Pretty overwhelming, I think. So, well done.
Thank you.
Our next speaker is Professor Carsten Flohr, who's speaking on the TREAT trial. Thank you.
Thank you very much. I'm delighted to tell you about what we found in TREAT. This is me just speaking on behalf of a very large group of investigators. A lot of the site principal investigators are here. It was quite sobering to look back. This has been a more than 10-year journey. We started off with the European TREAT survey to find out how systemic therapies are being used in children to inform a trial. We're very fortunate that the NIHR decided to put out a themed call for skin diseases in late 2013-2014, got funding through that, started trial recruitment in May 2016, finished the last trial participant follow-up in April 2020, right at the start of the pandemic. Lucky us, but nevertheless, COVID really put a big brake on the processing of a lot of mechanistic samples that we've collected as part of TREAT. But finally, we are here to tell you the results. The journey began with this recognition that really, when it comes to children, we don't have an adequately powered randomized controlled trial with conventional systemics to tell us what the gold standard should be. And this is in an environment where the National Institute for Clinical and Care Excellence requires us to use at least one first-line conventional systemic before we travel into a novel agent. Cyclosporin is licensed from 16 and above, and it comes at quite a high cost. So which drugs should we really compare to provide that gold standard, and at what dose? We collected data on current practice in the management of severe childhood atopic eczema across Europe. It really was about inducing long-term disease control. We made it very clear to everyone who was participating in the survey that this wasn't about treating acute flares. And we wanted to identify barriers to the use of specific agents too, really to inform that clinical trial. Using a case scenario of an adolescent who had failed topical therapy and also narrowband UVB phototherapy, just to standardize the responses. We had over 340 consultants from across 8 European countries participating. 71% told us they use systemic medication in severe cases. By and large, cyclosporin leading there at that stage, and we're really surprised, about a third of people still using oral corticosteroids for long-term disease control, at least at that stage, back in 2013. 22% used azathioprine, and then methotrexate was an emerging but clearly important drug, and I would argue, although I don't have that survey data from a repeat survey, our practice of conventional systemic prescribing has changed, and methotrexate is becoming increasingly commonly used. For a lot of centers now, it is the first-line therapy, but we're lacking that RCT data. So I think we got our choice right. We went for cyclosporin versus methotrexate. Cyclosporin at 4 milligram per kilogram per day, methotrexate 0.4 milligram per kilogram per week. These doses came from the TREAT survey. We decided to recruit children aged 2 to 16, and we wanted to not only see how they fare on therapy, but also how they do once you stop the treatment. That's something that's not very often done in clinical trials. Of course, we wanted to look at drug efficacy, safety, impact on quality of life. We've conducted a detailed cost-effectiveness analysis, which is not covered as part of today's talk. And then there's this mechanistic component nested in the TREAT trial, because the EME program really supports looking at the mechanisms of how drugs work. Again, I'm not going to tell you about those results today. people on the left put the grant in. That's a group of co-applicants, but on the right, our 13 centres, 12 in the UK, 1 in Dublin. Phenomenal effort from so many people, not just the clinicians, but also the research nurses and the wider teams. We had two hypotheses for this trial. The first one is, you might not be surprised, that cyclosporin is fast at reducing disease severity at 12 weeks into treatment, and then that methotrexate leads to better disease control off treatment, measured as reduced risk of reflare, so restarting systemic therapy or returning to baseline disease severity. But we also wanted to look at the frequency of patient-reported flares off treatment. Two key primary objectives. So to assess the change in disease severity, and we used the objective score for this, between baseline and 12 weeks of treatment, and then to examine disease remission, so time to first significant flare after treatment cessation. Important secondary objectives, to track disease severity over time from baseline to right at the end of the trial using EASY, O-SCORAD, IGA and POEM scores. What proportion of children reflare after treatment cessation, looking at quality of life, using the CDLQI throughout the trial journey, and then of course looking at treatment safety too. We randomized 103 children. Based on our power calculation, we needed 102 children. This is a pragmatic design trial. We allowed concomitant topical anti-inflammatory treatment throughout the trial. People had to have an objective score of at least 30 and fail potent topical corticosteroid therapy at enrollment. And while we weren't able to do this as a placebo-controlled trial, because one drug is given once a day, whereas the other one is given on a weekly basis, all our assessors were blinded. 52 children ended up on cyclosporin, 51 on methotrexate. One of the cyclosporin children never received drug because we found out there are traces of alcohol in cyclosporin solution, and because the parents were Muslim, they decided not to go ahead with trial treatment. One child each lost to follow-up in both groups. 4 withdrew in the cyclosporin, 5 in the methotrexate arm. There was premature discontinuation of treatment in 7 children in the cyclosporin group, 13 in the methotrexate arm, and the intention to treat analysis included the 52 in the cyclosporin and the 51 in the methotrexate group, but from a safety analysis point of view, it was just 51 in each because that one child didn't have cyclosporin from the start. Looking at the baseline characteristics, sex, ethnicity, age, weight, height, you can see there's a decent balancing really between the two groups. When you look at the EASY, objective, SCORAD and POEM scores, EASY's of close to 30, objective scores well over 40. You can see this is truly significant disease, and these figures are very similar to the more recently published novel systemic trials in terms of disease severity at enrollment. So what did we find? First, co-primary efficacy assessment. So this is the change in atopic eczema severity between baseline and 12 weeks using the objective SCORAD index. We did find what we expected. So there was a 5.69 greater improvement in the objective SCORAD and the cyclosporin compared to the methotrexate group. Second co-primary efficacy assessment was time to the first significant flare. And you remember we defined this really quite rigidly. It's a high bar to get across, returning to baseline objective SCORAD or restarting a systemic treatment during the 24 weeks after treatment was stopped. While there was a trend towards a higher rate of reflaring with this definition in the cyclosporin compared to the methotrexate group, this was statistically not significant. Now looking at change in disease severity over time throughout the whole journey of the trial. So from baseline to week 60, we used mean profile plots, linear mixed models for the different scores, adjusted for each respective baseline score and including interaction between time and treatment allocation. Time was included as a continuous variable in order to allow for visits outside of the scheduled visit windows. I'll let you digest this slide a little bit. So just to make it easier for you to see the results, in light blue here, this box is on treatment. So this is the first 9 months of the trial, and then off therapy in light green. Cyclosporin is in light blue, continuous line, methotrexate, red dotted line. So this is for the EASI score change over time. Stars indicate statistically significant results. And as you can see, cyclosporin is, as we found with regard to the primary outcome using the O-scored, is faster at the beginning and significantly so at week 12. But then from round about week 20, the picture flips and methotrexate starts taking over. And the interesting thing about that is that when you look at the 36-week endpoint for methotrexate, you can see how the graph seems to be pointing further downwards. We had to do a trial that was manageable within the confines of time and the resources we had, but you wonder whether if we'd continued this trial, whether we would have seen an even greater improvement in methotrexate, whereas the cyclosporin group seemed to plateau at that stage. And then no matter how else you look at the change in disease severity, whether you use the O-score here, again, over time, you see the same picture. This is the IGA. And also for the poem. Although the results were statistically only significant for the week 12 follow-up, with a difference in 2.73 in the poem, favoring cyclosporin, and then right at the end, at week 60, the poem was favoring methotrexate. CDL-QI changes were encouraging because you see a similar improvement in quality of life in these children in both study groups, above and beyond the minimal clinically important difference of 6, and that effect seemed to be sustained even after stopping treatment at 36 weeks. Number of parent-reported flares in each study arm, so this is again after stopping treatment. This was favoring methotrexate, so it was a mean total number of flares of 3.22 higher in the cyclosporin compared to the methotrexate arm, indicating better disease control with methotrexate compared to cyclosporin, even off therapy. And because categorical outcomes are so important now in the more recently published clinical trials, just to give you the EASI-75 scores as well. So at 12 weeks, cyclosporin was significantly better in terms of EASI-75, 44.2 in the cyclosporin group compared to 19.6 in the methotrexate group. At 36 weeks, they're pretty much at the same level. And then at 48 and 60 weeks, methotrexate is better with an EASI-75 of 46.7, still maintained at that stage off treatment compared to 29.8% cyclosporin, and a similar picture for the 60-week time point. Treatment safety, obviously important. There was a lot of oversight to this trial, for instance, through our independent data monitoring committee. Methotrexate caused nausea. Well, we knew that. It's helpful to have a figure now. I mean, it helps me talking to my patients when I counsel them around starting methotrexate. 43% had nausea compared to 17.6% cyclosporin. There are no significant blood or blood pressure abnormalities in either group, low rates of withdrawal and non-compliance overall. No safety concerns raised by the independent oversight committees, and then we didn't have any SUSARs either. So bringing it all to a close, cyclosporin was superior to methotrexate at 12 weeks using the objective score. There was no significant difference in time to first significant reflare, but that was a really high bar, having to restart systemic therapy because of the impact on quality of life or reaching baseline disease severity. There's a significantly higher number of parent-reported reflares in the cyclosporin compared to the methotrexate group off therapy. And methotrexate leads to better disease control using these different severity outcomes, both physician-assessed and patient-reported off treatment. Both drugs led to a noticeable improvement in patient-reported quality of life, which seemed to be sustained even after stopping therapy. Both drugs were relatively well tolerated and really appear safe within the confines of the trial. I would suggest there is a potential change here in how we, as dermatologists, prescribe methotrexate. I think traditionally, a lot of physicians have gradually updosed methotrexate. In this trial, we decided to go straight onto the full treatment dose of 0.4 milligrams per kilogram per week. A lot of our children ended up on 20 or 25 milligrams of methotrexate. Now you might say, my word, I'll never do that. It was a bit brave, but actually rheumatologists do this all the time, and they were the people who inspired us at the start when we planned the trial, together with our dermatology colleagues from 8 European countries telling us this is the right treatment dose to use. The health economic and immunology metabolomic analyses are still being finalized, so I hope to be able to present those at a later date. As I said, this has been a huge effort, and I feel very honored to be standing here on behalf of a huge team. There are more than 80 people who were involved in this trial over the years. I'd really like to thank, of course, the co-applicants, the trial steering committee members, some of them are here too, the independent data safety monitoring committee, our health economist, the Liverpool Clinical Trials Unit, who helped to steer us through sometimes choppy waters of a trial that is challenging, doing it across so many sites. The UK Dermatology Clinical Trials Network were hugely important in getting this all started, helping us to identify sites, and UK Trend also helped right at the start in the planning of the study. Eczema Outreach Support and National Eczema Society, thank you so much for supporting this study, and of course all the participants. And here you go, you've got the trial investigators, the research nurses, clinical trial practitioners. Again, thank you very much, everyone.
Thank you. Questions then? So Alexa on microphone 4.
Hello, you mentioned you had no blood abnormalities, and I just wondered, has that changed your clinical practice? Because it's certainly the thing that causes the greatest impediment to stop medication in my children, the anxiety and the tears about regular blood tests, and I would hope I could do them less often.
Yeah, I agree. I think we probably can, even with these drugs. We haven't rewritten our hospital treatment guideline yet for methotrexate. We're about to do that, but I think we can, and again, we can follow the rheumatology example. Rheumatologists don't do test doses. They test for safety bloods for both drugs much less frequently than we do.
Thank you. I'm afraid in the interest of time, we will have to push on. So I'm afraid we have to stop the questions just there, if that's okay. We'll move on to the next speaker. Thank you very much.
Now we'd like to welcome Dr. Gopi from Newcastle, who's an MRC training fellow, who's going to talk to us about the Human Skin Atlas.
Thank you. And thank you for the opportunity to speak today. I'm presenting on behalf of Professor Hanifa and the whole team working on the Skin Development Cell Atlas. Got no conflicts of interest to declare for the purposes of this talk. I'm just going to provide a brief overview of the Development Cell Atlas, which basically falls under the wider remit of the Human Cell Atlas, which aims to profile the different cell types and states that are present within the developing human. And the purpose is to be able to better improve our understanding of some childhood and congenital disorders by studying cell lineages and their temporal development. And also to be able to get a better idea of the fetal programs that are co-opted or exploited in disorders such as cancers and inflammatory disorders as well. So for example, in our paper published back in 2020 in Science, we demonstrated that some fetal programs involving macrophages, a subtype of macrophages, and in their interaction with the capillary venules and which recruit lymphocytes are actually present in development, but also expanded in conditions such as eczema and psoriasis, and are following treatment with methotrexate reduced significantly, which aligns with a response in treatment in patients. I'm going to focus today on the skin component of the Development Cell Atlas and highlight some of the findings that we have come up so far. Especially with regards to hair follicle development, basal keratinocyte heterogeneity, fibroblast differentiation, and the role of immune cells in skin development. So what we did was profile the prenatal human skin spanning from a 7 to 16 post-conception week using single-cell approaches, droplet-based single-cell RNA sequencing, and integrated that with some already published single-cell atlases or datasets, especially our adult skin dataset that I'm going to come back to. And when we do single-cell analysis, we do lose a spatial information because we dissociate the tissue, but we can use a spatial atlases to be able to combine them and sort of be able to put them back together and see where they were originally sitting in the skin. This is what we end up analyzing, about 190,000 cells across the different compartments. So each dot on this U map represents a single cell, and they are colored by the cell type. The broad categories are highlighted here, and there were 24 overall, spanning both immune and non-immune compartments. So what did we find? The first interesting finding was regarding the companion layer, which is traditionally considered to be part of the inner layers of the hair follicle, of the 7 inner layers of the hair follicle, and usually thought to be developing from the matrix, which sits at the bottom of the hair follicle. But what we actually found in our data was that this was transcriptionally more similar to the outer root sheet and also followed the same trajectory of development as the outer root sheet rather than the inner root sheet structures such as the cuticle cortex or other structure. And this has been suggested previously by this paper in 2017, which showed that even ablation of the placode and the sort of matrix cells actually resulted in still in formation of the companion layer without any significant abnormalities. And another paper studying mouse skin, which also found that the companion layer was more transcriptionally similar to the outer root sheet, but the companion layer did not actually cluster out in their dataset, and they were not able to do trajectory analysis. So this showed that compared to what was thought previously, the companion layer is actually transcriptionally more similar and developmentally more similar to the outer root sheet rather than inner root sheet structures. We also identified a cell state within the human developing skin that we call the predermal condensate. This has actually been identified in mouse skin only back in 2019. And as we know, we have FGF kind of informing the fibroblasts to form the dermal condensate, which eventually gives rise to the dermal papilla of the hair follicle. This originates from the fibroblast progenitors, but what they identified in the mouse paper was that there is a transition state sitting between the fibroblast and the dermal condensate, which are unclustered predermal condensate precursors. But this has not actually been previously identified in human skin itself, but it was present in our data set, and similar to what was found in mouse skin, this was also sitting between the early fibroblast progenitors and the dermal condensate and dermal papilla, similar to what has been previously described in mouse skin. And what was interesting along this trajectory is that we identify among the top genes expressed along this trajectory genes that have been shown to be implicated in GWAS studies in androgenetic alopecia. So as we know, this is a condition causing characteristic pattern of hair loss affecting the hairline and vertex, and it has been suggested that the priming of the hair follicles that are affected in androgenetic alopecia actually happens in utero itself, and this may be some of the genes implicated in this priming process, and they are usually involved in Wnt signaling and androgen receptor sensitivity. And if we look at the expression across the different cell types within our data set, both across the epidermal and dermal compartment, we can see that they are very specifically expressed within the dermal compartment, especially in the predermal condensate and dermal condensate, suggesting that this priming, if it's happening, is actually happening very early on during gestation. We also identify in our data set 2 subtypes of basal keratinocytes, both expressing high levels of keratin 5 and keratin 14, but one of them specifically characterized by the expression of periostin. And we wanted to look at what that meant for some conditions that are affected specifically by basal keratinocytes, such as epidermolysis bullosa. And we look at the expression again of the genes implicated in the different types, subtypes of EB across the epidermal and dermal cell types. Most of the genes were expressed in the epidermal compartment as expected. Expression was highest within the basal cell layers as expected, but actually expression was highest in the basal postin layers, especially for junctional and dystrophic EBs. And what that meant was that there is not only basal heterogeneity in terms of cell type, but the expression profile and potentially function within the skin. And a similar finding within a paper published from neonatal foreskin identified a similar basal postin positive cell type sitting preferentially or enriched around the dermal papilla protruding into the epidermis and less so within the rete ridges, suggesting that this may be some of the strongest points of anchorage within the skin. We also look at fibroblast differentiation, specifically with focus on scarring, because we know that fetal skin does not scar to some extent up to 24 weeks post-conception, compared to adult skin, which scars very easily. And we therefore wanted to look at what the differences were between fetal skin and adult skin. So we use here our previously published data set from adult healthy skin. And one of the striking findings was that the top genes that were differentially upregulated by adult skin compared to fetal skin actually related to immune activation genes, and several of those genes have also been implicated in fibrotic skin disorders and are perturbed in conditions such as systemic sclerosis. In comparison, the fetal fibroblasts upregulated genes that were involved in downregulation of the immune system. Several of those are actually exploited by cancer-associated fibroblasts to evade the immune system. And what this showed was that one of the factors that could be contributing to non-scarring potential of the fetal skin is that the fetal fibroblasts do not have an immune-activated signature as compared to adult skin. But we do know that this ability to not scar is actually lost beyond 24 weeks post-conception, and we therefore wanted to look at the fetal fibroblasts themselves and whether there were any intrinsic changes within them. And what we found was that, firstly, there are two types of fibroblasts, especially the fibroblast progenitors called HOXA5 positive fibroblasts, which are lost beyond in later gestation, so around 11 post-conception week. This is actually not present anymore. And within our major fibroblast cluster, which is the Win2+ fibroblast, the red bit shows enrichment in early gestation and the purple one enrichment in later gestation. And we can show that in terms of gene expression, specialized functions such as extracellular matrix organization and collagen deposition is actually happening later on in gestation beyond 13 or 14 weeks, and as opposed to earlier on in gestation where they're mainly involved in sort of core embryonic processes such as transcription and immune signaling. And what we also looked at was some of the roles of the immune cells within the skin, as to what are they doing apart from immune defense within the developing human. And we identify almost for the first time a microglia-like macrophage which is present in the skin. This has been only published in one of our previous data set, which spanned from a 7 to 10 post-consumption week. And basically, these macrophages are very much like microglia, and they have the same gene expression profile as microglia in the brain. They have been described in other developing organ systems, such as the gonads, but appear to be lost later on in gestation and in postnatal life. And we were therefore interested to find out what they were doing during development. And we performed gene ontology analysis, which suggested their implications in functions such as nerve development, akin to nerve-associated macrophages in the peripheral nervous system in mouse, as well as cell migration, such as very similar to microglia, but also implicated in regulation of the inflammatory response. And this is downregulation of IL-6 and downregulation of chemokine production. And this may further contribute to the fact that this sort of non-inflammatory environment or non-immune milieu that is present within developing skin, which may contribute to its non-scarring potential. Macrophages in our data set were also involved in angiogenesis, and this is not new information. We do know that macrophages are involved in angiogenesis in a variety of organ systems, and they were actually the highest producers of vascular endothelial growth factor within our data set. We identified them here present next to the vessels, co-localizing here, and actually there are several represented by the green dots next to the yellow ones on the bottom picture. And in our Visium spatial transcriptomic data set, here demonstrates anything greater than 0 or positively correlated that they're actually co-localizing. So you can see the different types of macrophages co-localizing specifically with what type of endothelial cells. So the TREM2 macrophages are mainly with the early endothelial cells and the arterial cells, and the other ones with the later cell types that are involved in vascular development. We also look at ILC3, and I interestingly found out that basically during early gestation, they appear to have a role in regulation of ECM formation, but later on, beyond 12 to 13 post-conception week, they're actually more implicated in epidermal differentiation, keratinocyte apoptosis and differentiation, which kind of relates back to psoriasis, which has been shown to be, can be generated in mouse models with just dysregulation of ILC3. And some of these processes that are in which ILC3 are implicated in fetal development may actually become dysregulated in psoriasis. And this just shows again that within our spatial data set, ILC3 was co-localizing with the early fibroblasts during this early gestation period. So this was just a way through some of our findings so far from our study. Basically, some of the new insights that we gained from in terms of hair follicle development, fibroblast differentiation, and the roles of immune cells within the skin beyond immune processes. And I would like to acknowledge everybody in the team who's been working and all our collaborators back in, at the Sanger Institute as well. And thank you. I'm happy to take any questions.
Any questions? Perhaps I could ask a question. Have you had the chance to compare murine and human data sets to really help us understand the differences from some of these earlier works?
Yeah, I think I skip on one other slide. There is one slide on fibroblast differentiation that is different, but there is a whole consortium trying to look at basically called mouse versus human, essentially, with Maria Kasper's lab back in Sweden, who's got the expertise in murine single-cell data set, and there is a plan to kind of do a whole comparison. I think the first step is to try to put all the human data sets together to kind of uniformize their annotations, which can be quite discrepant between data sets, and then progress on to mouse comparison.
Microphone 3 is a question.
Thanks, Huda. I've just got a clinical question. So if you show that, that actually it's a difference in the immune activation with scarring and healing, have there been clinical studies using topical immunosuppressants like tacrolimus or topical steroids in wound healing, sort of post-op and things like that? I just wondered if that might improve scar healing.
Not in terms of clinical studies that I am aware of, but it has definitely been shown in sort of mouse models and in vitro that downregulating the immune system or putting in the TREM2 macrophages, which kind of acts on one of the methods they do act is sort of downregulating this immune response, actually leads to non-scarring. So it's more been kind of in vitro and mouse model studies. I'm not aware of clinical.
Quite an interesting clinical study, wouldn't it? Not too tricky to do.
It depends how much you will need to kind of downregulate, how much immune suppression will need within that wound itself, because you do need an element of inflammatory response, I suppose, as a protection.
Then you've got the risk
yeah, exactly.
of infection, yeah.
Exactly.
Thank you.
Thank you.
Thank you. One final quick question as well. I think one of the areas of massively underexplored in dermatology is lymphatics and regulation of development of lymphatics. I noticed you had live 1 positive macrophages, but you didn't really mention whether you felt they co-associated with lymphatic development?
Yes, that's a very good question. Actually, there is about like 3/4 of the talk that I've not actually presented today, and there is a whole panel on endothelial cell and lymphatic development. And I think it was both the iron recycling macrophages, but a lot of the macrophages do associate very closely with lymphatics, but there is a whole other panel kind of dealing into endothelial cell development and those processes that I've not presented today.
Thank you very much.
So our final invited speaker is Professor Jayakar Thomas, who is the head of dermatology and director of research in Chennai. He's also the former national president of the Indian Association of Dermatologists. He's joining us via a pre-recorded presentation today.
Good morning, my dear friends and colleagues. At the very outset, I wish to thank the British Association of Dermatologists for giving me this wonderful opportunity to make a presentation in the Congress. I'm particularly thankful to Dr. Pio and Dr. Shahnaz Walton for introducing me into this project. I'm going to give a short presentation on hypertrichosis in children and what is the approach diagnosis as well as to some aspects of treatment. Now, it is important for us to understand the significance of diagnosing hypertrichosis because quite often it can be pointed to a multisystem disorder or pointed to a hereditary disorder and unexplained developmental delay. Here's a short study which was done during a 10-year course from Jan 2004 to December 2013, where more than 111,000 children were examined, and it was found that 2.3 of them had some form of hypertrichosis or other. And this is a pie chart which gives the different distribution of hypertrichosis with focal and diffuse, focal non-scarring or scarring, and diffuse non-scarring or scarring, apart from the acquired disorders and the genetic or congenital disorders. The approach will first start in this format: a detailed history taking, physical examination, microscopic examination of the hair, a thorough examination of scalp, skin, mucosa, teeth, nails, and relevant systemic examination. Of course, we have newer techniques such as videodermoscopy, trichoscopy, and contrast-enhanced photodiagram to aid in solving most of the clinical situations. Now, astute history taking and careful history taking is very, very important for us to differentiate mainly whether the hypertrichosis has been of sudden or insidious onset, and also to say whether it is associated with any other systemic anomalies which we could get usually from the parents. Because quite often you find that when you take the history, one will definitely be able to realize that there could be so much of underlying problems, including family history of hypertrichosis, autoimmune disorders, psychiatric disorders, and also getting to know the pattern of hair grooming practices. There is no substitute for clinical examination. There's no substitute for clinical examination, as you could see in this slide that is presented, where we should be able to make out whether there's any signs of inflammation or not, and also look for whether the anomaly starts off with the hair shaft or starts off with the hair root. And for that, we have two different methodologies of doing it, particularly examination of the hair at the age of the loss of hair, where it would be uneven, as you see in this, where it definitely means an hair shaft anomaly. There are two tests, of course, one what we call as a hair pull test, and the other which is the hair tuck test, which is very easy to perform, but nothing like a clinical observation where conditions like moneilethrix, as you see in this picture, or even pediculi, where you could get a cervical lymph node, and here you see the pediculus itself. Sometimes associated cutaneous findings like acneiform eruptions, along with hypertrichosis and acanthosis nigricans, may point to an endocrine disorder, particularly in young girls, to the possibility of polycystic ovary syndrome. This is what I told you about the hair tuck test and the hair pull test, wherein the hair tuck test helps in finding out whether there are any shaft anomalies, and the hair pull test where we could make out whether the anomaly is coming from the hair root. These are all simple tests which can be looked into, and apart from that, we do have diagnostic procedures, and definitely we want to rule out an infection, particularly fungal infection in the form of tinea capitis. Of course, other diagnostic procedures to rule out systemic disease, particularly thyroid disease, antinuclear antibody, and serum ferritin becomes very important. Although serology for syphilis is significant, but not all that important as what we told in the former tests. When we look at scarring alopecia, that's the only indication for a biopsy, because otherwise it's not really important for a biopsy to be taken for each and every case of hypertrichosis. Sometimes just a microscopic examination would help us to differentiate, particularly conditions like trichorexis invaginata, which we could come across in Netherton syndrome. As I had mentioned earlier, one should think of video dermoscopy, trichoscan, and contrast enhanced phototrichogram. Now I'll come to some descriptive cases where observation has really helped us. Look at this, a keratosis pilaris-like, but it's not keratosis pilaris alone. It's what we call as, because of the dry skin, ichthyosis follicularis. Ichthyosis follicularis, associated with alopecia and photophobia, as you can see the child. This is a case which I have seen in my outpatient, making a diagnosis of IFAP, that is ichthyosis follicularis with alopecia and photosensitivity. Here is another case where it's sparse hair, almost curly hair, but in addition to that, apart from this type of ectodermal dysplasia that we see in this child, look at the cleft palate as well as the ectrodactyly, popularly goes off as what we call as the EEC syndrome, or the ectrodactyly ectodermal dysplasia cleft palate syndrome. Colored hair, silvery hair particularly, there are three conditions one should think of when a silvery hair is seen. Griscelli syndrome is one, Chiediac-Higashi, and of course the third condition that one should definitely think of. Here, this is an example of Chiediac-Higashi syndrome and a Griscelli syndrome where clumps of pigment are seen within the hair shaft, better seen with a close-up view. That is Griscelli syndrome, which we had described earlier, along with lymphohistiocytosis. And this is very, very clear. One with enough clinical exposure will be able to diagnose these scales that are double-edged, and with trichorexis nodosa, trichorexis invaginata, where we clearly make a form of diagnosis for ichthyosis, that is your Netherton syndrome, the double-edged scale. The double-edged scale that we see in this Netherton syndrome associated with atopic dermatitis. This was a publication in the Turkish journal, which my colleagues and I made. Another case of silvery hair. Silvery hair, I told you earlier, Chiediac-Higashi syndrome is one thing which one should remember. This is a very, very interesting case where you find early aging. Early aging are where you get this type of loss of subcutaneous fat associated with loss of hair. This classical horse riding stance. Early aging, or Acheson-Gilford syndrome, also known as progeria. Just to give a break, nothing is perfect, nothing is ideal. We deal with probability and statistics only. We like to think that we have control, but the truth is that we don't. Here is a case of alopecia. One at first look think in terms of alopecia areata, right in the midline. Go on to examine the case, you find a port wine stain. Along with that port wine stain, you find that the breasts are far and wide apart, the nipples easily indicate that, and the teeth abnormality, and also the eye changes that we see, distance between the inner canthi, hyperpilarism. This is a case of Hallermann-Streiff syndrome, which again my colleagues and I have published in the Indian Journal. Stiff hair of this type are unformable hair, which is a frequent finding. The thing is, we must be able to catch these things earlier. And apart from the stiff, unformable hair, the possibility of this type of localized curling of the hair. Now, this is a woolly-haired nevus, again, which was seen in the outpatient department. Sometimes these cases of nevi, particularly sebaceous nevi or nevus sebaceous of Yadasan, could present as localized scouring alopecia. I told you about this curly hair, which is seen in siblings. You see it in siblings. Definitely the woolly-haired nevus, which we are able to give a cause as hereditary disorder. Now, to make it a little more simple, we could probably look at an algorithmic approach of hypertrichosis in children. We have to divide them into focal and diffuse. Focal, congenital. Think of congenital hypertrichosis or atrachia, and when there is ash-shaft anomalies, rule out Netherton syndrome, Menkes-Kinckey syndrome or monolithrix, and the wiry hair or pili torti. When it is acquired, history of prolonged illness, telogen effluvium is good enough for focal hairs. And the history of radiochemotherapy, one has to think of the possibility of focal hypertrichosis. Now, when it is diffuse, again we divide them into congenital and acquired. Under the congenital, we did see nevoid conditions like the nevus sebaceous of Yadasan. Sometimes an epidermal nevus can be seen, absent of overlying skin, as in the case of aplasia cutis congenita. Acquired conditions, alopecia areata with nail pits or exclamation point hairs, easily pluckable hair as what one could see in tinea capitis, and irregularly broken hair as what one could see in trichotillomania. So the practical points, my dear friends, which will help us really take away a few messages. There is a well-perceived need for hair clinics dedicated solely to the study of disorders causing hair loss. It's available in most parts of the world, but at least in my part of India, we do not have that. Also, one has to look at newer therapeutic armamentarium for alopecia areata, which is such a common condition, and we should start looking at it. Of course, now we have the JAK-STAT inhibitors, tofacitinib and baricitinib, which are found to be very, very useful in alopecia areata. Now, biologics and prostaglandin analogs. For a long time, we did use it in India, but now it's really lost its popularity, whether it is dexamethasone or bimatoprost, now found to be ineffective. N-acetylcysteine has been found useful in cases of trichotillomania. So given the opportunity to make this brief presentation on hypertrichosis and an approach to how one should go about in making a diagnosis and also in making a fairly safe practice in treatment of hypertrichosis. I once again thank the British Association of Dermatologists for being with me for this moment of time. A lot of counseling, a lot of hand-holding is required, particularly for the congenital alopecias. They remain a domain of orphan diseases, we call it. So more and more research to refine knowledge of genes controlling the differentiation of hair follicles is likely to develop treatment breakthrough such as gene therapy. With that, it's time for me to say thank you to all the listeners, to all the viewers, and also to the British Academy of Dermatology, British Association of Dermatology, including my good friends Shahnas Walton and Pierre Battlefield. Thank you once again. Enjoy the rest of the conference.
I'm afraid Professor Thomas isn't able to join us live, and apologies for the video and audio on that presentation. So just one final comment, if that's all right, from the BSMD.
Yeah, thank you. Just to give you a quick pre-warning, if you haven't seen it already, on the BAD website, please look for the Advanced Medical Dermatology Therapeutics meeting we're having, October the 12th and 13th, that's Wednesday and Thursday, the Royal College in London. It's a fantastic meeting. We've got speakers from all around the world, and if you came on the previous one, you'll know we focus on therapy. Obviously, it's medical dermatology, so anyone who's doing medical dermatology, it's really aimed at consultant level, but we welcome all levels. But it's a really excellent meeting, and we've got quite a lot of places taken already. So if you're interested in that area, please look at the BAD website. Thank you.
Thank you very much.
Good afternoon. How you doing?
Well, thanks to you. I do. I just need to put the code in. Okay, it says clicker muted, but I think I'm in the right place. Okay, great, yeah. 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 Oh, yeah, okay, great. That's it. Cool. Oh, that's super easy. Yeah, great. I don't see the auditorium when I'm presenting, do I? Just this. Okay, fine. And tomorrow morning, do I join at the start of the session into this? Okay, is it the same link, or this is just for the tech rehearsal? Okay, fine, great. Okay, and then at the end of my presentation, do I stay for the questions and then leave, or do I stay, or what's the? Okay, and stay around. Yeah, that'd be okay. Great. Cheers. Thanks very much. All right. Cheers. Bye.
I'm Pew Banerjee, consultant dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I'm a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day and I'm grateful that I've just completed the month of Ramadan.
Hi,
am Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
I'm a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free Rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
Good afternoon, everybody. I'm Chris Bauer and I'm joined by Brian McDonald. We're here to co-chair this afternoon's plenary session. Now, I'm not going to be able to introduce anybody because my glasses went missing in a karaoke bar somewhere in Glasgow last night, so it serves me right. There is a change to the first talk was going to be the best dermatology team of the year. Now, James Powell from Wye Valley won the award, the BMJ award for the best dermatology team of the year. He was originally double booked and had to give another presentation. So, James, I think if you come up first and give your presentation now, because there has been a change and he can present, because I was there with a B team presentation as one of the runners-up, but you need to hear from the winner himself. So, James is going to come up and present his team's performance.
It's not a joke. to James's slides, which were the couple that you were given late on.
So thank you very much for having me, and I'm going to keep it short because my voice may pack in at any minute. So thank you for having me. It's nice to see some of the Hereford team here. If you'd just like to put your hands up and say hi. There they are. Not everyone's made it from Hereford, unfortunately, but I've just got a few slides, which are really the slides which we gave to the BMJ judging panel regarding our response to COVID, which we called parry and riposte. And I'm glad to say Sammy's here, who is also presented with alongside me at that awards and judging session. But of course, it was the whole team who put in the effort to be awarded this in the end. So we really just introduced who we were and where we'd come from. We explained what we meant by the parry and the riposte, and I aimed really to introduce the whole team because it really was a huge team effort. Yes, we've got, of course, dedicated dermatologists and dermatology doctors, nursing, HCA, and our admin team who worked incredibly hard over that time. But it is odd looking at this picture now because the point of difference, I would say, compared to other teams which I might have worked as a part of, as a registrar and a consultant, the real point of difference were the management team. I was perhaps used not to seeing the managers on the shop floor in the department, but our managers, who you can see at the bottom there, are there almost every day, whether we liked it or not. And when the COVID pandemic hit, they were really responsive to ideas about how we could break through that COVID barrier which had come up, and how we could still deliver our services. Again, it is quite disconcerting looking at that picture of the team because all of those management personnel have now moved on, either away for health reasons or have moved jobs or been promoted. So it just shows how you can have a very successful year with a successful team, but how quickly things can change and how you need to really reset and carry on and not get complacent, I suppose. I went over how we set up a teledermatology service essentially from scratch, which soon became very popular locally, with us seeing now 400 to 500 cases per month on the teledermatology platform. We managed to maintain our outpatient activity through a number of ways, but including carrying on our surgical procedures, our MOPs, and having a significant amount of virtual appointments. We had the funding to get equipment to GP surgeries so that they could take part properly in the teledermatology and send us not just photos but dermatoscopic images as well. And finally, at the your bottom right, what I called then an inpatient remote review SHO-led service, which I actually now know properly to be called inpatient teledermatology service, was set up with our GP VTS. And that's actually what I'm giving a presentation on next, if my voice holds out, in the teledermatology symposium. We work with the management to move our whole department really into new facilities with brand new surgical rooms and outpatient facilities, and having our offices above those rooms. And I do think COVID was the catalyst which enabled us to get the funding to do that and to get it done in record-breaking time. I think everyone's estimates of how long it would take were 5 years, and it was done in about 6 months. So really proud of what we've done in Hereford, really proud of how we all work together. Yes, dedicated doctors, nurses, an admin team, but I think that is a given really. Especially in a room full of dermatology doctors. I won't want to say we were any more dedicated or skilled than anyone else, but we really did manage to pull together to achieve a lot. And as I say, the relationships which we have with management can be very difficult, but we were lucky over that time that we had a group of managers who were interested in our thoughts and were prepared to back us up with their time and money, essentially. Thanks.
Thanks, James. Do we have any questions about James and the team, their award? I'd just like to ask, which of those innovations that you brought in do you value the most? Which have you kept as the number one?
Well, I think teledermatology is the one which we've set up and now is becoming more and more relevant and important, but also more and more of a headache. Like, I think everyone's teledermatology services, there's excellent things about it and also difficult things about it which they bring. And it was good to be in the telederm symposium this morning to hear other people coming up with the same sort of problems and concerns. But
okay, well, thank you very much. Thanks. So I had prepared a B-team presentation, which I will just flash through very quickly because we do have another 8 minutes available. So if you could put up the other one. I won't dwell on a lot of the slides because I don't want to run over time. So this was our entry to the BMJ Awards, and we were not successful. James and the Wye Valley team were the successful team, so this is very much the B-team performance. But I was told to be a fluffer, a gap filler, and so that's what I'll do. So this was set up with, alongside our senior nurse practitioner, Claire Parkinson, who was really the driver behind this. So we're from down in Exeter, and in Exeter, we've got an older than average population. The average age is higher than the UK average. We've got a predominantly white population. So as a consequence, we have an awful lot of skin cancer. If you look at the chart on the top right, our GPs are pretty good at what they refer. We've got a 14% conversion rate of 2-week wait, which is the highest in the country. So they don't send us rubbish, they send us appropriate things. It's just the cancer rates are so high. This is showing 2-week wait referral data in the southwest, and those numbers are continuing to rise. And like many places, we've just broken records, and for a population of 350,000, we're hitting over 1,000 2-week wait referrals a month now. Since I arrived in the department in 2001, we've audited regularly our BCC excisions, and the numbers that we've done have gone up. We're taking work away perhaps from the surgeons and less being done in GP after the NICE guidelines came out. And we do it pretty well. Our excision rate is, our complete excision rate is high. When I arrived, we started working with one of our nurses who did a lot of surgery, did biopsies and curettes, and I'm sure that happens in other parts of the country as well. And we've seen our day case activity continuously rise, and I'm sure, again, this is paralleled around the country. What we found was that there was so much skin cancer, so much surgery to do. We were the victims of our own success in so much as everyone had a list. Our pediatric dermatologist had a surgical list. All of our trainees had surgical lists. Everyone had surgical lists, and it then became quite difficult. If you're delivering training, actually, they don't need to be doing so much surgery. So we needed other people to be doing surgery. We had GPs coming in to do it, but we looked at the nursing workforce and thought, well, this is an obvious example of something we could expand. And Claire had been doing this for a while, and then she took it on to do more and more of it. And if we look at the proportion treated by nurses over that period of 2013 to 15, we went up from about 2% to a quarter of the work, the surgical work being done by the nurses, and it allowed us to do more and more same-day treatment. The trouble is we were running out of physical space. Claire by now was operating at a level where she could perform small flaps, she could perform large excisions anywhere on the body. She was performing surgery at a level higher than most of our consultant colleagues. And we decided she was competent enough, safe enough to operate independently out in the community. So we're based in Exeter, but she started doing lists independently in some community hospitals, not always supported by consultant colleagues. So she was doing this with remote support. And it was aided by the fact we've got electronic records, EPIC, so she could send in a message to the on-call person, the on-call consultant, to say, look, this is what I've got, this is what I'm planning to do, and we talked through it. So we were offering remote support, and it's what electronic records allow us to do. There were challenges. I mean, the IT interface was difficult, particularly when we were working in neighbouring trusts. It was difficult. We had to get all the kit together to go out. It wasn't available in the community setting, and we had to train the personnel up locally to help out. Claire has gone on from this work, and she runs a course, an annual course that's been running for 10 years, training other nurses around the country in all these aspects of skin surgery. And also offering an advanced surgery course as well for GPs in the local area and for other nurse operators. There have been lots of benefits and spin-offs in terms of offering patients with wound complications and removal of sutures and other general dermatological issues can pop in when she is operating out in the community setting. We had patient involvement. They were very positive about it, and they love the fact that they don't have to drive far. And a lot of our patients are elderly, and so being able to be treated close to home was really important to them. And there, lots of examples of good practice, particularly during COVID and the need to keep people away from the main hospital. So the nurse surgery evolved. Not only now has Claire been doing it, but we've been training up the next generation of nurse surgeons. And I feel this has been a great way of, when we were here yesterday at the AGM, we were talking about workforce, we were talking about how we address problems of the future. And I feel this is an underused resource. Our nursing colleagues that we work with doing this surgery are absolutely fantastic. And we've got Claire operating up to level 4, occasionally level 5, one of the other nurses at level 4, and we've got 2 other nurses who are moving their way up through this hierarchy. We assess them through DOPS, and they're fully supported. They keep a surgical logbook. This is the one created by Adam Bray, available on the BSDS website. And so if we audited Claire's results from this community service over a 6-month period during COVID, she'd carried out 530 procedures. That's 400 hours of operating that would otherwise fall on a doctor, probably, who I feel is better served doing triage of complex medical and surgical dermatology, rather than spending a lot of time doing this type of surgery. And Claire does it exceptionally well. Her incomplete excision rates are very good, and she participates in audit. And this sort of mirrors what Gerft has been recommending that we need to be doing, which is focusing on areas like pharmacists and nurses to deliver services in different ways, rather than relying on traditional models of providing dermatology services. And this is the progression planning that we've got with our different Band 5s. And if any of you have any questions about this, then please get in touch with me, chris.bauer1@nhs.net, and I'd be happy to share our model. So in conclusion, nurse surgeons, I feel, are a potential solution to help with the UK dermatology workforce crisis, and I think the community location and independent working frees up space and time for training of other people who need that closer supervision. Once you've got somebody up to a high level, then really it does free up space back at base. So thank you very much.
Thanks very much, Chris. Does anybody have one quick question for Chris? No? I think we've heard two very inspirational talks there about how we can change our services to meet the changing demands for dermatology. And I'm really intrigued about getting nurses trained up to do Mohs surgery in your slide. I'd like to hear how that progresses. So next, we'll move on to Dr. Suha Towik, who's going to come and speak to us today about carbonylated proteins, the marker of oxidative stress, and the association with the filaggrin genotype in atopic eczema.
Thank you for the introduction. Good afternoon, everyone. As we all know, the loss of function mutation of filaggrin is the commonest genetic risk factor in atopic eczema. However, they do not account for all of the cases, and there is a strong influence for the secondary environmental triggers such as allergens, oxidants, and pollutants. I'd like to give a little background about oxidative stress and its effect on skin proteins. What happens is there is formation of carbonated proteins, which are aldehyde and ketone groups that form on protein side chains, leading to its dysfunction. These represent general markers of oxidation because they are very stable and they are very early to occur during oxidation, enabling us to measure them. But also they are present in very high basal concentrations, especially on the skin. What do we know of them? We know that they are attached to mostly keratins and other barrier proteins and dermal proteins, and they are either oxidant-specific or results from general oxidation by pollutants, whether these pollutants are primary pollutants such as fine or coarse particulate matter from combustion fuel, or secondary pollutants such as ozone. And they are usually present, and it has been reported before that they are present in a descending gradient from the epidermis down to the dermis, and usually present in higher concentration in inflamed skin, such as atopic skin and psoriatic skin. And also, they are associated with decreased skin hydration, more reactive oxygen species production, and more inflammation in the skin. Now, moving on to atopic eczema in the Bangladeshi population. It has been noted that in this specific ethnic group, there is quite high incidence among the infants, and usually they suffer from severe phenotype together with recurrent eczema herpeticum, and they have known enrichment and variation in filaggrin mutations. And this led to Tower Hamlet Eczema Assessment Study, which is a large study led by Professor Edel O'Toole in East London, aiming at studying and investigating the genotype-phenotype interaction and the effect of environmental pollutants on eczema in the Bangladeshi. So far, we have recruited 700 patients and 100 ethnic group matched controls. This is how our THEA workflow goes. We recruit patients with a confirmed diagnosis of atopic eczema with an age range of 0 to 30 years old, and they have to be of Bangladeshi origin. There are two types of samples that we take from patients: buccal swabs for the DNA extraction and the filaggrin genotyping, and skein tip strips from which I extract proteins and then investigate 3 proteins of interest by Western blotting, the carbonated proteins as markers of oxidation, and 2 barrier proteins, the filaggrin and the cytokeratin 10.
Why did we choose the skin tape strips? Obviously, they are less invasive compared to biopsy. We sample a non-lesionless skin site on the volar aspect of the forearm, and we take successive 9 tape strips, and this enables us to reach the level of the stratum granulosum, making them a good sampling method for assessment of any barrier protein or superficially expressed protein in the skin. Now I'll be discussing some of my results from the tape strips. Because the processing of the tape strips is quite laborious, I managed to extract proteins from 51 patients and 10 ethnic group matched controls without prior history or without prior family history of atopy. And we do have all the filaggrin genotype for the patient except for 2 patients, and we do have some variation in our cohort with wild type, heterozygous, compound heterozygous, and homozygous patients. To start off, what is the volume or the amount of protein that we harvest from these tape strips? It's definitely significantly higher from the skin of controls compared to patient skin. And this could be explained by 2 factors. First of all, the thinner epidermis and the less amount of insoluble proteins that's present in atopic skin, but also the discohesive corneocytes fail to adhere to the surface of the tape strips. In terms of our proteins of interest, we hypothesized that the carbon-related proteins, as reported in previous studies, would be elevated in patients. However, filaggrin and cytokeratin 10 would be reduced in our patients. But this wasn't the case, and there wasn't any significant difference in our patients versus controls. However, when we started subdividing our patients by the filaggrin genotype status, we started to see some differences, where there was a significantly increased concentration of carbon-related proteins in patients who have biallelic mutations, as you can see in the upper image of the Western blot, compared to wild-type patients or heterozygous patients. And this could be explained that biallelic filaggrin patients usually have a severe phenotype, and our data suggests that they might be more prone to oxidative stress. What about the filaggrin? So our data also showed, interestingly, that there was a significantly higher level of filaggrin dimer in patients with biallelic mutation compared to patients carrying only 1 mutation or to wild-type patients and controls. So this may suggest that not only there is a defect with the formation of filaggrin, but also there is a defect with the filaggrin processing with the accumulation of such filaggrin dimer. So to conclude, we do get less amount of protein in atopic skin on the surface of these tape strips. That there is also a significant increased level of carbon-related proteins in patients with biallelic mutations, suggesting that they are more prone to oxidative stress. And our data also suggests that there is definitely a defect with the filaggrin processing with the accumulation of the filaggrin dimer that we assume that is not a functional filaggrin. Now I'll be giving you a little background about my ongoing work, and this has been based on the results of my colleague, Dr. Bjorn Thomas. So these are also some of the aims of the THEA project, where he did statistical modeling of all the pollution data gathered from stations across central and east London. And he did find that the prolonged exposure to low levels of ozone was in fact the most important associating factor with eczema severity. And this became quite evident during the COVID pandemic, when the ozone levels went high. So we decided to take this further into the lab, and we started exposing immortalized keratinocyte cell lines to low levels of ozone. Most of the studies out there usually exposed to levels of ozone of 100 parts per billion or 400 parts per billion, which are known to be toxic levels of ozone. However, we decided to go for an average of 70 to 80 parts per billion and compare this to cells exposed to pure air. And we're investigating 2 pollution pathways reported previously in literature, JAK-STAT pathway, the aryl hydrocarbon receptor and artemin pathway, and also the oxidative stress resulting from such exposure. So we expose our cells over for 1 hour daily for 5 days, and then we allow the cells to regrow for 2 days and then restart the exposure, and this is done over a period of 3 weeks. And we're starting to see very interesting results, like you see in these staining images, with the activation of the phospho-STAT3 only after 3 exposures to ozone of 70 to 80 parts per billion. And this also becomes quite evident at the protein level with the phosphorylation of the phospho-STAT3 and activation of phospho-STAT3 in the nuclear cell lysates, as well as in the cellular lysates, the whole cell lysates, after a total exposure of 10 exposures. So these preliminary data might suggest that ozone, which is often overlooked in pollution studies in eczema, might have an important role in the JAK-STAT activation in atopic eczema. And we're hoping to validate this further in 3D cultures. Finally, I would like to thank my supervisors, Professor Ida O'Toole and Dr. Ryan O'Shaughnessy, all of the members of O'Toole Cayley Lab, all of the Blizzard staff. Thank you for listening, and I'm ready to take any questions.
Thank you very much. Do we have any questions? Are we all going to move away from high pollution areas? No?
Yeah.
Thank you very much.
Thank you.
So we're going to move on then to Dr. Brigitte van Bodegraven. Hopefully the slides will be coming up now for you. We're a little bit early, so give us a minute or two till we get these up. And she's going to be speaking about skin tumours in England 2013 to 19, in-depth reporting of new consensus classification to improve prospective data extraction and clinical interpretation.
Good afternoon. I am Dr. Brigitte van Bodegraven, and this talk is about the development of a new Get Data Out partition, which provides new statistics on skin tumors, including skin cancer and in situ tumors, diagnosed between 2013 and 2019 in England. I am an employee of the BAD, and I am embedded within the National Disease Registry Service, NDRS. NDRS collects and analyzes data on patients diagnosed with cancer, congenital anomalies, and rare diseases in England. The source of this data is the patient's journey through the NHS, and the data is collated and quality assured by staff at NDRS. It is linked with further data sets, such as the patient administration system, MDT outcomes, treatment data from SACT and RTDS databases, as well as hospital episode statistics. This data is then used to provide the annual cancer statistics and other routine publications, but it can be used for research as well. So the routine publications that are published on skin cancer are generally limited to two types. We have melanoma and non-melanoma skin cancer. And the non-melanoma publications have generally been limited with their quality. They contain less information, or they are limited to just the first tumor ever diagnosed in a patient. But the way that NDRS processes its data, it means that they have more informative data available. At this time, you won't be able to find specific data on tumor types. There's no routine publications on basal cell carcinoma or Merkel cell carcinoma or any rare tumor types. We did this project in order to provide that data. So Get Data Out is an NDRS program which aims to provide statistics on groups of similar cancer patients, and it provides statistics such as incidence, survival, and treatment. We worked collaboratively with a group of clinicians, dermatologists, pathologists, and oncologists to create a specific skin tumor partition following that framework. So we started with identifying all tumors that had skin topographical codes based on ICD-10 coding, and those with relevant behavior and morphology codes based on ICD-03 coding. We then grouped tumors together in an iterative process, using tumor information such as the stage of diagnosis, the tumor type, as well as patient information such as their age, their sex, and their geographic location. This then created a tree-like structure, and statistics are published on each group. At the primary level, we split skin tumors into skin cancer, melanoma in situ, extramammary pageants, and tumors of uncertain malignant potential. Skin cancer is then split further into keratinocyte cancer, melanoma, and rare. Keratinocyte cancer is split further into BCC and SCC. Using all of the information that's available within a database, we continued splitting tumors using this information. This here shows the continuing of melanoma of that initial tree, splitting by genital versus non-genital, common presentation, acrolentigious, age, and stage. The aim was to continue splitting groups until it contained approximately 100 patients, although this does differ a lot by tumor type. Three statistics were published as part of this first release, and the first one is incidence. So what we see when we're looking at incidence is that both the crude counts of skin tumors as well as skin cancer have been increasing over the time period. And the incidence rates are also very high and have been increasing. Now, some of this might be due to better registration practices, but that remains a worry, mostly for workforce planning. Just some highlights. There are 1,800 rare tumors diagnosed each year, of which 500 are ependymoid nexal tumors. There are 1,500 genital SCCs, 100 cases of extramammary Paget disease, and 120 cases of melanoma in under 25-year-olds. Without this data, it would be quite unclear to know exactly the statistics at a national level. The second statistic is survival, and I'm showing you here 5-year survival, although there are other time estimates available in the output, such as 1-year survival. What we see here is that the survival differs a lot by tumor types. We have BCC and melanoma in situ with excellent survival above 99%, and at the very opposite side, as you may all very well know, melanoma at late stage with much poorer survival. But just to highlight some interesting things here, SCC has a 5-year survival between 80 and 89%, and the rare group overall between 70 and 79. The last statistic is called routes to diagnosis. And what this is aimed to do is categorize each of those tumors through their referral route. So whether or not they were a 2-week wait referral, that they can come through GP, through an emergency presentation, inpatient, outpatient, or elective. And when we're looking at the outputs here, we see that melanoma had the highest percentage of 2-week wait referrals. We see patients with the same tumor type at the same location that are older have less 2-week wait referrals than their younger counterparts. Women with congenital SCC have higher 2-week wait and GP referrals than men with that same tumor type. Acrolentigious melanoma have fewer 2-week wait referrals than common melanoma. And I know you see many BCCs through your clinics, but only approximately 1% come to the 2-week wait pathway. There is a high percentage of unknown through this, where we weren't able to categorize that tumor to a route. That might be because they are private referrals, or it could just be a data quality issue. So this release happened Get Data Out was released on the 25th of April, and it is publicly available on the Cancer Data NHS website. This is the first time that statistics have been published on precancerous lesions and on the rarer types of common cancers, such as the cancer in the under 25-year-olds and the genital tumors. So as I said, the data is available on Cancer Data NHS website. I'll just quickly show you what that looks like. So Get Data Out is included here under Detailed Statistics. If you click on that, this page opens. And here you can see all the cancer sites that have gone through this process. I heard some talks yesterday about Kaposi sarcoma. That's also included here. And there will be a new hematological partition, which includes lymphomas, also the cutaneous ones, in the near future. To view the interactive tree, you can click on skin tumors, and you can download the data for yourself by clicking the icon on the right. This then downloads and opens a CSV, which you can open in Excel. You can then use Excel to filter and find specific statistics or tumor types that you're interested in. The data is available for each individual year between 2013 and 2019, as well as for rolling 3-year periods. I'd like to thank the Get Data Out work group for providing their expertise and knowledge, which has allowed us to make this partition. I'd like to thank the additional staff from both NDRS and BAD for providing project support, and the BAD NDRS Steering Committee for providing overall support as well. Just to summarize, Get Data Out Skin will provide detailed statistics on all English skin tumours going forward. This data is publicly available and will be routinely updated. The next update should be either later this year or very early next year, and contain 2020 incidents, so the first COVID year, as well as treatment and survival data. This data can be used by clinicians, by the public and commissioners and researchers as well. It can provide the basis for identifying trends in the data as well as anomalies, and for identifying new research questions. I'd like to just say that the following two presentations are examples of where NDRS data has been used for research, where a question was developed collaboratively and a project plan was delivered, which allowed these early career researchers to gain data. Thank you for your attention.
Thank you. Do we have any questions for Dr. Van Bodegraaf? I was a little surprised by the data there about only 1% of the VCCs came through the 2-week wait.
Yes.
Did that surprise you?
I'm not a clinician, so I don't know, but our chair, Zoe, is. And she tells me that she was a little bit surprised by that.
Yeah, I mean, certainly in clinic it feels like we're seeing a lot more than that, doesn't it? But I guess if you look proportionally, you know, we see 160,000 VCCs a year, and if it's 1% of that, then it still is a large number, isn't it, going down the 2-week wait pathway. Additionally, though, I mean, Brigitte said there was a high proportion of unknown pathways, and unfortunately that was about 10 to 15%, so we don't really know how many are getting lost in that unknown statistic, unfortunately, so it might be higher than that. But yeah, certainly that was interesting to see. And the other thing that was interesting from the 2-week wait pathways was that all of those skin cancers that had the worst outcomes, so things like acral lentiginous melanoma compared to the common melanoma, or genital SCCs compared to a normal site SCC, they were all less likely to go down the 2-week wait pathway as well, which was quite interesting to see.
Because traditionally gathering this sort of data has been very unreliable.
Yeah, and that's why we need to get this data out, because actually it's pretty good now. You know, we've got good quality data, and the Cancer Registry has been storing it up and not really publishing on it. And now we've developed this website called Get Data Out for that reason, to make sure that, you know, people realise that actually we've got good quality data on a huge range of skin cancers, not just melanoma and non-melanoma skin cancer. And so hopefully you can see the data we've got available, develop your own project ideas, and use the data.
We have some questions.
Hi, George Coltop from Southampton.
Hello.
When you're looking at the subdivisions of SCC and VCC, can you be confident that you're looking at invasive disease rather than Bowen's or superficial VCCs?
So all tumours are registered by NDRS based on pathology reports. So they do it based on ICD-03 coding, so anything that's in that book will be able to be registered. But there is a limitation there. A BCC that's treated through different means and not excised, we wouldn't know about, and that's not included in this data.
I'll add to that, precancerous SCC, so in situ SCC, is not registerable, so we don't collect data on that. I did do a validation, because BCCs and SCCs are auto-processed, so I did do a validation, so I reviewed 1,000 pathology reports for SCCs and 1,000 pathology reports for BCCs, and actually the auto-processor worked really well, and I think it only picked up less than 1% were incorrect diagnoses, actually, so we've got good data, we're happy with that.
Kate Otto, London. I just wanted to congratulate you, Brigitte, on this. I think as we move towards population-based commissioning, this is absolutely vital data to get in order for workforce planning and just making sure that we have the right dermatology departments and availability, if you like, for actually managing this skin cancer data, because up until this work, really, there was no sensible data, and NHS England was completely unaware of how many skin cancers there were and what the distribution around the country was. So, fantastic. Yes. Thank you.
Any other questions?
Another question.
Oh, hi. It's Dr. Varma, one of the derm surgeon. I just have a very brief question. Many of us are seeing an increase in the skin cancer in UK. This is largely also driven by the fact that a lot of our public and the teenagers are influenced by looking tan, especially in the Love Islands program. My question is, what is our stand in terms of public campaign and education from BAD point of view? Because certainly it's going to be an explosive skin cancer. Along with the melatonin usage is widely available, 25 pounds for a bottle for sublingual use or injectable. And the second thing is, are we collecting any data from our BAD research? Because this is quite relevant to our future planning. Right, thank you.
So that's probably not a fair question for you, Birgitte, but...
But I agree, dissemination of this information and public awareness campaigns for skin cancer in young individuals and the wearing of sunscreen is very important. And I'm sure the BAD could be doing a little bit more on that. Your second question, I've forgotten, I'm terribly sorry.
Yeah, I was just going to comment that actually our next project that Birgitte is going to be doing is looking at skin cancer in the under 25 age group and looking at trends over time actually. So hopefully that will give you a bit more information about young people with skin cancer and because those are the patients that are high risk as a result of the tanning booths and increased sun exposure. So it'd be really interesting to explore that data further. So we do have that in mind as well. With regards to public awareness campaigns, our as a BAD NDRS partnership, we're all about getting the data out there, making sure people are aware of the data, and we're not so involved in the public awareness campaigns, but hopefully our data can be used to fuel that and to highlight those issues.
I mean, the BAD have a very active campaign, and there's lots of online resources. I mean, recently on that incredibly hot Friday, we tried to get out a press release about, about Friday, FRY, about sun protection, but if it's not a newsworthy item, the trouble is it's dictated by the interest of the press, really. But there's lots of resources on there for patients, and one of the ones I find particularly useful is we know that patients who get skin cancer have a tendency to get lots and lots and lots. So, so that resource, the patient information leaflet on how to reduce risk is very helpful.
Yeah, just to add to that, actually, so part of the Get Data release, we did develop a media release with BAD comms team, and actually it was really well received, and it was included in 40 different media outlets and 7 national newspapers. So we are trying to get the comms team on board as well with this data.
We just need to keep pushing.
Yeah.
I've got one question. We've talked about sun in relation to this, and obviously we're getting the data, but what struck me was the amount of genital SCC, and that's. Do we need to be doing more for prevention? What are your thoughts on that?
Sorry, I can't hear you very well.
Genital SCC, they're quite a significant number that you find. Do we need to do more to try and prevent and to pick these up in a pre-invasive state?
Yeah, the genital tumors are quite interesting because they're not generally included in the definition of skin. So we've expanded our definition and included them. And they're a site which I imagine comes with a bit of embarrassment having to visit your doctor about. And that may lead to some delays in diagnosis. So I think we can do a little bit more about that. And just highlighting how many there are is the first step there. But it's definitely in our list of potential future projects to explore further.
Yeah, it's really interesting data, isn't it, Birgitte? And then you've got the whole HPV factor there, haven't you, in the vaccine and how that's going to influence these cancers in the future. So yeah, really interesting and interesting to see that they've got such a worse survival. And I think sometimes that these are often tumours that fall through the gaps. So do they go down the urology or gynecology route, or do they go down the skin 2-week wait referral? And we're probably not very good at collaborating and making those decisions together.
Final question.
Oh yes, Nick Lever. Yep. I was just going to respond to Kim's question, a really good question about the ongoing use of sunbeds and tanning salons. But of course, you have a BAD comms team, have done a lot of work in the past, I know, on this, and I think we're probably instrumental in getting the legislation passed, which was supposed to restrict use of tanning salons for younger people. But I totally agree it is an area which needs to be readdressed now with the Love Island phenomenon.
Thanks very much for that, Nick. Thanks, Brigitte.
Thank you.
So we've had one really great presentation looking at the cancer data. We're going to drill down a bit more and look at porocarcinomas, and I'd ask Mr. Jilsi Joshi to come and present to us.
So, hello everyone, my name is Jules. I'm an intercalating medical student from the University of East Anglia, and today I'm really excited to share the results of our study looking at the epidemiology of porocarcinoma. I have no conflicts of interest to declare. These are the conflicts of interest of the co-authors, and this research received no external funding. So porocarcinoma is a rare type of non-melanoma skin cancer. There are very few studies on its epidemiology, and the ones that do exist have reported an incidence of 0.04 to 0.06 per 100,000 person years. A 2017 systematic review found that the mean age at diagnosis was 68, and the commonly affected sites were the head and feet. Porocarcinoma is a really difficult diagnosis to make due to its variable presentation, consisting of a dome-shaped papule, macule, nodule, plaque, which can be erythematous, villaceous, or skin-colored. The histological features can be difficult to differentiate between other skin cancers, and currently there's no set immunohistochemical diagnostic criteria for this condition. There's also no standard protocol for treatment and no recommendations on management, and recurrence rates of 20 to 35% have been reported after surgery. So what we aimed to do with this study was to report the number of people in England diagnosed with porocarcinoma between 2013 and 2018. We hope to calculate European age standardized rates using the European standard population in 2013, and we aim to analyze the survival data to produce a Kaplan-Meier curve. So anonymized patient data was extracted from the National Disease Registration Service's National Cancer Registry. Relevant information for these codes are routinely collected from pathology reports and cancer services and outcomes datasets. We use statistical software to calculate the age standardized rates and to produce the Kaplan-Meier curve. So there was a total of 738 people in England diagnosed with porocarcinoma from 2013 to 2018. In 5%, ethnicity was unknown, and of those we knew the ethnicity of, 96% were white. This graph shows the age at diagnosis of our cohort, and as you can see, incidence increased with age. We found a median age at diagnosis of 82 years of age, and this was much higher than previously reported from the systematic review I mentioned earlier, which reported a mean age at 68 years of age. This diagram on the right shows that the lower limbs were the most frequently affected body site, followed by the face. These two graphs show the annual trend in European age standardized rate of porocarcinoma. Age standardized rate is a summary measure which takes into account the age structure of a population at a certain time or at a particular location. It's really useful because we can make reliable comparisons between incidences of conditions between different time periods and different locations. As you can see from the green line, the overall trend in incidence for porocarcinoma for the whole cohort was generally stable with a slight decrease in 2018. Throughout the whole study period, we found the European age standardized rate to be 0.25 per 100 person years. And this is much higher than previously estimated of just 0.04 to 0.06 per 100 person years. This map of England has been split into different regions by grouped cancer alliances. And as you can see, the region with the most highest incidence of oral carcinoma was the east of England, and the least was the southwest. So from this study alone, we're not too sure what might be causing this large regional variation in incidence, but we think it might be due to differences in pathology lab reporting or how the oral carcinomas may be being diagnosed. As I said before, there's no set diagnostic immunohistochemical criteria for this condition, and this warrants further research in this field and in this area. So this slide summarizes our biopsy and treatment data. We only had procedural codes linked and identified for 85% of our cohort. And of these, the table on the right shows the breakdown of the different type of biopsies and surgical treatments that the cohort received. It's important to note that some patients received more than one type of biopsy or treatment, and therefore that's why the numbers are higher than the total of 738 patients in our cohort. The majority received excision, with 9% requiring re-excision, and it was interesting to note that only 1.5% of patients received Mohs micrographic surgery, and we think this might be due to varying service provisions of this type of surgery across England. This slide summarizes our survival data. As you can see, this is a Kaplan-Meier curve showing the survival of males and females in our cohort. 53 months after diagnosis of oral carcinoma, the overall Kaplan-Meier survival for the whole cohort was 50%. And after doing Cox proportional regression analysis, we found no statistically significant differences in the survival between males and females in our cohort. We also report a 5-year overall survival rate of just 45%. This suggests that oral carcinoma could potentially be an aggressive condition with a poor prognosis. So this was the first ever national epidemiology review of oral carcinoma in England, using the largest case series of data with the help of Birgitta. It was, as I mentioned before, it's unclear why there might be such a large regional variation, and so hopefully more research can be done in looking into a potential diagnosis discrepancy of oral carcinoma due to the lack of histochemical markers for it. And also it's important to note that the treatment data wasn't directly linked to oral carcinoma, so some of our treatment data included procedures patients may have had for coincidental tumors at the same time, and this is obviously a potential source of bias in our study. In summary, we reported a European age standardized rate of 0.25 per 100,000 person years for those diagnosed with oral carcinoma in England between 2013 and 2018. We found the median age at diagnosis to be 82, and the most frequently affected site to be the lower limbs. And finally, reported an overall 5-year survival rate of just 45%. These are my references. And I just want to give a very big thank you to my supervisors and the rest of the research team for helping me guide and supervise me in this research project, which was the first one I've ever done. Yeah, so thank you for listening, and I welcome any questions.
They don't make medical students like they used to. Very good. Do we have any questions? We do. Andrew.
Yeah, it's Andrew Burney from Canterbury. Well done. I mean, really brilliant presentation. One's an observation and then a question. The observation is that it's interesting that you've noticed the geographical variance. And I did my training in Nottingham, then did a Mohs fellowship in Cardiff. And then when I moved to Kent, there was all of a sudden, it seemed loads more diagnoses of porocarcinoma. So my hunch is that it is a pathological diagnosis that's slightly different rather than there's something to do with the genetics of east-west in the country. The question I had is that you're saying that a 45% 5-year survival from a median age of 82. I'm just wondering, is that tumour-specific survival or overall survival? Because if you're 82, your 5-year survival is probably not much more than 45% anyway, isn't it?
Yes, I agree, and that's a very good point. And yeah, I should have clarified that it was not disease specific, but overall survival that we're looking at. And I agree. The older patients may have increased morbidities, which may be affecting the mortality for sure.
You didn't by any chance look what the 5-year survival of an 82-year-old is?
Oh, I did.
Yeah, just on average.
Oh yes, I did. But I think because of space, I took it out of my PowerPoint. But I would be happy to share that data with you, maybe afterwards.
Thanks.
Hi, sir, it's Catherine Holden from Sheffield. I know it's not directly related, but at the moment you said there's no specific management plan for porocarcinoma. I know there's been either sentinel lymph node biopsy and stuff, especially in America. There's quite a few cases. The last patient I had, I convinced the plastic surgeons to do, I think we did lymphoscintigram, was positive, and they've had a complete axillary dissection. And I think from the studies, theoretically, he's got a better survival rate. Do we know whether there's any studies in the UK or plans to look at management?
So there's very few studies on which I've seen on the use of sentinel node biopsy for porocarcinoma. I think it's a dilemma that has been mentioned, but very, very rarely in the literature. And I think there is scope to investigate the potential use of this procedure even more in our patients.
Thank you.
It's a condition that we've all been there at MDT. A case comes up, we all have a room of silence as we reach for our smartphones and look for the latest evidence. So having data collection like this is going to be very useful for the future. So thank you very much.
Okay. Thank you.
I'd like to now move on to our next speaker, who's Dr. Caelan Mistry, who's going to come and speak to us about the National Merkel Cell Carcinoma Epidemiology and Mortality-Related Risk Factors in England from 2004 to 2018.
Thank you. My name's Caelan Mistry. I'm an academic foundation doctor and aspiring dermatologist at the Norfolk and Norwich University Hospital. I'm very proud to be presenting our research on Merkel cell carcinoma epidemiology today. On behalf of my co-authors, I'd like to declare the following conflicts of interest. So to begin with, a clinical scenario. I'd like you to imagine that you're in your clinic and you've just diagnosed a patient with Merkel cell carcinoma. The patient's very anxious and they ask you, how common is Merkel cell carcinoma in England? And what are my chances of surviving? At present, it would be very difficult to answer these questions. MCC publications are often limited by small sample size and paucity of data on different risk factors. A study from the east of England between 2004 to 2013 highlighted an increasing number of cases of MCC and predicted further rises in the number of cases. And more broadly, studies from Australia, America, and across Europe have all reported increasing incidence. Our objective was to report national epidemiological data from England on MCC between 2004 to 2018, with the aim of using this data to better understand the incidence, demographics, and prognosis of this rare but important cancer. Similar to previous talks, we use National Cancer Registry data to identify MCC cases. Data request approval was obtained from NHS Digital, and IRAS approval was also obtained. Pathology reports were received from all NHS labs and most private labs across England. We were then able to link the pathology reports to patient demographics and the treatment pathways that patients followed. 3,775 tumours were registered from 3,760 patients over the 15-year study period. Crude counts rose from a low of 143 in 2005 to a high of 340 in 2016. We calculated European age-standardized incidence rates and ran joint point regression analysis to identify significant changes in incidence trends over time. The curve on the left shows that the overall incidence in England between 2004 to 2018 was 0.56 per 100,000 person years. An incidence increased from 0.43 in 2004 to 0.65 in 2018, representing a significant annual percentage change of just under 4%. We can therefore say that the incidence of MCC in England increased over the study period, and we hypothesize that potential reasons for this increase may be due to increased UVR exposure, greater exposure to immunosuppression, and greater awareness of MCC amongst clinicians. The curve on the right shows the incidence in males and females separately. You can see that the incidence is higher in males throughout the study period, and the rate of increase is also higher in males. When we compare the incidence in England to other countries, you can see that the incidence in America is quite similar. However, the incidence in Australia is much higher, with a rate of almost 2 per 100,000 person years being consistently reported. This variation in incidence between countries may be due to differences in UVR exposure, differences in Merkel cell polyomavirus positivity, and differences in cancer registration and the diagnostic criteria which are used. This map depicts the variation in incidence across different regions in England. The highest incidence was seen in southwest England, and the lowest is seen in London. This variation in incidence between regions may be due to greater UVR exposure in lower latitudes, differences in outdoor occupations and behaviour, and also a higher proportion of the population in southwest England who are of a white ethnicity. This table here breaks down the demographics of our cohort. We have an almost equal proportion of males and females, and the median age at presentation is 81 years old. 97% of our population were of white ethnicity, compared to the UK general population of 86%. The face was the most common site of disease, and most individuals presented with stage 1 disease. We defined immunosuppression as a diagnosis of HIV, hematological malignancy, or previous organ transplantation, and 8% of our cohort were considered to be immunosuppressed. Definitive surgery included excision, Mohs surgery, lymph node dissection, or other complex surgery. Systemic therapy grouped together both immunotherapy and chemotherapy. Radiotherapy and systemic therapy data were restricted to 2009 and 2012 onwards, as this is when we had reliable data for these variables. 81% of our population had definitive surgery, 43.5% had radiotherapy, and 9.2% had systemic therapy. When we look more closely at the most recent 5 years of data, which are arguably the most reliable, you can see that the proportion of patients having definitive surgery fell to 75%, with 40% having radiotherapy and 10% having systemic therapy. This fall in the proportion of patients receiving definitive surgery may reflect an aging population where the risk-benefit ratio of surgery changes. In the most recent 3 years of data, the proportion of patients that were treated with avelumab of all patients that received systemic therapy within a given year increased. Avelumab was licensed by NICE in 2018 for the treatment of metastatic MCC, and so it's reasonable to predict that the proportion of patients being treated with avelumab will continue to rise. The curve on the left is a Kaplan-Meier curve, which it stratifies survival, disease-specific survival, by sex. You can see that the 5-year disease-specific survival overall is about 65%, with median follow-up time of 767 days. This is similar to the survival reported from studies in the Netherlands, Australia, and America. The Kaplan-Meier curve on the right shows disease-specific survival stratified by stage at presentation. As expected, those with stage 4 disease have a much poorer prognosis. For survival analysis, we also calculated multivariable Cox regression analysis, with time to MCC-specific death as the outcome of interest. Mortality-related risk factors included being elderly, coming from a more deprived background, those presenting with late-stage disease, and immunosuppression. The greatest predictors of mortality were stage at presentation, followed by immunosuppression. It's important to note, however, that quite a high proportion of our cohort were of unknown disease stage, and we think that this subgroup may represent elderly and frail patients who underwent diagnostic biopsies but not further investigations such as imaging to determine their true stage of disease. Compared to the reference site of the face, MCC of the eyelid had a better mortality as represented by the green areas, whereas MCC of the scalp, the neck, the ears, the trunk and the lower limb all had a higher mortality as represented by the red areas. We defined non-UVR exposed sites as a trunk in both males and females, and then the scalp, the neck, and the ears in females only. Non-UVR exposed sites had a higher mortality than UVR exposed sites. We hypothesize that UVR exposed sites may be on parts of the body that are more easily noticed by patients, and that may explain our findings to an extent, but further investigation is required. The main strength of this study is the size and the quality of the data for such a rare cancer. The study raises awareness of the epidemiology and prognosis of MCC amongst clinicians, which may help to improve patient outcomes. There were some limitations, however. We were reliant on routinely collected data with no access to clinical notes. Improvements in cancer registration and regional differences in cancer registration may have confounded our findings. And unfortunately, we were unable to ascertain information on the polyomavirus status of patients and the excision margins which were used. And these may prove to be important prognostic factors. So in summary, coming back to that clinical scenario, I hope you feel a bit more prepared in answering those questions. MCC is rare, but its incidence is increasing. And in England, we see around 340 cases per year. 5-year disease-specific survival is around about 65%. However, the elderly, those from more deprived backgrounds, those presenting with late-stage disease and immunosuppressed all have a poorer prognosis. The treatment of MCC in England remains variable, and international collaboration and further research is needed to establish clear evidence-based guidelines. And it was great to see a few weeks ago that the European Consensus Guidelines for the diagnosis and treatment of MCC came out. This is definitely a step in the right direction. I'd like to acknowledge my mentors, Associate Professor Zoe Venables and Professor Nick Lavelle, for their continued support and guidance, the team from the Erasmus Institute in Rotterdam, as well as the National Disease Registration Service and the rest of the co-authors for their hard work with this project, and finally, Clinical and Experimental Dermatology, for having me on the editorial board. It's been a pleasure, and please do follow us on Instagram. We post interesting case reports, articles from our journal, and also quizzes which are very helpful for dermatology trainees. Thank you very much.
So what we're all learning here is if we can avoid getting into our 80s, we're not going to get these rare, nasty tumours, are we? No. Any questions, please?
I'll start with a question. You said that it's more common as you get older, so you're more likely to end up with problems of MCC. Do you think it's really age, given that people may age at different rates biologically? And would performance status be something else that you should possibly look at?
I'm sorry, I didn't hear you. Can you say it again?
Sorry. Lean into the microphone. I just think, with regard to, you've said as you get older, there's increase, but do you think it is truly age, or is it biological age? Is it performance status, which may be more appropriate to look at? Are these people with multiple comorbidities, and therefore, is that a driver, or is it purely down to how old they are? I see Zoe stood up there as well.
Yeah, no, that's a really great question. So we calculated age standardized rates, so there must be something going on beyond people aging, which is causing an increase in the incidence of MCC. And I think we alluded to a few of those things, so things like increased UV radiation exposure. We're seeing more people travel aboard. We were talking about earlier about the new generation and people spending more time on tanning beds. We're also seeing more immunosuppression, so we're using drugs like cyclosporin and azathioprine, which have been associated with Merkel cell carcinoma. So I think age is a factor, but the research has shown that there are also other factors which are coming into play.
Yeah, I just wanted to add as well that unfortunately we haven't really got very good performance status data. It certainly is not complete, but yeah, that would be really interesting to explore. But we could potentially include a Charlson score, which might be interesting to include. The other point I would like to say is, yeah, I totally agree. I think immunosenescence is we're becoming more aware of it, aren't we, as a key factor in these cancers. Not only Merkel cell carcinoma, but that links into Brigitta's data earlier, saying that SCC survival is 89%. And we don't think all these people are dying from SCC. I think it's probably an age-related increased risk of death from other causes that results in their SCC, and it's probably the same thing with Merkel cell carcinoma, isn't it? We've got immunosenescent patients, and that's why that's why we're seeing them more common, and that's why they've got such a poor prognosis as well.
Yeah, I think it's a bit disappointing that we don't have the data on the polyomavirus with that, because it would just add that extra layer to it. But obviously, the data goes back quite a long way, and that's a more recent finding.
Yeah.
Maybe in the future.
Yeah, and it's really interesting because there's a growing body of evidence to suggest that those individuals that are infected with the polyomavirus tend to have a better prognosis compared to those group of patients that are getting Merkel cell due to UV radiation. So it is a shame, but maybe in the future, yeah.
I mean, we're coming full circle here because what we're coming back to, you've probably got a very similar population to the one we've got in Devon, and we're seeing our tumour clinics are overrun increasingly by the very elderly with really nasty tumours. And already we've got a problem with our workforce in the UK, and this is very labour intensive, and it's going to be a bigger problem.
Makes for complex medical decisions, doesn't it? Yeah, I agree.
Well, I think that brings us to an end. Thank you very much. And thank you, Norwich, for propping up a large portion of the BAD meeting.
So thanks for coming, and enjoy the rest of the BAD conference.
same lab. I'm going to mention that. God, no. But I think he's just split up with someone again. A girl, yeah. I don't really like this guy. But there's never been anything between me and him. We've been just good friends. No, never.
Defensive.
Yeah. He's like my brother. I mean it.
He's a very nice man.
He's very nice. He's a very busy man, but we've been good friends since the 90s. Yeah, I like him.
Did you graduate together though?
No, we met in the immunology lab.
Okay.
And he's one of the, I've kept in contact with a couple of researchers from the lab doctors.
No, very good. You've done a great meeting. What's it going to be like to stop? Well, you're not quite stopped though, are you?
I'm not quite stopped. Yeah, Tanya told me off for not enjoying the meeting well just now.
Does she?
Yeah, she said you're not enjoying it. I'm not being comfortable going into long succession, so I concentrate when I get in there. I need to get this over
If
with.
if you're running, I mean, at the AirStaff meeting, I don't listen to a damn thing.
Yes, I wasn't going to go into a room. I'm not going to listen.
Because you're busy, you're too busy just making sure that things are organised, people are on time.
And do you know what I want to? Yeah, I just so there's no point me just pretending.
No. You going to start on time?
Well, what time is it?
It's 4 o'clock.
God.
I think we should start on time if we can.
You know, I'm going to take the cue from.
Looks like we're on.
So I said that.
People can come in as they go on. Yeah. Okay. Let's go.
Stop. So loads of people walking through.
That's fine. They can come in as they go on. Or maybe it's up to you.
I think we should.
Okay.
Bit.
Yeah. You're the boss.
Literally flooding in.
Yeah.
And we haven't got a major thing straight after this.
No.
We'll finish
True.
after this.
Yeah.
I think you might make me.
That's fine. Nobody can hear me do things.
No, yours is on.
Yeah, as soon as you start speaking, they'll close the door.
God, they're flooding in. Must remember to give them. I'm very bad at remembering. No one's got mugs from them.
Is this so? They're all appearing in person.
As far as I know, yeah. I know Roxana's here. Well, she was due to come in person. Presumably Sally's here. She was.
Do you know what she looks like?
Roxana, no. I assume she's someone of colour. Good afternoon, everyone. Good afternoon, everybody. Good afternoon and welcome to our next plenary session. Please do take your seats. It gives me great pleasure to welcome our first speaker today, who's a keynote speaker. Professor Mark Lipman is Professor of Medicine at University College London and consultant in respiratory and HIV medicine at the Royal Free. I personally know Mark because Mark and I worked in the same immunology lab in the 90s, and we've remained in contact since then as friends. With the increasing use of biologics in dermatology, I've invited Mark to talk a little bit about this, as he's a leader in the field of TB and mycobacterial disease. Welcome, Mark.
Thank you. Thanks so much. And I'd like to say what a treat it is, firstly, to see you all face to face. Secondly, thank you so much, Pew, for inviting me here. It's just been a lot of fun. The last 48 hours has been great. I hope I'm going to entertain you and educate over the next 30 minutes. I did, because I'm quite bad at this, I put my talk together today. So I did a lot of canvassing. Yeah, that's for trainees. Don't do it. Do what I say, not as I do. You know. So I did canvass a lot of opinions about what you wanted to hear. So I'd like to thank Sandy, Farina, Kate, Sam, Adam, Steve, an endless, you can see, an endless list of people. You know who you are. So this is the title of my talk, and I'm going to use cases because I thought that would be helpful. So you can see 34-year-old white female, born in Portugal, came to the United Kingdom a few years ago, worked in Angola, so a high TB prevalence area, has psoriasis, which is bad enough to want to start a biologic agent. Okay, so they want to know what to do. Well, if you go online, you find things like this, which is 9 medical tests you need before starting a biologic drug. And actually, it's pretty good, and it lists everything. If you look at that in a little bit more detail using the BAD biologics checklist from 2014, you can see that here it's talking about infections, and it's focusing on hepatitis B, C, HIV testing. It's also talking about immunizations, and then it covers tuberculosis, which is going to be the main bulk of what I will talk about going forward. As I say, it does mention about making sure that people are appropriately immunized. I'd love to see how frequently that's really done in practice, because I know my background in HIV and respiratory medicine, we're pretty poor at checking on these things. So I hope you're better than us. On the back of the form, you can see that there's a bit more detail. So here, again, the results of the tests, and here, the results of the screening. And that all looks pretty straightforward, doesn't it? It says do a chest x-ray, and then or do a tuberculin skin test, or you can do a TB IGRA, and I'll talk about that in more detail, because I think it's really quite confusing. And then eventually, and you can see, refer all patients to local TB service with a history of previously treated TB or have had close contact with a case of active TB, which all seems really straightforward until you start to drill down into it, I think. So let's just carry on with our case. She has no symptoms to suggest TB disease. Her chest x-ray, that's great, is normal. Generally, I would recommend getting a chest x-ray within the last 3 months. As you know, the risk of, in terms of radiation dosage of a chest x-ray is pretty small. People can have up to 100 chest x-rays a year. So I will try and get one, as I say, within a short period of time before starting a biologic. And then you get the result, TB IGRA positive. Okay, so what do we do about that? Well, there's a few things you can do with an IGRA result. One is ignore it, and we'll come on to why you might want to do that. Second is get more information, and the third is refer to TB services. Well, I'm using acronyms left, right, and center. So I'm talking about an IGRA, and who knows what that is? TB, okay, that's pretty easy. Other than in my hands, where when I say I'm head of TB services, I'm unable to pronounce the word B or the letter B, so it comes across as V. So I usually sound like I'm the television maintenance man. As I say, I'm head of TV services. It gets very confusing. So interferon gamma release assays. Well, if you like, the blood versions, and there's 3 commercial ones. There's quantiferons, there's ELISpots from Oxford Immuno, and there's more recently the VIDAS test, which probably isn't that commercially available at the moment. They are the extension of tuberculin skin tests. What I'm showing you here in panel A is why these things work. In other words, someone who has been exposed to tuberculosis develops an antibody, and so a humoral and cellular response. They then have T cells which are primed to react if those T cells then encounter the same mycobacterial antigens in the future. So that's panel A. You can then test that doing either B or C. And B is a tuberculin skin test, which most of us at some point in our lives have probably encountered. And C and D are a T-spot TB and the quantiferon blood test. So what are the advantages and disadvantages? Well, TSTs are much simpler to perform in settings where you haven't got the facilities for laboratories. Because if you look at what a T-spot and the quantiferon require, it's overnight incubation. It's relatively complex laboratory setups if you're in a resource-poor environment. But let's just think about what a positive TB result, IGRA result means. So we've talked a little bit about it, that it's the host response to mycobacterial antigens. Is that specific for TB? No, it isn't. So you've got the Mycobacterium tuberculosis family, but you've also got some other bugs as well. And maybe one that jumps out at you there is marinum, which can lead to fish tank granuloma, so something that you may see in your dermatological practice. What's important about the blood tests is that there is no cross-reactivity with BCG. And that's particularly important because BCG is probably at the moment the vaccine that has been given more than any other in the world. That is likely to change soon, one would hope. Okay, so that's different to TST. What else, though? Well, one thing that is a major issue is that TB-IGRA positive results, that indicates infection, not TB disease. And as you can see, as I've put in that bullet point, infection at some point in the past. It can be recent, in other words, something from, say, 2 weeks onwards from infection, you'll start to see a positive IGRA, or it can be years and years ago. And quantitation in terms of IGRA is helpful to a point, as I'll show you in a moment. It is not a useful test for active TB disease. Why? Because it's about 80%, the sensitivity is around 80%. That is a level which really isn't good enough for the sorts of diagnostic tests that you would want for TB disease. So there's a clue. A lot of people, certainly in my neck of the woods, like to do TB testing for TB disease. When I say a lot of people, I don't mean dermatologists, by the way. I'm not waving my hand at that. What I'm saying is people who do TB a bit, people who do respiratory quite a lot, people who do HIV infection a fair amount. And of course, that bottom bullet point, it relies on an adequate host response. That's really important if you've got someone, as maybe this patient, who is being considered for a biologic and therefore is probably already on an immune modulator. And then, of course, people who may have certain underlying disease processes, whether that's HIV or whether that's things like collagen vascular diseases, rheumatoid, lupus, etc. They can all affect test results, as I'll show you. Okay, so we talked about the patient having a positive or a negative IGRA result. Is that how it really is? No. There's 2 other categories as well. There's indeterminate and there's borderline. So indeterminate, well, that's where the test just hasn't worked. Within each blood test pack that you get, there'll be a positive and negative control to make sure that the result you see actually is a genuine one. An indeterminate test where the negative has failed is where the negative is coming up positive. For some reason, the kit just doesn't seem to work. The other thing is where the positive control, which should give you a high value, is coming negative. And that is a problem, and that's a problem in particular, you can imagine, in individuals who are, again, on drug therapies and might be being considered for biologics. Borderline, well, that's an interesting one. Borderline was introduced initially for the T-spot TB when it was clear that there were tests that were clustering around the arbitrary cutoff, which was separating results into positive and negative. And over time, we've appreciated that actually you probably have to do the same for quantiferon results as well. And I'll show you some information about that as well. So now we've gone from 2 tests, positive, negative, to 4 tests. And now we're starting to get potentially a bit confused. So how do we manage that in practice? Well, going back to our patient, her TB-IGRA result for a quantiferon comes back at 6.62. I'm showing you the cutoff there for a positive and negative, 0.35. So that's pretty good. That's a high result. So we're pleased about that. Okay, what are we going to do in that setting? Well, we're going to refer to TB services. Seems like the right thing to do, and hopefully what myself and the team will do is we will discuss with the patient the planned need for TB preventive treatment. Now, clearly, one of the reasons that people have done a pre-assessment before biologic therapy is that we know that the biologics have a chance of increasing the risk of going from latent TB to active TB disease, and I'll come back to that later. Okay, here's some data which was generated from work in the UK. And the reason, of course, that that's important is if you're looking at information on TB, any form of TB, you want to know the background prevalence of tuberculosis. The UK is a relatively low TB incidence setting. But the reason I say relatively is because we have more TB in the UK than most resource-rich environments such as the US, Australia, and most of Western Europe. But we have considerably less by a log scale than obviously areas where TB is endemic. And this was the UK PREDICT study where we looked at 10,000 individuals and asked the question, if you measure an IGRA, and the 2 IGRAs are shown there that were available at the time, together with a tuberculin skin test adjusted for the BCG value, and then look at the quantitative values themselves, does it predict TB? And the answer is yes, it does. So to use the quantiferon in the case that I'm presenting, you can see that a value of 6 and a bit takes that person right into the top panel, in other words, greater than 4, and therefore the greatest incident risk of TB over a 3-year follow-up period. So that's pretty useful, and it makes one beg the question, why do we not get given positive and negative results ourselves when we look at IGRAs? The problem is it can be confusing. So most laboratories will decide to talk about a positive and negative. But you can ask to get the actual value, and certainly when you refer a patient where there's an issue, someone may well say to you, someone like me may well say to you, well, can you give me the value, or do you know the lab where this was done so I can ring them and drive them mad rather than you being shouted at? I'm happy to take that hit. Okay, so we think quantitative values might be quite helpful, and that was easy in the case of a value of 6.6. But now let's think about the values which are a bit lower, and actually a bit more like real life. Here's a value of 0.46. Remember, the cutoff is 0.35, but in our lab, we've actually developed a borderline range, which is 0.2 to 0.7. We used to call, and it's completely interchangeable in terms of names, equivocal and borderline. They mean the same thing. It does mean that that result is sitting somewhere around the cutoff point. And therefore, we want to get an idea whether or not we should be offering that person treatment to prevent the chance of them developing tuberculosis during biologic therapies. Now, why is that important? Well, the problem is, as you know, with anti-TB therapies, is they are hepatotoxic. Depending on what you wish to choose, because some of the drugs that we use in terms of biologics interact with rifampicin, some also with isoniazid, but those are our 2 main drugs. So if we're going to give those drugs, then we may actually be causing a problem in terms of the drugs, the biologics that we want to use, and also, of course, hepatotoxicity. And that is, all it takes is you to give hepatotoxicity to one person who was previously well, and then have a really rough time, and it does make you totally reconsider the risk-benefit ratio in settings such as this. Okay, so we were talking about the options with this, with the previous IGRA results. What are we going to do with this one? Well, again, let's think about those. So I gave you ignore it. You could say, well, when you've got a borderline result, isn't that Mark just mucking about as usual? He's got a lot of results, a bit of time on his hands, and he's now just coming up with analyses. Possibly, yeah, possibly. Get more information. Can we get any advice on this? And we'll come back to that in a moment. And then refer to TB services, because now it's getting frankly too confusing. When people start, when you say, email me and say, I'd like some advice, please, and I come back to you and go, well, this is a borderline result, so I'm thinking about this and thinking about that. And it is just much simpler sometimes just to get the person to see a specialist, a TB specialist. Not least of which, because remember, as you know, these people, they're going on to, whether it's in dermatology or in other disciplines which are using biologics, there's a reason that you're giving these drugs. You want to get the person onto them quickly, and also, of course, the person themselves. And so when they are then told the good news that there's something to do with tuberculosis, and they are now going to have potentially treatment for TB, that's not good. Also, of course, the distinction between latent TB, and what I mean by that is someone who's asymptomatic, has no clinical features of disease beyond the underlying condition for which they are now being considered for biologics, And TB disease, where cough, fever, night sweats, weight loss, etc., they're not going to get that. They're just going to think they've got tuberculosis. And they are going to go down a pathway of who have I infected, what's going to happen to me, what's going to happen to my family. This is the reality, and it's something that one needs to just manage very, very carefully. And so, as I say, if there's any concerns, send them to TB services, or at least get your friendly TB service to even come and talk to them in your clinic if you can. Sometimes that's a way of just taking the heat out of a situation. Okay, so how do we manage borderline and indeterminate results? And this is what we do at the Royal Free. So clearly taking a history, getting an idea, as we talked about, underlying disease, anything that might be affecting the results. A suggestion would be to repeat the test 2 weeks from the first test, and I'll come back to the evidence for that in just one moment. You could use an alternative test platform. In other words, if you're using a quantiferon, you might want to use a T-spot. More generally, it's the other way around, that if you have a T-spot that's problematic and repeat it with a quantiferon, you may be able to actually get a proper result. And that's as a result of just the test, the way that the tests work. They measured slightly different things. So I talked about repeating the test. Is that just extemporizing? In other words, am I just trying to find a way of buying some time because my clinics are busy and I'm not quite sure what to do? This is some data that we looked at from once we had the system working, we looked at 3,000 previous quantiferons. And what I'm showing you here is the flow chart of negatives, the equivocal, or borderline, and indeterminates, and then the positive results using the cutoffs, as you can see, of 0.2 and 0.7. The bottom line of all of this is that it was about 8% of results that we couldn't interpret, either because they were equivocal or they were indeterminate. Just to deal with the indeterminates, which is the box in the bottom left-hand corner, you can see that the majority of those are in people on pre-biologics, pre-biologic assessments. So, surprise, surprise, either underlying condition driving it, maybe rheumatological disease, or they're already on drugs which might be affecting the test result itself. Okay. Then if we think about actually the equivocal results, and what did we do with them? Well, we recommended repeat testing, and you can see one point immediately is that there is a huge fall-off. As soon as you recommend something, quite often it doesn't happen. We've got better than this now, I think, and I think we probably get about 95% of people retested. What does that do? Well, it does manage to split people a bit. So in other words, we find that when we repeat the test for these low, either high negatives or low positives, if you like, we find that we can then dichotomize them rather more into true negatives and true positives. Now, again, you might well say, well, Mark, that's just you playing with numbers, isn't it? You've taken one test, you've repeated it, you times them together, and you then move things apart. So does that matter? I don't think it matters that much, because what you're doing is you're managing to reduce the number of people that you are offering TB preventive therapy to. And as I say, I would stress the fact that when you get down to a small risk of TB disease, and this person might have encountered TB, remember, in the past, may have developed an immune response to it, the thing you're measuring, and they may be completely protected because they might have eradicated the mycobacteria. And therefore, the toxicity of additional drugs, the time spent in getting someone onto latent TB preventive treatment therapy and so forth, you may want to not do that, and you may just want to get someone straight onto a biologic. Certainly in inflammatory bowel disease, that's something where we move very quickly, because individuals are at great risk of significant gut damage if they don't go on to biologics rapidly. And in that case, we will actually do an accelerated phase. People get started on a biologic, and then we start to, if needed, the TB preventive therapy at the same sort of time. That sort of answers one of the questions I was asked about when can you start a biologic after starting latent TB treatment, but I'll come back to it. Okay, so here's one thing, though, because it turns out that this person, not only have they got an equivocal or borderline IGRA, but they've also tested negative previously. So now we've got a test that seems to be shifting. So what do we feel about that? Well, we feel that's a test. That's what we feel. So in general terms, our advice would be, if we're asked the question, should we be doing repeat testing on patients in low TB incidence settings? The answer, no. Not unless there's a history of recent TB exposure. Can we get caught out? Of course we can, and here's an example. So what you can see here is someone who was on a biologic, was pre-assessed, and that's month 0's negative assessment, and month 12, what happens? They come back with TB. So we knew the IGRA was negative when they tested. What do they do in between? They went on holiday to a TB endemic area. How long was a holiday? More than 4 weeks is our general advice. So there is something about thinking about repeat testing, because maybe what repeat testing does is it eliminates the uncertainty of reassessing people each time. In other words, if you do repeat tests, it's quite programmatic, and programmatic things aren't necessarily a bad thing to do. It just means you're going to be testing a lot of people, possibly unnecessarily, and there's a cost in all sorts of ways associated with that. Okay. So finally, I'm going to get on to the different biologics, because that's the bit, because it must feel, this first part must seem quite simple, and I think to a point it is, but I just find that for me it's very, very useful always to just work through that and to be clear about what the tests are, and then as we move to the new biologics. Okay, so here's one of those scary tables that is a bit overwhelming. So these are the new biologics. So it is completely astonishing, actually. This was 2018 that this table was produced, and there's an awful lot of them, absolutely. Oh my goodness. So which ones do we use in dermatology? Well, I'm pleased to say it's mainly this bunch, and actually when you look in a little bit more focused, you can pick out that if you look at the excellent rapid update from BAD and psoriasis from 2020, what you've got is this. So you've got some rather more clear-cut biological agents, of course, most of which are from originally the anti-TNF agents, and then there's more and more things, whether it's anti-IL-23, anti-IL-17, and so forth. Okay, so we know the sorts of drugs that we're dealing with. What about the risks associated with them? Well, one thing that is quite difficult to do is to disentangle the underlying risk of the disease, for example, rheumatoid arthritis, which we know increases people's risk of both non-tuberculous and tuberculosis diseases from the drugs that you're using. So it can be quite hard sometimes to get particularly good information. But when we do look at the different biologics, and I'm sorry that they're written now in abbreviations, but you can see at the top you're going from, and the key is at the bottom, by the way, you've got things like rituximab, and then you go down to adalimumab, and so on and so forth. And then it's also including some of the newer drugs, so things like tafasitamab and tocilizumab, and so on and so forth. You can see that there is an odds ratio for all of these different drugs. You've got reasonable numbers, which is the tuberculosis patients per year. In other words, that's the patient years that you've got expressed there. And what you can see is, surprise, surprise, that the anti-TNF agents probably have the greatest risk. So that's still not giving you a relative risk, because you've not seen background rates. What will I quote? Usually for something like an anti-TNF agent, and although people have tended to distinguish a bit between anti-TNF agents, I'm a little less certain about that, and I think it depends a bit on the regimen that's being used, as I say, the underlying disease condition and so forth. So I would generally quote a risk of between 4 and 8 times over background. How does that compare to other scenarios? Well, it's not that much. If you think of untreated HIV, that's something like 20 to 40 times background. Even so, it does bump up people's rates. 4-fold increase is obviously quite a lot. So we do need to think carefully. If I talk to other clinicians who manage pre-biologic assessments for TB, they will often try and distinguish between the drugs that are being used. I think that is certainly something that's worth doing. And so, say, for some drugs, during COVID, inevitably there was the question asked, what about anti-IL-6 therapies? So things like tocilizumab, should we be screening for TB? Our advice at our place was no. I think this creates more problems. You should just be giving the drugs. The increase over background isn't enough to justify it. Okay. You can then, and this is again from the same paper from 2014, you can then try and split people into the populations into the underlying background rates depending on what disease they have. That gets a little bit hard to interpret as well. So as you can see, as we move towards biologics, things start to get a little bit unclear. What do we know? Well, we do know that some drugs seem to actually not have much of a risk. So drugs like ustekinumab, which in theory, because of the way that it affects the pathways IL-23 and IL-12, you would really expect those to increase the risk of tuberculosis. That does not seem to be the case. What does that suggest? Well, I don't think it's the fact that we're missing TB. I think that would be unlikely. I think what it's saying to us is that perhaps those drugs either aren't as effective as they might be, although we know they work, or that actually mycobacterial disease is only to a small extent affected by the IL-23, IL-12 pathway. Okay. Another point that people wanted to know about, of course, was, well, people are already on some drugs prior to going on biologics, so what's the risk there? And is it a bit dumb that we haven't actually assessed people for using IGRA tests and so forth prior to starting a biologic, yet they were already on various forms of immunosuppression? And that's true, although we know that for most, and again I'm showing you this in this table, you can see that for some disease, the DMARDs or disease-modifying agents, you can see that those, such as cyclophosphamide, which is in the 5th panel down, azathioprine, cyclosporine, etc., there does seem to be an increased risk of tuberculosis. So there is an argument for possibly doing IGRA testing prior to that. As far as I'm aware, most people are not doing that. I haven't seen anybody advocate it at all in any national guidance. As you go down the list, you can see one other important thing, of course, is that actually long-term oral steroids increases the risk of tuberculosis, and that's something to take into account. We've got no evidence, as far as I'm aware, that topical steroids, that's topical applied to the skin steroids, increase the risk of TB. I have certainly seen topical steroids applied to areas such as the vocal cords. They have definitely caused tuberculosis. So that's people who have struggled post-intubation, have had a lot of edema and inflammatory disease, have therefore had local steroid injections. Also inhaled steroids. We know they increase the risk probably of TB, certainly of non-tuberculous mycobacteria. So something just to be aware of maybe in one's practice. The very large table I showed came from this guidance, as I say, the ESCMID guidance from 2018. And if we just go back to it, we can see also, and I've extended the panel here, that there is, in the middle of the section, there's both the consensus guidance on who should have latent TB infection screening, in other words, IGRA testing, chest X-ray, and symptom profiling. And then what does it say in the summary product characteristics? And there's no's and yeses. A little bit hard to follow, but essentially there's quite a lot of things that have a yes attached to them. There was minimal discrepancy between the panel and the SPC. But it is something that certainly I get asked a lot about, not by the drug companies in general, but by people about, as I say, about the tocilizumab and so forth, what we should be doing. Okay. So, final couple of slides, some roundup questions again that I thought were relevant. One, when can people start? Well, within 2 to 4 weeks. The ESCMID group recommended 4 weeks. We generally say within 2 weeks. Why do we say any time? Well, largely so that people can tolerate the drugs that we're giving them. As I say, they're not without consequences, whether it's rifampicin by itself, rifampicin and isoniazid, or isoniazid. There are other drugs available, but those would probably be the top 3 combinations that we would use. One thing that's really important is, as you will always do, inform your patient, tell them to get back to you or whoever is their local healthcare provider to stress that something new or worrying is happening to them. I showed you the image of the chap who went away on holiday and came back unwell. It's that sort of thing. He actually turned up, came back to clinic or as a drop-in and said, I'm not right. take an x-ray. His not right, by the way, was high fevers. He did not have respiratory symptoms. He just had high fevers, and that was TB. So that's very, very important, and that should be the health warning, I think, with all biologics. And do talk to your TB service if you have any concerns. Okay, anything else we should consider? Yes, definitely. NTM, I talked about that. Fungal infections, they always look like TB. If you're thinking TB, think fungus as well. Same problems, I think. And then, of course, we know with the biologics cancer risk, and that's something that you're very, very hot on. I'm very aware of that. We, if anything, are a bit less good at that from our side, and so that's something I've learned actually from being at this meeting, which has been really excellent. Final thing, the TB service. My happy smiling face should be a reflection of the fact that we're always delighted to see you. Well, probably mainly the people at the Royal Free, but we'd love to see you all. Really, we would. And not as patients. So we're here to help. And with that, I'd like to take some questions if you have any. Thank you so much for listening.
Thank you, Mark. That's fantastic. I think you've just increased your referral rate now. Any questions, please? Can you come close to the mics, please, to each side? Tony?
Yeah, sure. So, Mark, really interesting talk. Thank you very, very much indeed. What's your take on the JAK inhibitors? What do we do about patients who are going to go on JAK inhibitors? Because they're going to increase, we're going to increase the use of JAKs for the time being in dermatology.
Yeah, I think they, I mean, firstly, they seem to be remarkable, incredible drugs, and like most of these drugs, they come through one avenue, and then you find them being explored more and more in terms of dermatology. They do increase the risk of TB, and in fact, I'd meant to put a slide in to cover that. I think that is going to be a problem, and I think because that's an example where really what you want to do is new drug, okay, checklist. Yes, let's do the IGRA, and also, again, same thing, just, if you have any concerns about it, just talk to us, but yeah, they will undoubtedly, all of the a lot of things like the ustekinumab, so the anti-IL-23, IL-12 drugs, post-marketing surveillance is very reassuring in that sense. I think with the JAKs, you're starting to see a different sort of picture. Certainly my experience, intriguingly, was that I was seeing more NTM, non-tuberculous mycobacteria with them. Touch some wood quickly. In my practice, I haven't seen TB so far, but surveying the literature, and again, of course, depends on the environment. If you're in a low TB incidence setting, you may not see much because there's not many people who are either going to be encountering TB in the first place or have evidence of latent TB. The really interesting populations, though, of course, in many ways, if you go to somewhere like Korea or Japan, they have very old, the populations there who have latent TB are much, much older. They get sick through various conditions, they go on to biologics, and bang, they're the people who really are developing it. And lo and behold, that's exactly where you see it. So you see, so the JAKs, they've caused problems in terms of TB in that sort of setting.
And you mentioned about the transaminitis, about the hepatotoxicity. Can you talk a little bit more about that? Because what is the risk of the transaminitis with the antituberculous drugs?
Yeah, so we will usually quote a risk of about 0.3% to 3%, depending on whether you're seeing moderate or severe hepatitis. Now that actually, if you really look at the data, it's not terribly clear about that. The original work that was done for isoniazid, for example, it's thought that there was, and this is one of the great epidemiological stories, there seemed to be, when they did, again, a large surveillance study in the United States, there was a lot of hepatitis associated with isoniazid in one bit of Maryland, and so it was assumed that this was the cause. It was then discovered that there had actually been a viral gastrointestinal infection, which had also been extremely prevalent at that time, which also caused deranged transaminases. So it's possible that we overestimated. We do know from most studies, though, that you will see an appreciable proportion of individuals developing a hepatotoxicity, enough to scare not necessarily the individual, because they may be asymptomatic, remember, but certainly the person looking at the results. And isoniazid seems to be strangely more of a problem than rifampicin and isoniazid because of the duration. You're giving it for 6 months rather than 3.
Any other questions?
Thank you very much, Mark. I've got a little something for you.
Oh dear. That's a bill, right? Or a referral?
It gives me great pleasure to introduce our next speaker, Sir Andrew Goddard. He's well known to all of us as the President of the Royal College of Physicians. So Bod was a consultant physician and gastroenterologist in Derby since 2001. And in 2018, he was elected as the 121st RCP President, the youngest for 400 years and the first from the East Midlands. I don't know about all of you, but I've been reading his bulletin with great interest. I think it's been full of information, particularly about the pandemic. And he's been instrumental in influencing the national response and representing us all, the fellows and membership views. And for that, we're all grateful. But I just want to mention that I first met Bod in 2019, and I also met the late, great registrar, Professor Donald O'Donoghue, at the same time. And I met them at the RCP, and I was really, and continue to be really impressed with Bod's approach to inequalities, and also in racial inequality, and the work he's doing to try and make medicine fairer for all of us, and particularly those who come from ethnic minorities. And thank you for that work, and please continue. Thank you, Bod.
Thank you, Pew. So, good afternoon, everybody. Absolute pleasure to be here. I think I'm probably light relief for you, I hope. I'm not going to be too serious, but I'll hopefully give you some of the reflections that I've had over my past 4 years and perhaps the 5 years before that as registrar. When I came into post, my predecessor, Jane Dacre, said, you can have the greatest plans, but it's all about events. And that's probably true. Many of you will know the famous quote by Macmillan about events, events, events. I'm actually going to use more recent ways to introduce my themes today. Those who read my newsletter will know that I'm quite a fan of music, and I think we can learn a lot from music, and particularly Mr. James Blunt, who tells us that all of the best laid plans fall apart in your hands. And the first thing that hit my desk that derailed what I wanted to do with workforce wellbeing and worldwide, which is what I got elected on, was assisted dying. The college had planned to survey on assisted dying. We were opposed at that point, although interestingly we had been neutral back in 2010, and we were faced with a situation where there was a real mix of opinion amongst members and fellows, and it was roughly a third, a third, a third. So we felt that we should go neutral, and that was the best representative viewpoint of our membership. The following evening, I received 2,500 emails coordinated by the Catholic Church in Spain, and I began to realise that people feel quite strongly about this topic. It then went through the media and was then taken to the High Court. Now, all of that actually came to nothing, and our position has held, and other people have followed suit. But you begin to realise that things you think, and you've tried really hard to be fair and balanced about, people will feel very strongly and have a certain opinion. So the next event that came my way, which is relevant to me as a gastroenterologist, was the lack of loo paper. Now, you all know that that was due to panic buying in the early stages of the pandemic. So what I would say to you is watch out for the sale of candles, because if energy becomes an issue and power cuts become an issue, I think we'll see the same with candle supplies. So let's focus a bit about some things I learned during the pandemic. Communication is so important. And the communication that our leaders gave us at that time was, at best, mixed. with various ideas on a theme of 3 about what we should be doing. And when you're trying to get across public health messages, you really need to be, firstly, simple. So you could argue that was reasonably simple, but you need to be consistent. And we weren't. Now, sometimes even the best intended messages actually fall badly. But if you look what happened, and there was a good review in the BMJ recently about the different policies of lockdown in the different 4 nations of the UK. But remember those days within England of having different tiers? It was remarkably confusing. So we should not be surprised that as a public health measure, things did not work well. And now we're getting back into that phase of, are we all going to wear masks again? And certainly within hospitals, as of today, that's the rule. So you need to be simple, consistent and clear. And that's what I tried to do with my bulletins. And for me, doing the bulletins was a therapeutic exercise in some ways. It allowed me to get all my thoughts on paper. It allowed me to feel that I was doing something, making a connection. It also allowed me to read stuff and make sure that when I was then asked questions on the media, I actually had read the papers and I knew what the evidence was. But it is really important that you keep talking, and whenever things go badly, you've just got to communicate, communicate, communicate. Do it early and do it often. And that's something that I've really learned over the past few years. And you need friends. And it's amazing how when the stuff hits the fan, how you learn who your friends are. And as Pew said, I just want to mention 2 friends of mine. So the gentleman on the left is Manjeet Riot, who is one of my ED colleagues in Derby. And whenever anybody asks me, what are your reflections on the pandemic? What are your recollections? So my reflections was that it was terrible. These are 2 good friends that died from COVID during the pandemic. So Manjeet was one of the first doctors in the UK to die in our emergency department. And the last time I saw him was in ED in the small hours, as you do as a gastroenterologist, and gave him a really big hug. I hadn't seen him for a few months, and so really nice. And little did I know that would be the last time I would see him. So the next time you see a friend, welcome them warmly. You never know. And the same was true of Donal. So Donal was my right-hand man at the college as registrar, and he was a lovely, lovely man. He was a renal physician from Salford, and highly regarded in the world of kidneys. And I think would be replacing me, probably, as president in September, had he not died. He contracted COVID a week before the vaccine started to roll out amongst healthcare professionals. And he then died at the beginning of 2021. So let's remember our friends and let's hold on to them dearly. But friendship's really important when it comes to getting stuff done and working between each other. And I've got to say a massive thank you to both Ruth and Tanya for their friendship over the past few years and how they have helped bring dermatology as a specialty forward in the world of medicine. And I think the relationship between the college and BAD is as good now as it has been in my living memory. And that's because of the likes of Ruth and Tanya. So if you want your specialty or your department or whatever to sort of to move forwards in a direction, you've got to be able to form good relationships with people. And I'm, I think I have been so lucky to work with some great people like Ruth and Tanya. And what I remember most about my time in the college is people. Yes, we've got some lovely buildings, and yes, there's been a lot of events and stuff. But when I go, and have been doing stuff with the college for 20 years, what I will miss most is the people, the staff, the members and the fellows, and the friends I've made there. Because at the end of the day, medicine is all about people. You also mentioned sort of my focus on health inequalities, and it's something I feel very passionate about. And sadly, the pandemic has undoubtedly widened the health inequalities in our society. The cost of living crisis and Putin's invasion of Ukraine is making that worse. This is a picture from the first wave of the pandemic of the healthcare professionals that died, and many of you will recognise this from the BMJ, but it is quite striking. the ethnic distribution within that photo. And if you look at the mortality from COVID in individuals, there is certainly lots of relationship to the ethnicity of patients. But if you correct for that, a lot of it comes down to deprivation. And what we saw with the pandemic was that the poorer you are in society, so the closest you are to the right on the curve, the more likely you are to die. And so over 100% more likely to die if you're from the least rich parts of our society than if you're from the richest parts of our society. And that woke everybody up to it. But if you look at the grey, that's for all other diseases before that. And this has always been the case. I would hope that the light that the pandemic has shone on health inequalities will allow us to do something about it. I was hoping that the levelling up agenda and the move that the governments were making was a good one. Who knows? I've never stood up to give a talk before thinking the Prime Minister may be gone by the time I sit down, but we're in a very interesting time in politics. And one of the things I think I'm going to be proudest of, people always talk about legacies, I don't think you should do that, but we established the Inequalities in Health Alliance just before the pandemic hit, because we knew it was a problem before the pandemic. But we now have over 200 healthcare organisations engaged with that alliance, and we will continue to push very hard to get our government to focus on health inequalities. And one of the things that really annoys me is you write a letter to Boris, or whoever comes after Boris, about health inequalities and ask for a cross-government strategy, because you've got to do something about housing, you've got to do something about the environment, you've got to do education, etc. It has to be across all parts of government. And immediately they give it to the Department of Health because you've written health inequalities. And that tells you a lot about what people understand about the causes of health inequality and the social determinants of health. And things change, and you've got to be able to feel the wind, and you've got to be able to know when to do something a bit different. So let's talk about the early days of the pandemic. So you'll recognise this, I hope. This is the Diamond Princess, which was moored outside Yokohama for a few weeks at the beginning of the pandemic. We should have learnt much, much more from this. 3,500 people on this boat, over 700 got COVID, of which we know 19% were asymptomatic now. Yet, for many weeks during the beginning of the pandemic, we did not talk about asymptomatic infection. And if we had done that, I think our response would have been much more urgent and would have been much better placed. But because we thought it was going to be like SARS and people were going to be unwell with respiratory infections, we did not shut our borders early enough. And so what that meant was that by the time we sat up and noticed, COVID had already come in through multiple ports of call in the half term of that February. And the genomics of the bug now allow us to say exactly where it came from. It came from Spain, France, and Italy. It did not come from China. And you remember all that horrible stuff that was there in the first weeks of the pandemic about people sort of stigmatizing people from a Chinese background. This was mostly middle-class people going on half-term holiday and bringing it back. And there were arguments within government. And I'm going to talk a little bit about Chris Whitty, who I think is fantastic, and I think I am so glad that he was our chief medical officer during the pandemic. From an infectious disease background, highly intelligent, great communicator. We were very, very lucky to have him there. Now, you might argue the same about Mr. Hancock standing behind him. And I introduced the last health secretary who came after him for our conference in the office where that infamous photograph was taken of Mr. Hancock. He was very good at relationship building, was Mr. Hancock. And I couldn't really look Mr. Javid in the eye without looking at the door behind him and thinking what had been there before. But in Mr. Hancock's defence, he and Chris Whitty rallied so hard and pushed so hard to protect the health of our nation compared to the rest of government. And we should be glad they were both there, because I dread to think what would happen if they hadn't pushed that hard. And we know that actually, as a health system, we responded fantastically well. At one point, this is at the beginning of 2021, 2/3 of beds in hospital were filled with COVID patients. And who was looking after that? It was physicians. It was you. It was me. And people doing stuff that we hadn't done since we were medical registrars, because we could do it and because we stood up to the plate. And I'm so, so proud to be a physician. And when it needed to happen, we could make quick choices and quick recommendations. So when it became clear that the AstraZeneca vaccine was causing clots, we kept waiting for guidance, and it never came. And in the end, we said, stop this. We'll come out with some guidance. We're not going to wait for NICE, because we need it now. And people will come together, and they'll do the job. But it had a massive impact, and it had a massive impact on the college from the point of view of finances. And we've been running at a bit of a deficit. So the college turnover is around 40-odd million per year. And we've been running at a little deficit the year before. But the impact of the pandemic on our income, which is the blue line, was massive. 12 million loss of income. And we still had all those staff. We had all those things to do. And so we had to find ways to reduce money. So one of the hardest things that I had to do was sack people. Make people redundant in order to cut the wage bill of the college. I have never had to do that before as a doctor. I wish and hope that none of you ever had to do, because that was remarkably hard. We have now recovered, and last year we actually broke even. And as part of thinking about what you're going to do about money, you have to make some hard decisions. And we're a charity, and as trustee of that charity, I have to decide, well, we've got some assets I can sack people, or we've got some assets and some things. Should we think about selling the assets? We have to consider all of that. Now, we were having those discussions. This got leaked to the Times, which I normally like, but actually when they were covering this, they were pretty unfair and very personal in their attacks on me. It was really hard. Do you sell a book, or do you sack a person? Now, I've oversimplified and overgeneralized that, but that was the sort of decision we were having to think about. And then, clearly, there were a lot of people who felt that we should not sell the books. So we listened to that, we found other ways, and we found a way around it. I'll come on to that in a little bit. Because at that point, I really learned who my friends were. So my friends, when we were making those hard decisions, rang me up, said, we know this is really tough, Bod. I don't think you should sell the books, and here's why. People who I thought of as friends signed an anonymous letter. And what I did learn about myself is I'm not very good at forgiving people. So take your chances while you can, and vaccination was one of those shots. So let's talk a little about vaccination. One of the hardest things we had is when the vaccine first came out, we didn't have enough. So we had to make a decision. Do you give lots of people one shot, or do you give half that number, which includes healthcare professionals, 2 shots? So what we said is, based on the immunology, it seems unlikely that a 3-week distance is going to be any different from 12 weeks. And they chose 3 weeks because they needed to rush the drugs through the trials. So we, as a college, supported the government and JVT and Chris's plan to do it at 12 weeks. And the BMA lambasted me. I had one of my fellows resign over it, and history has shown us that it was the right thing to do. Because I could not stand there and say, I think I should have a second shot as a young, honest man compared to my patients who are 85 who've not had any. And it was that, and these are sort of the hard decisions. And it's really hard when that is played out publicly and the profession is seen to fight against each other. One of my most amusing moments is that Chand always likes to have the last word. In some ways it was great with him as leader of the BMA during the pandemic, because he was a very good vocal proponent of the profession. But sometimes, and I was on one BBC News programme in the morning once, and there was he and me, and every time I try and say something, he'd come in, and then his internet went down. And they could only ask me the questions. I enjoyed that briefly. Vaccines, we always kept thinking about us again. We need to think about the world, and we need to continue to think about the world and how we supply vaccines everywhere. You'll get lots of opportunities to do stuff when you're in these roles, And we must learn from them. So one of the positive things about the pandemic was how much drug design advanced so quickly. And the recovery trial and clinical research coming back to the fore. But you think of all those new, the antivirals, the monoclonals, the vaccines, and good old dexamethasone. So we learn a lot very quickly. We learned that you can do outpatients virtually for lots of things. Before the pandemic, we'd suggested reducing the number of outpatient face-to-face appointments by 30% and making that 30% virtual in order to save the impact on the environment. When we produced that report in 2013, I was told, don't be ridiculous, Goddard, that's utter nonsense. We can never have 30% of outpatient appointments virtually. Coronavirus showed us we could. We came up with virtual ways to hold conferences. And I think it was really sad for you that your 100th conference was a virtual one, but it was successful. And we carried on through the pandemic. We saw that actually having medical students as FIY1s on the ward in their 5th years was a good thing. They loved it and we loved it. One of the other things, though, to move away from the pandemic that I've learned as president, that I knew climate change was important, but I didn't really realise how important. As the years have gone by over the past 4 years, I've really begun to understand that this is going to be a massive health issue for us moving forwards. And if you don't think climate change is going to affect us, well, you're wrong, because it is. And it's going to do lots to us. It's going to hit the poorest in our world first, but it's going to result in mass migration, food shortages, and it's going to be a nightmare unless we do something about it, and we can do something about it. So I'm a firm believer in there are solutions. Let's pursue them. But I think we as health advocates can advocate very, very strongly on this. I'm getting to the end. A couple of little things. Number one, social media. Very useful for making quick communications, but I've seen so many people derailed by it, their mental health has gone off. The number of people I see on social media say, I need to take a break. Anything that you do that you feel you need to take a break, it's a bit like asking that question, do you need a glass of whiskey first thing in the morning? You know, it should make you think this is an addictive thing. Social media has lots of positive things, but I've seen it do more harm than good. And the best things in life are free. I could not have done my job, and none of you will be able to do whatever you want to do in life without people to support you. So my family, I'd just like to say thank you publicly. Even my mother-in-law at the end there. She's got dementia, she wouldn't remember anyway. So, a massive thank you to you all for being physicians, and thank you for all that you've done for the specialty of dermatology. It's been a roller coaster ride. Here's a photo of me just before I started. I hope that I've left the college in as good a shape as it was before, if not a little bit better, and I hope the profession will carry on going from strength to strength. The college has been here for 504 years. It will carry on being here, but I'm out the door. Bye.
Thank you, Bod. You can tell from that applause that we all thank you for being a great president of the RCP. Thank you. Mabs.
Much for what you've said today, and you're quite right to highlight Ruth Murphy and Tanya Bleiker's interactions with the RCP to enhance our relation. I know you're stepping down in about 3 months, but we hope to interact again mutually beneficially from that point of view. I think you've given a few tips for new presidents, so I won't task you on that one further. What I wanted to say was your first few slides. You may not know this, but Manjit Riyat Singh was one of my best friends. And the way I found out that he'd died was actually the Sky News ticker tape at 10 p.m. So that was, quite a shock. I think we should reflect and remember all the physicians, but also everybody else we've lost during the COVID pandemic. And it's really, really, timely that you mentioned that. And I think, those of us that are here, we should always remember the ones that we've lost, particularly the NHS frontline workers. Thank you for that.
Okay, thanks very much, Bod. Now, it gives great pleasure to introduce our next speaker, who is Dr. Roxana Daneshu, who is from Stanford, USA. We're very, very pleased that you've made it across the pond to come and join us today. Dr. Daneshu is going to talk about AI in dermatology and overcoming biases. Dr. Daneshu has quite a provenance in terms of research in AI. Graduated, first of all, in bioengineering and then completed her MD, PhD at Stanford, and then has worked extensively in AI and is working currently on AI projects. So thank you very much, Dr. Daneshu.
Thank you so much for having me here and inviting me. I've really enjoyed visiting your meeting and your beautiful country. I get a lot of comments asking what it's like coming from sunny California to here. And I laugh because we are quite close to San Francisco, and the American writer Mark Twain is purported to have said, "The coldest winter I ever spent was summer in San Francisco." So I was plenty ready for fog, cold, wind in the summertime. So today I'll be talking about artificial intelligence in dermatology, and particularly focusing on where we're at and what we need to do in terms of bias. These are my disclosures. They're not directly relevant to this talk. First, I would like to start with some headlines. Headlines that were quite popular in Silicon Valley, and maybe you've seen them here across the pond as well. Man against machine. AI is better than dermatologists at diagnosing skin cancer. Google says it has an AI that can detect 26 skin conditions just as good as dermatologists. Titles like "The AI Doctor Will See You Now." What is happening with this technology? Are we about to be replaced? This is where we actually are, and by the end of this talk, I hope you will agree with me, see what some of the limitations are, and also see what we need to do in order to make some of this technology work for us, with us, not as a replacement for us. So these headlines, which are also recent: most dermatology algorithms don't have transparent data. They also don't report the diversity of their data sets. The data that's used to build algorithms detecting skin disease is too white. There's not good information about what skin tones they incorporate. And of course, if you're interested, I would also say to check out Dr. Ade Adamson's commentary in JAMA Dermatology, which he actually wrote before all these headlines came out, saying this is going to be an issue that we need to be aware of. So taking a step back, I want to, you probably heard these terms a lot thrown around, used interchangeably: AI, machine learning, deep learning. I would like to just talk at a high level about how this technology works and what these terms mean. So artificial intelligence is any technique that enables computers to mimic human behavior. That could mean your Netflix giving you a recommendation after seeing what movies you've watched, just like a friend might if you told them what your favorite movies were. Machine learning is a subset of AI techniques that enable machines. It uses statistical methods to enable machines to improve with experience, meaning to improve with data. And deep learning, which is what a lot of dermatology AI algorithms utilize, is a subset of machine learning which uses computation of multi-layer neural networks. Particularly, most of the algorithms developed in dermatology use something called supervised learning. Now, there is unsupervised learning as well, but we're not going to go into that deeply. And supervised learning is how humans often learn about the world. So this is my daughter back in 2020. If you see her running around the hotel, you'll note that she's much bigger now. And she wanted to learn about animals, and so this was, in a sense, supervised learning, giving her labeled data saying, these are what dogs look like, and she looks at it and she starts to extract some features. Oh, has has a, small nose and cute furry face and pointy ears. And so she starts to create some sort of structure in her mind of what a dog is. And then she sees this animal and she says, oh, this must be a dog too. And we say, no, that's not a dog, that's a cat. And so now she's learned something that this is a cat. So she starts to think about what features she can use to discriminate between what is a dog and what is a cat. And then she sees this animal and calls it a dog. And once again, we say, no, that's not a dog, that's a lamb. And again, she starts to think about how to discriminate. And she says, this is a dog. And we say, that is correct. So she's getting some reinforcement of her previous decision-making till finally every time she sees a dog, she's able to call it out appropriately as a dog. And if you think about it, this is how supervised learning is often how we train our residents as well. We have them follow us around in clinic. They biopsy things, they see things. We tell them the labels of the example. This is a melanoma. This is a benign nevus. And so machine learning or deep learning has tried to essentially do this, but do it computationally. And it draws very much from human learning as well, and how you may recall these experiments from Hubel and Weissel, where they had a cat looking at a vertical strip of light that was turning, and what they found is that different groups of neurons were firing in the primary visual cortex with the movement of this light. And so with artificial neurons, which are essentially performing mathematical operations in the computer, what happens is that you give them many labeled examples of a task, say recognizing different faces, and they begin to extract different features like lines and circles, and they put these together to be able to identify eyes and noses until they're able to actually discriminate between different kinds of faces. Like humans, these algorithms do not come into the world without some information. So my daughter, before she ever had to learn what a dog is, had lived in the world, had seen color, texture, and lines. And similarly, most of these algorithms are what we call pre-trained on millions of images of different everyday ordinary objects. So they've already been able to extract some information about lines and shapes and textures. So in medicine, how do these deep learning models get built? Many times what happens is we pull from labeled data that is retrospective in design, and we do some training of the algorithms. Then we have some portion of the data that we've never shown to the algorithm that we tested on to see how its performance is. And many of these papers have been published with just that step. But if you were to go further, you would then consider doing some pilot study with prospective data and essentially assessing model impact. And so why should dermatologists care about this? As I mentioned, my first notion is that the biggest thing that I hear is dermatologists have a fear that algorithms are going to replace what we do. And I'm here to say, as someone who does research in this space, I don't think that that's going to happen. But the reason I want dermatologists to care is because I think there are opportunities to utilize this technology to improve our workflows. And that is the idea behind augmented intelligence, which was put out in a position statement by the American Academy of Dermatology, talking about humans and algorithms working together to solve some of our pain points in the clinical process. So that's the reason that I would like dermatologists to care about this. And in particular, my focus has been looking at how the development of these algorithms could lead to bias. Previous talk talked about the significant health disparities that already exist in medical systems, including the medical systems in the US, and how if we build these algorithms the wrong way, they can actually make those disparities worse. And so the thing I'm going to talk about is how opportunities for bias actually exist at every stage of the development of these algorithms. So the first area that this could happen is in the data sets. And so going back to how you build the deep learning model, it is reliant very much on example labeled data. And so if you put in bias data, you will get bias out. Now, as many of us know, we have bias in dermatology at baseline. It was published during the COVID-19 pandemic that during the pandemic, as cutaneous manifestations of COVID-19 were published, it was shown in the British Journal of Dermatology that there was an absence of images of skin of color. In the US, there's been audits of our textbooks showing an underrepresentation of skin of color. And there's this fantastic TED Talk by Dr. Jenna Lester at UCSF talking about, at least in the US, why skin disease is often misdiagnosed in darker skin tones. There are issues around photography. Historically speaking, color balancing has favored light skin. They used models of individuals with light skin to balance the color of the images, and so this affected our, on the sort of Kodachromes that were done on film photography, do not have as accurate of a representation on on dark skin compared to light skin. And digital cameras may still have differences in color balancing, though these are not well quantified in the literature. And there's this whole issue of discordance between what we see as dermatologists in real life and what is captured by images. And so one thing is that many of the guidance that has been presented on taking photography has been focused on light skin tones. And so with Dr. Jenna Lester, we wrote up some guidance on how to take good photographs. And one of the major differences is you don't want to use flash photography because this can leave flash artifact and lead to misrepresentation of the color. And so here's sort of an example of this. So A actually represents natural lighting, and the individual is wearing a blue mask and a blue shirt. And so you can see how the use of flash can actually influence how the colors appear. And so that's important because, again, these AI algorithms are learning from photography. And so if the images are not a true representation of what we see in the skin disease, it can influence the performance of the AI algorithms trained from it. One of the other issues is looking at bias in these algorithms. We often use the Fitzpatrick skin type scale. Yes, the scale was originally developed to look at photosensitivity, not for assigning skin tone. It also originally did not have the darkest skin tones in there. And so even when we're talking about how we assess these algorithms for bias, it's an issue because this is not likely granular enough to capture the full diversity of human skin tones and the issues that might arise with bias. I will say that in this talk, I will be using this kind of labeling because we will see that even using this imperfect scale, we see a significant amount of bias in existing AI algorithms. So one of the things that we did is that we decided to quantify the sources of bias in AI and dermatology data sets. And so we did this scoping review and identified 70 papers which we read very closely. And we found a couple of interesting things. We found that most AI and dermatology data sets are siloed, meaning that the data is not available for us to be able to assess it, to be able to see what biases might exist in the data set. Here in this figure here, every purple square is a paper, every red circle is a data set. The red circles are data sets where the data is not shared. The green circle is a data set that is shared and available for scrutiny. And as you can see, most of the circles are red. And the other thing you'll notice is that open data actually stimulates a lot of research. And so number one there is the International Skin Imaging Collaboration's open data sets for AI development. The other issue we noted is that these data sets likely have noisy labels and are likely not representative. So as I mentioned, these algorithms trained off of labeled data. How is that data labeled? Well, in the 56 studies looking at cutaneous malignancy, 20 of them had the labels picked by dermatologists and no biopsy to prove whether or not that's the true label. Now, I think dermatologists are fabulous and we do a fantastic job of treating skin disease, but studies have shown that we biopsy, at least in the US, about 7 suspected melanomas before we discover a true one. And so if these labels are labeled by dermatologists without pathological confirmation, there's a high chance there's a good amount of label noise that the algorithms training on this data learn from. The other thing we found that only 7 out of the 70 studies included at least one data set with skin tone descriptors, and you will not be surprised to find out that of the 7 that reported any information about skin tone description, there was a lack of skin types 5 and 6. Now, Wen et al. And some of your colleagues here actually looked at the publicly available data and to assess what skin tones were seen in those data sets, and they found that only 1.3% of images had associated ethnicity data, 2.1% of images had associated Fitzpatrick skin type data, and you can see the sorry state of the number of images that we have available that are publicly available for training AI algorithms across diverse skin tones. So that is the issue with the data. What about the task design? So you have the data, but then you have to decide that you're going to teach this algorithm to identify certain things like disease. Is it going to identify melanoma? Is it going to identify 26 different skin diseases, hundreds of skin diseases? What happens there? In work by one of our fantastic medical students, Michael Chen, he went through and looked at all of these research papers to assess what tasks were being done. And in panel A, you see that there are hundreds of papers that are looking at identifying benign and malignant pigmented lesions, different tumors. In panel B, you find that when we looked at diseases that are often seen in skin of color clinics or diseases that are often seen in women, such as autoimmune disease, you have a sparsity of papers that are looking at trying to identify pigmentary disorders. And so again, if you deploy an algorithm that claims to be able to diagnose many skin diseases, but you are leaving out pigmentary disorders from that algorithm, you're basically already designing an algorithm that is biased. So why should we care? What happens when an AI algorithm encounters a disease that it has never seen? There was actually the first prospective randomized controlled trial of an AI algorithm working in concert with clinicians. It was an algorithm that had trained on hundreds of thousands of images and 178 diagnoses. They looked at 4 dermatology trainees and 4 non-dermatology trainees that were randomized to see 576 consecutive patients with or without AI support. Turns out that this algorithm, which is the kind of algorithm that generated the kinds of headlines I showed before, it was an algorithm that had beaten dermatologists when they had done retrospective testing. When it was put to the test in clinic, it did not improve the accuracy of dermatology residents. It did, however, and this is again how these algorithms might be useful down the line, improve non-dermatology trainees in diagnosing the lesions. But what was a little bit terrifying and important to note is that if it saw a disease that it had never encountered before in training, it had 100% incorrect output, and not only that, it actually swayed people towards the wrong decision. And that is why it matters when we talk about disease representation in designing these algorithms. And the last part is biases amplified by algorithms. And so this is probably the most terrifying thing. There's an excellent paper by Dr. Ziad Obermeyer in Science 2019 where he looked at an algorithm that was deployed in the US across millions of patients, and it was being used to decide which patients who were being sent from the hospital might need additional resources. And what they found is that given the same score, Black patients were actually significantly sicker than white patients. And so the algorithm was actually making the biases worse because it was using healthcare spending as a proxy for the need of resources, which, as we know, because there are disparities already existing, healthcare spending is not a good metric for how sick the patient is. And so my concern is that I don't want us to end up with algorithms that perpetuate the biases that exist. And so what we did is we actually, as a result of the prior work and data sets, built an adjudicated biopsy-proven data set of clinical images across all skin tones. And we matched Fitzpatrick skin tone 1, 2, and 5, 6 by diagnostic categories such as benign, malignant, age, time that the photograph was taken, and sex of the patient so that we could do a comparator. And what we found is we took algorithms that had really excellent performance previously, algorithms that, again, have generated those kinds of headlines. And what you see is that the original reported performance of the ROC AUC, which is a measure of how easily these algorithms can separate benign versus malignant, was quite good. 1 is perfect, so nothing is perfect, but they had quite good performance originally in their original papers. When we put it on our data, there is a significant drop-off in performance across all 3 algorithms. And even more concerning is that when we compare Fitzpatrick 1 and 2 versus 5 and 6, we see significantly worse performance on Fitzpatrick 5 and 6 versus 1 to 2. And that is because many of these algorithms, again, were trained on data sets that did not include diverse data. We showed the importance of diverse data for unbiasing algorithms by taking a portion of our diverse data set and then augmenting or fine-tuning the algorithm, which means that we show it additional examples and we train it further. What we found is that when we train only on images of Fitzpatrick 1 and 2, there is a boost in performance because, as I mentioned, these algorithms are sensitive to the data, so maybe there was differences in lighting or the camera technology that was used. However, the gap persists if you only fine-tune on Fitzpatrick 1 and 2. It's only when we tune on the diverse data that we're able to close the algorithmic gap that exists. And so once again, this is kind of my plea to everyone to, when you are assessing these algorithms, ask about the diversity of the data, bring up points about this, particularly if you're asked to review papers or you're asked to work with technology companies who are working in this space. So I hope by the end of this talk you see that these headlines are actually not where we're at. We are not anywhere near any algorithms replacing the functions that we perform. However, I do have the hope that we can try to leverage this technology in the future to improve some of our workflows. And I want to leave you sort of on a hopeful message of thinking about what we can do to address some of the issues that I have discussed today. Like it or not, AI algorithms are becoming part of medicine. In the United States, the FDA has approved many non-dermatological algorithms for use. There are not yet any dermatology algorithms approved. However, there are many dermatology AI devices, including the one by Google, who have received CE mark. If developed properly, such algorithms, and tested properly, such algorithms could help augment workflows. But it's very important for us to be vigilant about the biases in the AI algorithms, both in the data sets and the tasks that are being performed. And it's really important for us to emphasize and be advocates for our patients and for our field to have the development of fair and equitable algorithms with rigorous evaluation and testing across diverse data. And so, of course, science does not happen in a vacuum, and so I would like to thank my many, many collaborators. The list is actually much longer than this, but these are some of the people who were involved in some of the work that I presented today. Thank you very much.
Roxana, thank you very much. Does anybody have any questions? If you do, please come up to the mic. Roxana, I'm very interested. Where do you think this is going to go?
So I'm giving a talk tomorrow that's a little bit more hopeful, talking about the ways that we can leverage AI to make things better. So one thing that we have done is actually leverage algorithms to help our patients take better telemedicine photos. And as I showed in that prospective study, that, you know, there's 3 billion people across the globe who have inadequate access to dermatological care. As we know, that our primary care colleagues play a role in helping refer patients to us who need dermatological services and don't necessarily have that training, and so building algorithms that could help identify who might need to be seen sooner, sort of triage workflows, but always a human in the loop who can help sort of override any decision making that seems incorrect.
Thank you. One more question over here, yeah?
Hi there. Thank you very much for your talk. Dimitris Karbonis from Oxford. I was wondering about the study that you presented about Han et al. In 2022, that recent study, whether the dermatologists, their accuracy was not improved versus the non-dermatology trainees. I was wondering if any of that result was observed because the dermatologists were less open to accepting the AI diagnosis and were more confident in their diagnosis.
So I believe that they had some analysis of looking at that. Now, there is data that shows the more experience you have as a clinician, the less likely you are to accept that information. And so they actually worked with trainees here. So in some sense, they were probably more likely to accept. I would say to look back in the original paper, because I do think they may have looked into some of that, but there are also some fascinating work in AI human decision making, and that's actually some research that we've done ourselves and found that actually dermatologists do not always reject the information, but again, experience can influence how likely you are to reject that information, and whether that information agrees with what you are thinking to begin with can also influence whether you change your differential. You might move something up higher because you thought about it, but then the machine is also thinking about it too.
Roxana, thank you so much for coming and giving that really interesting talk. How do you think we can move forward in guiding our patients and our colleagues with regard to the limitations of these data sets? Because, I mean, we've been working hard at the BAD with Roberta, as you know,
Yes.
to try and inform people, but what can we do?
So I think that you guys have done a fantastic job at trying to engage regulatory bodies, which I would say to continue to do. I would also say that engage technology companies. Many of these companies don't properly engage with dermatologists before they make announcements of releasing algorithms directly to consumers. And so I think that's an opportunity. The other thing is counseling, patients with, you may have heard about some of these apps which claim that they can diagnose your melanoma. These are the reasons why I don't think that these apps are adequate for use without you seeing your physician. And I tell them essentially, I said, many of these algorithms are actually sensitive to small changes like changes in lighting. They're not trained across diverse skin tones. And so I just, I urge them that if they have a concern about their skin, that they talk to their physician and not rely on the app. But I actually think that there's an opportunity here on social media, in the news media, for us to do messaging, because sensationalist headlines always, catch people's attention. So I've actually had patients who truly believe that algorithms work as well as dermatologists because that's what they've read. But it's, our sort of duty as dermatologists to do that public messaging as well in the media to let people know, like, these are actually some of the existing issues, and that's why, those headlines are not correct.
Dr. Donescu, thank you very much for a brilliant talk. We have a medal for you and a certificate as an emblem of our appreciation for coming across from the US. Very, very grateful to you.
Thank you so much for having me.
Okay, last but not least is Sally Ibbotson, who is Professor of Photobiology over at Dundee, so not so far from here. Sally and I go back a long way, many years ago, even though we're only 33, I think we are, aren't we? 33 years old. Back in the Cambridge Biology of the Skin course, I met Sally back then, and since then she's had an absolutely meteoric career and really pushed the boundaries of photobiology. And it is a real pleasure to have Sally here with us today. Thank you.
Well, thank you so much, Tony and Pui, for inviting me today and to the BAD. And it's a real pleasure to be back here talking to colleagues and friends, and just so lovely to be here in person, so thank you. And I'm going to talk about photosensitivity and photodiagnosis, and in particular I'm going to focus on photodiagnostic services that are available to us all as dermatologists in the UK at present. And I think stripping this right back to the basics, you know, when is photosensitivity abnormal? So we all have photosensitivity, but when does it become abnormal? So when does it go either, you know, in terms of exaggerated degree of photosensitivity, or when we have an abnormal morphological reaction to UV exposure? So that's the question for us as photodermatologists. And another point I'd like to make out is that the vast majority of patients with photosensitivity never get as far as photodiagnostics. Most will probably not even get as far as a general dermatology clinic. PLE is 1 in 5 of the population here have PLE. And actually, the vast majority of PLE does not need to be sent through for photodiagnosis. It's a general dermatology clinic diagnosis that is readily made. As with this guy who's a truck driver who had his rash provoked very readily by UVA through his truck window. However, photodiagnostics really comes into play in certain situations. So I would argue that these two young women would both have virtually identical clinical presentations. And our unit in Dundee has been present for 50 years, and we still, on a regular basis, get our diagnosis wrong. Are they light sensitive or not? Is the testing going to be abnormal or not? It is impossible on clinical assessment to know. In reality, this young girl on the left had very abnormal phototesting and a diagnosis of young onset chronic actinic dermatitis. The girl on the right had just photoaggravation of atopic dermatitis and normal phototesting. And it's key for these patients in terms of management, because the girl on the right can be readily treated with phototherapy. It would be a disaster to treat the girl on the left with phototherapy. So this is where phototesting really is essential. The other important aspect I'd like to convey, and we've heard a lot about psychodermatology at this meeting, is that actually photosensitivity has a massive impact on many people's lives. It's not readily captured by measures such as DLQI or HAD scores, and actually it has very specific impacts in terms of some of the aspects of life it affects. And I'm going to talk about this a bit later when we come to our patient engagement work. So tertiary photodiagnostic services really began in the 1970s and 80s by pioneering work, much of which was done through London, Dundee, and Newcastle. And actually, back then, in the early days, David Bilsland, through a BPG workshop, looked at a review of photodiagnostic services, which came about really to meet the needs of diagnosing and accurately characterizing patients with